I'm Mark Clement, and I'll be doing the review. And Linda Cave is out at the table. She has a lot. She can answer any questions about logistics, about the course. So she's best to ask on that. Usually, if you have a question, I'll just refer you to her. So just go to her first. She'll be here today and probably tomorrow and probably Sunday, but I'm not exactly certain on Sunday. She may or may not be here. You should have in your possession a blue and yellow book. If you don't and you didn't register, you need to go out and register now and get that done. I'd like to thank Shannon and Derek for all their work getting this organized. It's what you do. It's a lot of work. I appreciate it.
Thanks, guys.
A lot of work. And amazingly, in just like 2 weeks' time. I know professional event planners that can't pull off anything unless they have 6 months. So you guys ought to go into event planning if you don't pass your boards. Career number 3. Yeah. The lights, we still don't know anything about the lights, are they?
No, I tried getting them back on. They're not functioning.
We have some functioning with the lights. Are they even trying, or did they just say?
Anytime that they come on, they immediately go back off.
So they're not going to try to fix them?
Not this weekend, no.
So we're going to be...
Yeah.
Yeah, now is that sunlight? Or is that ambient light? Lighting behind?
Sun in Ohio?
That's true, that's true. Because I was going to say, if that's sunlight, when it goes down, it's going to get a little dark. But hopefully it's just backlighting. Do you think that's what it is?
Yeah.
Okay, good. Well, that'll give us some lighting. My eyes actually are, when I first came in here, they seemed pretty dark in here, but it actually seems a lot lighter. I guess I'm accommodating. So you'll have to take notes in this light. I apologize for that, but that's just the way things happen sometimes. I think there's a little more light over here. If you're having a hard time, that might be a good place to sit. Can you see me? Okay, can you hear me? Of course, if you didn't, you wouldn't answer anyhow. So I guess that's a stupid question to ask if you hear me or not. But I don't usually use microphones because I don't usually need a microphone. But if it becomes a problem with you having to really attend to hear me, let me know, and I can use a microphone. But I don't like to use it, and I don't usually have to. And I've lectured in auditoriums this size and bigger without microphones, and my voice usually lasts, so it should work. Logistics, there are men and women's restrooms right out to the left. For those of you that aren't from Mount Carmel, well, no, anybody can use them, but I'm telling those of you that aren't from Mount Carmel where the restrooms are. There aren't separate restrooms for Mount Carmel people. But to watch what I say, people take me literally. Also, there's chips and salsa out there, I guess. And then tomorrow, Shannon's arranged for pizza to be brought in for lunchtime. And so you can plan on that. And if you wanted to bring some extra little things to throw on the table, that'd be fine too. Is that correct?
Correct.
Let's see. Shannon, anything else I needed to tell them from your information?
No, we are planning on a potluck, so if you do want to, if anybody's great bakers and like to make cookies, go ahead and bring some that kind of thing, and tomorrow would be wonderful.
All right.
The pizza, of course, is free. It's donated from.
Yeah. All right. Let's see, what else? Is there any good wing place around? Here in Columbia? Maybe Sunday I could spring for wings. Of course, they're awful goopy. But we'll see, we'll see. Let me know if there's something really good around here, you know what I mean? Okay, I don't know Columbus that well. All right, just real quick introduction, and then we'll get into it, because you're not here to learn about me. You're here to learn about the NCLEX RN. So just so you know a little bit about me, some of you, most of you have never met me. Some of you have taken my class before and are here for a refresher. So that's cool. You also can do that if you, let's say that some of you I know are from Wright State and some other places, and you may not graduate till June-ish. Somebody not graduate till June? Whatever. If you keep your receipts, you can come to any other review I have at no cost. Just show your receipt, and you can come. You know what I'm saying? So you can keep refreshing, you know, that kind of thing. So, all right. I am a registered nurse. I have been a nurse since 1973. So that means I've been a nurse for
36 years.
36 years.
That's how old I am.
36
I was born in
years.
73.
So you're born the year I graduated. Okay. How many weren't born when I graduated from nursing school? Okay. So I've been a nurse for 36 years. So it's been good to me. It's been a great profession. I will have to admit that in 1973 in Youngstown, Ohio, that was the steel mill closings. We were in a really big recession up there, and it took me 3.5 months to find my first job as a nurse. But ever since then, I've had a minimum of 2 jobs going on at the same time. I've never been unemployed, never lost a job, always had at least 2 jobs going on. So it's a great, even in an economic downtime like is now, your first job might be a little hard to find, but after that, it works pretty well. So it's been good to me, good to my family. I love it. I like to teach it. So hopefully you'll enjoy it. I try to stay current as well, you know, in practice, work in nursing as well as teach in nursing. The last 2 years I haven't been able to work in nursing because these reviews have just taken over my life. Every weekend I'm somewhere, which is, I'm not complaining, that's great. It's just, I'm gonna have to start saying no to some things eventually. Let's see, I'm basically educated as a med-surg nurse, but I also teach psych, and I've worked in psych, so I know psych. I also do pharm, and I have graduate education in testing and measurement and cross-cultural nursing, transcultural nursing. Anybody ever hear of Madeline Leininger? It's the Wright State people should have heard of Leininger. Did you hear of her? She was my advisor. So I'm an expert in cross-cultural and stuff like that. Let's see. I've worked a lot of ICU, a lot of ER, step-down units. I usually have the idea that if something scares me, I go at it. So I was scared of neuro, so I first started working in neuro. Then I was afraid of being able to read EKGs and rhythm strips, so I went into coronary care and learned that. And everything, you can learn anything, just don't avoid. Don't ever think you can't learn something or that something's too hard for you. Just go at it and you'll find that it's not a big deal. See what else? I have a wife and 4 daughters. Yeah. I better shut my cell phone off. It's Friday. They're teenagers. They're going to be wanting money. I better shut off the phone. There. That was it. Now I want it. But they always, 4 daughters, they're 22, 21, 20, and 12. So we're just getting out of those teenage years. But they still do. My 20-year-old, I got a phone call an hour ago from my insurance company. It said, we have a claim by the state of New York from your daughter who spun out and hit a mile marker. And the state of New York has filed a claim on your insurance company to replace the mile marker. $1,200 to replace a mile marker. Jeez. Give me a break. That's not the half of it, though. You imagine what a 20-year-old's insurance is going to go up to. But anyhow, okay, I know you care. Let's see what else. That's basically it. I've taught at Cedarville University for 27 years. Taught at nursing there. This is my 27th year. And I stick with, I'm a stick in the mud. I stick with one town, one job, one wife. You know, I'm just sort of a stick in the mud. I don't like change. You know. If I could have gotten rid of the kids, I would have, but I stuck with them too forever. No, I'm just kidding. But that's where I'm at. Okay? So we'll go around the room. You got to tell them your name and something that nobody else knows about you. No, we're not going to do that. Everybody's going, oh,
Oh,
okay.
thank goodness.
Don't shape places that do that, go around the room, introduce yourself, tell something. We're not doing that, okay? Forget it. Okay, what the goal is here, while we're together, I have three objectives. First, I want you to acquire some knowledge. I want you to learn something. I want you to go out that door and go, boy, I learned something today. Because I don't assume that everybody knows everything. And it doesn't hurt to learn some new information every once in a while. And I know enough about nursing to know that every graduate doesn't know everything they could know for this boards. There's some information that you need to know for boards that you do not know. Now, it's different for everybody. Not everybody has that same deficit. You have one that someone else doesn't have, and vice versa. But I want you to acquire some knowledge. Some reviews, you don't learn anything. All they do is they just do multiple choice questions. And you're learning how to apply it. Well, that assumes you know it. And you can't apply what you don't know. So a lot of good it does to sit there and try to apply something if you don't know what they're talking about in the first place. To me, that's a waste of time. And I've worked in nursing long enough education to know that students don't know everything that they probably should know. They've forgotten some stuff. So we're going to try to spiff up your knowledge, and I want you to acquire some knowledge. Secondly, I want you to gain confidence. I want you to, when you walk out of here, go, I can do this. This is something that I can do. Because I think one of the biggest fears that people have is that they're going to fail because somehow, some way, they're the one person in the universe that this is just beyond their capabilities. Do you know what I mean? Now, everybody else will be able to do it, but they will not. For some inexplicable reason, it's beyond their capabilities. And I got through school, and I got through that, but when I go to the boards, it's just going to get me. Those standardized tests are just going to get me. And you don't want to go there, okay? So I want you to have confidence that you've done everything that you humanly possibly could have done when you sit down to take that boards. Because the worst case scenario is you go to boards, and some of your friends, some of your classmates don't do any reviewing for boards. They just go take it. Well, that's okay, but can you imagine yourself, you sit down for boards, and you sign your name in, and you click go, and it brings up the first question, and suddenly you realize you haven't done anything to prepare for this? Could you imagine how you would feel if you had not done a thing to prepare? Your friends that aren't taking review classes might be confident now. I'd like to talk to them when that first question pops up and say, hey, would you think you might want to do something? But then it's too late. So when you sit down to click and start taking that test, I want you to realize that you've done everything you possibly could have done. And you did what is above and beyond reasonability. And you can have that confidence that you've done your part. Secondly, I want you to become exam proficient, meaning I want you to know how to take tests. Because earlier I just said you can't apply what you don't know, but you have to be able to apply what you do know. So it takes three things to pass boards: knowledge, confidence, and skill in taking exams. So this review is designed to address all three of those points. Have you acquire some knowledge, gain some confidence, and gain some exam proficiency. When you walk out of here on Sunday, I want you to think, I know how to do those select all that applies. I know how to do those click and drags. I know how to do prioritization questions, delegation questions, staff management questions, best questions, first questions, all those kinds of different formats. I want you to be able to do point and click and all of those. So we'll be talking about that. I really believe that any review, there are two types of reviews out there, and if you've had reviews, you know this, is some reviews just sit there and they give you a book that's an outline, and what do? They read it to you. I don't know about you guys, but I haven't enjoyed being read to since I was 7. So I would just immediately go to sleep. And after the first break, I'd probably just leave, figuring I can read it at home. I don't need somebody to read to me. And then the other kind of review is, like I said before, they have just this whole bank of multiple choice questions. And all they do is they flash it up on the screen, and they say, okay, You got, 30 seconds to do this question. So everybody sits there, and they say, okay, we're done. And of course, Susie, anal retentive over here, says, it's B. And then all of a sudden now you guys, your thought process is contaminated because she shouted out the answer, and now do you know what I'm saying? And it messes up the whole process, and then you're supposed to learn from that, and then this person starts arguing with the teacher that they didn't think that was the right answer, and then it takes up 20 minutes arguing about some stupid question, and you're going, oh, let me out of here, this is just ridiculous. What's that?
That's our class.
Okay, so it just, to me, that doesn't, neither one of those models works. Because two things, you can't apply what you don't know, but you have to be able to apply what you do know. And if all they give you is a lecture, you don't get a chance to apply it. And if all they do is apply it, you don't get a chance to learn it. So I think the uniqueness about my review, if there is uniqueness, and I believe there is that it hits both of those. I hit a balance between applying and learning, applying and learning. So that's sort of where we're headed, what we're doing. Now with the group this size, we should be able to learn a lot. I sometimes have groups of 160, 170 people, so it's kind of hard to keep that all. But sometimes I have groups of 20, so it just depends. So this is about a small average size group, which is great. I like this size. That way I can keep in contact with you. Now I can't really see your eyes very well. Now I always like to make some eye contact every so often. But please ask questions. This is your chance to get things clarified. So ask me questions. There's probably not a question you could ask me I haven't heard yet. Because after a while, there's only so many questions people can ask. So please ask. If I don't know the answer, I'll tell you where to get it. Let's see. Anything else I need to say? We'll take breaks, 10-minute breaks, 10-minute breaks. Now here's the deal. I always schedule more time for these reviews than I have. No. I always schedule more time than I need for these reviews. So here's the deal. If 10-minute breaks are 10-minute breaks, we get out, we'll end up with extra time. Not because we didn't cover everything, but because the worst thing in a review is not to cover everything. So I always put an hour or two extra time on every day. If lunch becomes, instead of 45 minutes or an hour, whatever we decide, it becomes 20 minutes longer than that, then we don't get, so what am I saying? If you get back in your seat and we get started on time, we get out early. Probably. Just so I'm saying, most likely. So you do have control of some of our finish time, our quitting time. I am assuming, and this is an assumption, that's dangerous. What did you guys assume about a meal this evening, like 3:30 to 9:30? Did you plan a meal? Who planned a meal in there? Who figured we'd just go straight? So how many figured there was a meal? Like 3 or 4 of you? Usually on the first day we don't do a meal. We just go 10-minute breaks. Now, isn't there a Wendy's over there or something? Yeah. And they can zip over there and grab something and probably eat in here, although you're probably not allowed to have food in here. They're not going to crab about it, I don't think. Will they crab about it? They won't say anything, so you can do that. Just don't squirt ketchup on your neighbor's book. That's all I would have. Okay, none of that. Okay. But tomorrow we'll have a lunch, and Sunday we'll have a lunch. And lunch, depends on, sometimes it's a half hour, sometimes it's an hour. It just depends on where we are and accessibility of food. Those of you guys that are from this area, Mount Carmel and whatnot, what would you say is a reasonably prudent amount of time for a group this size to get lunch and to be reasonable to expect them to be back?
30 to 40.
Hours.
What's that?
It's like 45 minutes.
We'll start with 45 minutes tomorrow, and we'll see how it works. Alrighty?
Hazel will be here at noon tomorrow.
Okay, I'll plan for that. All right, and then what we'll do is, if everybody's sitting around doing nothing, well, we'll start early. And that'll mean we'll get out 15 minutes earlier than we would have otherwise. Question back here.
Oh yeah, when's the next time you're offering a review?
The next scheduled one, I'm in negotiation with about 8 places.
Oh, okay. So it's
Okay,
not-
the next scheduled one is in Florence, Kentucky, south of Cincinnati, about 5 to 10 minutes south of the airport, or 5 minutes across the street from Turfway Park. If you've ever been down to play the horses down in Cincinnati. But it's on March 26, 27, 28. Supposedly, I'm in negotiation with Ohio State for a review the week before that. And then I'm in negotiation with Central Ohio Technical College, possibly, for a review sometime mid-March. And then Chamberlain wants me to come do a review first week of March. But none of those are all Columbus areas. I also might put in a Dayton review second or third week of March. It just depends on how those all come together. So I can't, the website's the best way to look at. Has everybody been to the website? And that way, as soon as we know something's set, we'll put it on there. So that's all I can tell you.
Good.
I don't know otherwise. Then there'll be a lot in May. A lot in May. Any other questions? Okay, the way this works is basically we play fill in the blank. You have your yellow book, and that's what we're going to do together. The blue book is because people for years and years said to me, what do I do now? What do I do now? The review's over. What do I do now? What do I do now that it's done? What do I do between now and when I take my boards? And I got tired of telling people individually what to do, so I made this blue book. I want you to do the blue book. Doing the blue book is part and parcel of the review. If you haven't done the review book, you have not done Mark Klimek's review. You've only done half of it. Because that blue book is a drill book to teach you facts. Facts, facts, facts. When people don't pass boards, I usually sit down with them when they come to me, and I'll sit down with them and see if they know what they're talking. And we'll sit down and start doing some questions. We probably aren't 10 questions into that, and I've already taken them to the blue book like 3 or 4 times. Because they'll read something and they go, well, I don't know what that is. Let's get out the blue book. Okay, there it is, page 52. What's it say? Oh, okay, well then it's A. Yeah, it's A. Do you see what I'm saying? So get that blue book out. The first question somebody, on occasion people will take this course, not commonly, but on occasion, people will take this course and not be successful on their boards. That happens. It happens to every review. There's no perfect review. If there were a perfect review, every other review would be out of business. Do you see what I'm saying? The other thing is that so what I do is if you would not be successful on your boards and you would want to talk to me about what to do about it, do you know what the first question I would ask you would be? Do you know your blue book? Do you have your blue book up here? Okay, then we'll talk. But you got to know your blue book first. Then we'll talk. So it's very important. I can't stress that enough. Alrighty. All right. I think I've covered a variety of issues. I can cover some things as we go if I've missed anything. I think most of the logistics are here. I usually lecture for about an hour and a half before I give a break. Is that okay? Your nurses, you should have developed a bionic bladder by now. Yes.
I guess I was just wondering, I assume you are up to date with everything?
Yes.
Because
Now-
they say they change the tests every...
5 years. Every 5 years it changes in content. Every 5 years in content. Every 3 years they review past standards and percentages. There are going to be a few changes as of April 1 of this, what's that, 6 weeks from today? April 1 there will be a few changes. But, what's that?
Is that good or bad for them?
It could be very good for you. It could be very good for you. Because the last time, 3 years ago, see, every 5 years they change content, and they only change 5% every 5 years. So if they change the content, it's only going to be 5% of the content, not the whole content. Do you know what I'm saying? Everybody thinks that they change everything every 5 years. Well, that's people that don't know what they're talking about telling you that. They change 5% every 5 years. Okay? So in April 1, they will change 5% of the content. All right, they will drop some issues, include some issues. My book is designed to get you up until April 1. And then I have some changes in the book already for after April 1 as well. But I'm focusing on the 95% and not the 5. Okay. The other thing is they reevaluate the pass standard every 3 years. And they're going to evaluate that April 1 as well. And that could be very good for you because the last time they did it, they made it higher. Now there's some talk that they'll make it higher this time, but people who really know are saying that they might bring it down because they were having too high a fail rates from schools all over the place. Do you know what I'm saying? It used to be Case Western Reserve never had anybody ever fail. People from there are failing. Christ Hospital has huge, high pass rates. They were having bad times. Do you see what I'm saying? Lots of schools that had traditionally done really, really well. Sinclair Community College in Dayton stayed up pretty well. But a lot were coming down because they had upped that standard. So there's a chance they might lower the standard on April 1. But don't delay taking it until after April 1 because you're thinking they might lower the standard because they may increase it. So we won't know that until they meet. But there's because the failure rates went up since they changed it 3 years ago, there's pressure to bring the standard down. Does that make sense? All right, let's talk about acid-base balance in ventilators. The first lecture. In the first page, you'll notice a table of contents and some page numbers, and then a blank out to the left. What that is that's for you obsessive compulsives to check off the lectures as we go, because you have to have some way of knowing that you're accomplishing something, and if you aren't checking it off a checklist, you're not getting anything done. So that's for you guys. All right, the rest of us, we won't care. The other thing about that too that's helpful is, let's say that tomorrow you are late and you miss 2 hours of lecturing. Well, if you're keeping your checklist, you'll know what you've missed, and you'll be able to talk to me about it, and I'll tell you how to get that and how we would arrange for you to get that material you missed. But if you come up to me and say, I missed yesterday morning, what'd I miss? I'm going to go, I don't remember. I'm just a talking head, basically. So you keep track of where you're at. Okay, acid base. And the other thing about this review is we're going to go alphabetical, which is kind of odd. Because most reviews go by specialty. They'll do all of pharmacology in one day. And then they'll do all med and surg in one day. Then all peds in another day. Then all psych all at once. And I don't know about you guys, but if I had a 5-hour review on pharmacology, I would be more confused at the end than I was at the beginning. Because you just can't dump it like that. So I like to vary it up. And you've had all this stuff before. So I don't have to teach it in a coherent whole. I can bounce around. And I also want you to get used to bouncing around. Why? Because what does it do on the test? It bounces around. So I want you to get used to talking about med-surg, then jumping to some psych, then back to some peds, and then some OB, and then bouncing around so that your mind understands the principles rather than the specialty. You got it? Okay, and all you have to do to pass this test is do a little less than average. How many of you in here is it possible that you could achieve a little less than average on a test? See, so you don't have to do how well on this test. Do you have to do well on this test? No. Do you have to do average on this test? No. You need to do a little less than average on this test to pass. So don't think that you've got some insurmountable standard that you have to hit. And then you say, well, then why do people fail? Because they think they have to be up here. You see what I'm saying? And they study that way, and they get anxious that way, and it just doesn't work. Okay, acid base is something you do have to know about. If you do not know acid base, you are in trouble because everybody else knows about acid base. Okay? So one thing you have to do in acid base is if they give you an arterial blood gas value report, you have to interpret it as metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. So if they give you lab values, you have to convert it to words. Now, if you know how to do that, you're 100% accurate, go for it. Don't listen to me. I don't want to fix what isn't broken. But if you're confused about that, you're nervous about it, you're anxious about it, I've got something here that might help you. Okay? All right, interpreting blood gases. The first thing I suggest you memorize is the rule of the bees. Do you see it there? The rule of the bees. And what I want you to do is fill in here. It says, if the pH. That fills your first blank in. And as I say, there's only 3,000 to go. Okay, so if the pH and the bicarb, the pH and the bicarb are both in the same direction, then it's metabolic. So the B's are bicarb both bolic. Do you see those? Bicarb both bolic? The reason why this works is respiratory does not have a letter B in it. Bicarb has the B in it. So what I'm saying is this. They will give you an arterial blood gas with 8 values in it. How many do you look at? They'll give you 8 values. How many do you look at? 2. Which 2? pH and the bicarb. That's what the rule says. Just look at the pH, look at the bicarb. Then look to see what direction they're going. If they're both in the same direction, be it up or down, it doesn't really matter. As long as they're both in the same direction, who cares what direction? Then you must use what adjective? Metabolic, because the rule says if the pH and the bicarb are both in the same direction, it's metabolic. Well, what if they're in different directions? Then you only have one other choice, and that's respiratory. Now, what do you get the acidosis and alkalosis from? The pH. Exactly. So let's look at how this rule would work. Well, first we have to know the normals. What's the normal pH? 7.35, 7.45. That is a piece of universal nursing knowledge. Everyone knows that. If you do not know that, you're the only nurse in the universe that doesn't know it. No, I'm serious. Okay, the normal bicarb is 22 to 26. Not every nurse knows that, so learn that. 22, 26. I call them the bicarb years, when you're 22 to 26-year-olds and you have to make all those decisions. What job do I take? Who's my buddy? Am I gonna get married? Am I not gonna get married? Am I gonna move in, not move in? You know, all those decisions you gotta make when you're 22 to 26. That gives you heartburn. So you need the bicarb. I call it the bicarb years because you're always in a knot over decisions. It's nice to be 56. No choices. No other women want you. No jobs want you. So it's nice. You only got one option. Makes it nice. Question.
Our teacher told us to remember that 2 plus 2 plus 2 equals 6.
That's true, but what does that mean? Oh,
It's
okay.
just a
2
way
plus
to-
2 plus 2. Oh, 22 to 26. 2, 2, 2, 6. Oh, that's cool. I
That's
like
an
that.
easy way.
That's good.
A lot of 2, so
Lots of 2s.
bicarb.
So 2, 2, 2, 2, 6. Okay. Now, let's look at those, and let's look at our examples. In the first example, the pH is in what direction?
Down.
Down, so draw a little arrow down in the box next to it. Then the rule says to look at what? The bicarb, and the bicarb in this case is in what direction?
Down.
Down, so draw a little arrow down. Are those arrows going in the same direction?
Yes.
So what adjective must you use?
Metabolic.
Metabolic, and because the pH is down, it is. So that is an example of metabolic acidosis. Okay, look at letter B. Bicarb is the pH is in what direction? Up. Bicarb, up. Are they both in the same direction?
Yeah.
Yes. So what adjective must you use? Metabolic. So this is metabolic alkalosis. Is everybody with me? Okay, the next one, pH is down, bicarb is up. Are they both in the same direction? No. So what adjective can you not use? Metabolic. So you have to use Respiratory, so this would be respiratory acidosis. Now, the only time this doesn't work is when there's a mixed acid-base disorder and boards doesn't go there, because that's way too hard. All right? So if the pH, does everybody see how the rule works? What if I gave you a pH of 7.50 and a bicarb of 25? 750 and 25. What would it be?
Respiratory alkalosis.
Respiratory alkalosis. Why?
Because the
pH is in what direction?
is low.
Well, 750 would be
yes,
up.
it's up.
And the bicarb is
Down.
normal. 25. It's normal.
I thought you said 30.
25. So is that the same direction? Up and normal?
No.
So it's got to be respiratory. So even if the bicarb is normal, it still works. You see what I'm saying? Alrighty, that's the ABG interpretation. Let's talk about signs and symptoms, letter B. They will tell you a patient has respiratory acidosis, metabolic alkalosis, something like that, and they'll say, what would you see? Select all that apply. And you get a whole laundry list of stuff, and you have to select, check, check, check what's true. Well, two things here. One thing here, I hate lists. One thing you're going to see in my review is I do not have you memorizing lists of things. I hate lists, I despise lists, I refuse to remember lists. The reason why I hated lists in school was for two reasons. First reason I hated lists is, for example, if I learned 15 signs and symptoms of hyperkalemia, and then 15 signs and symptoms of hypokalemia, when I took the test, guess what would happen?
Forget them all.
I'd memorize, I would remember the lists, word for word. I could reproduce the list, but I would forget which one was which. Do you see what I'm saying? And when that happens, you're dead. All that work went for nothing. The second reason why I hated lists was, even if I could remember which was which and all 15 signs, my teachers had the tendency to pick signs numbers 16, 17, 18, and 19, and not the 15 that I memorized. And one thing that you guys learned real early in nursing is every book says something different, right? Take two nursing books, same thing, look at the lists. The lists aren't the same, right? Have you ever found two lists that were the same for anything in nursing? Never. So you can memorize a whole bunch of lists, but for that to be productive on boards, it better be what? The list that boards is using, right? And what chances is that? Very slim. So the point is this, boards does not test your knowledge of lists. It does not. What boards test is your knowledge of principles, not lists. But how will they test your knowledge of principles? By having you generate lists. Do you understand what I'm saying? Boards will not test your knowledge of what? Lists. They test your knowledge of,
Principles.
but they will test your knowledge of principles by having you generate lists. And so when people take boards, they say, oh, you got to memorize a whole bunch of lists. No, you don't. They don't know what's going on. For example, in general, what do pain meds do? In general, what do opioid pain medications do in principle to a person? What do? They sedate you, don't they? They're CNS depressants. Okay, now, they will ask a question like, your patient is on Dilaudid, an opioid analgesic. What of the following things would you expect to see if they got too much or that they were getting a little too much? Select all that apply. Alrighty? And you're thinking, oh my goodness, I don't remember the list of Dilaudid signs. It's not a list of Dilaudid signs. It's to see if you know that opioid analgesics are CNS depressants, sedatives. So when you go to the list, what do you select? Agitation or lethargy? Lethargy. Flaccidity or spasticity? Reflexes of +1 or +4? +1. Hyperreflexia, hyporeflexia? Hyporeflexia. Restlessness or obtunded? Well, you go, I know what restless is. That's up, so obtunded must be down. That's a good test taker right there, okay? And you say obtunded. Okay, a good test taker never says, what? They say, and then they figure it out the other way. The thing about you guys that aren't good test takers, you haven't figured out that those good test takers, they don't know anything. They don't know anything more than you know. In fact, they probably know less than you know. They just don't quit. They just figure, oh, I'll get it. If they won't let me in the front door, I'll go in the back door. And if the back door's closed, I'll go through the cellar window. And they'll figure a way to get at it. They just don't quit. Poor test takers go, oh, I don't know what that is. No, don't do that. I had a student that was a really bad test taker. He came to a maternity question, and it said, what's the best way to treat morning sickness in a first trimester woman? And he said, oh, this is the only OB question I know the answer to. It's crackers. And he was so excited that he got the one OB thing he didn't know. So it's crackers, crackers. You look, A didn't say crackers, B didn't say crackers, C didn't say crackers, and D didn't say crackers. And what did he say? As a bad test taker, what did he say? Oh my goodness. I thought I what? Knew this. I guess I don't know this. So he picked something like antacids every half hour. Okay? And then he wonders why he doesn't do very well. Well, you know what number C said? You know what answer number C said? Dry carbohydrates. Well, what is a dry carbohydrate?
Cracker.
A cracker. But what did he do? Oh! You know, he was expecting the front door, cracker. No, you go the back door. Dry carbohydrate. Do you see what I'm saying? Don't give up. Don't think that you don't know this. You know it. Okay, so if they say restless versus obtunded, you know what restless is. Obtunded must be the other. Okay, but do you see what I'm saying about the sedation? And you generate the list by applying the what? Principle, not having memorized some list. Does that make sense? Do you see why why can't boards test lists? Why can a national nursing test not test lists? Because what? All the lists are different in different textbooks used in different geographical areas of the nation. To write a statistically significant, reliable, valid question, you have to write the question so that no matter who takes it, no matter what book they read, no matter what school they went to, it's a fair question. And if you're just taking out a Mosby's book on whatever, the signs and symptoms of whatever, and you write a question on that, it will perform horribly statistically nationally. The only way you can do these select all that applies and have them perform well is to test what? Principles, and see if a student can generate a list from a principle. Now, does that change the way you might look at a select all that apply question? You understand what they're about? There is no mystery. You weren't supposed to have memorized some mystery list that you didn't know. You're supposed to say, this is a chance for me to show I know a principle. You got that? That's how you do those. Okay. So, I want to give you a principle for answering acid-base signs and symptoms. And it's what's in the box there. It says, as the. Do you see where I'm at? As the pH goes, so goes my patient. As the pH goes, so goes my patient. What? What does that mean? As the pH goes. pH can go up, or the pH can go down. And when the pH goes up, your patient goes up. And when the pH goes down, your patient goes down. Does that mean they sink and levitate? No. What does it mean? What's it mean? Talk to me.
Not very exciting.
Yeah, so when the pH goes up, every system in your body gets more irritable. But when your pH goes down, systems in your body shut down. So when your pH goes down, you shut down. When your pH goes up, everything gets hyper-excitable. It's pure chemistry. It's talking about catalyzing chemical reactions, basically. So, do you see where it says up? Oh, except for potassium. I'm sorry, I didn't write that in there. Except for potassium. So what does that mean?
pH goes up, potassium goes down.
And when pH goes down, potassium goes up. Because if it followed the rule, we wouldn't even mention it, right? So So as the pH goes, so goes my patient, except for potassium. So if your patient goes up, do you see the little box there that says up? What is that? What's another name for that? Up pH? Alkalosis. What will you see with alkalosis? Give me some stuff. Give me some signs you'd see with alkalosis.
Vomiting.
Irritability, absolutely.
Hyperreflexia.
Hyperreflexia. What would be some numbers that would be hyperreflexic? What numbers? 3 and 4. 3 and 4 are hyper, 2 is normal, 1 and 0 are hypo. Remember that with reflexes? 3 and 4 are high, hyper, 2 is normal, reflex, and 1 to 0 is hypo reflex. What else would you see with alkalosis? You got 2 of them.
Irritable.
We got irritable, we got hyperreflexia. What else do you think? Think of a body system and then go a high. Tachypnea. What else? Tachycardia. Would you have paralytic ileus or borborygmi? Good. You good test takers said borborygmi, even though you may not know what it is, because paralytic ileus sounds like everything's what? Shutting down. That would be the down. The up would be borborygmi. Now, Boards loves the word borborygmi. B-O-R-B-O-R-Y-G-M-I. Borborygmi. That is the word they will use for increased vowel sounds. So if you hear somebody's stomach growling this evening, what will you say? How borborygmus of you. Borborygmi, increased vowel sounds.
Can you spell that one more time?
B-O-R, and do it again, B-O-R-Y-G-M-I. Borborygmi.
Thanks.
So what would be down? Acidosis, and what would you see there? What's that?
Hyperreflexia.
Hyporeflexia. What else?
Bradycardia.
Bradycardia. Lethargy. By the way, obtunded means just one step more lethargic than lethargy. O-B-T-U-N-D-E-D, obtunded. Vocabulary is critically important to pass this test. That's why the blue book and the yellow book are real heavy on vocab. Can't answer a question if you don't know what the words mean. Sounds pretty obvious. So what would you have, paralytic ileus or borborygmi? Paralytic ileus. Would they have a seizure or a coma?
Coma.
Coma. Because seizure's up, coma's down. You got to go the same as the pH. So let me ask you this. What acid-base imbalances are most likely to seize, and which ones are most likely to have a respiratory arrest? Alkalosis will what? Seize, and acidosis will respiratorily arrest. Does that make sense? Because you're doing as the pH goes, so goes your patient. So what acid-base disorders need an ambu bag at the bedside? What acid-base imbalances need an ambu bag at the bedside? Acidosis, because they're going to what? Respiratorily arrest. Which acid-base disorders need suction machines at the bedside? Alkalosis, because they could seize and aspirate. See, don't limit yourself. When they start asking these things, say, wait a minute, I know about this. I can get there. See, I shouldn't have to teach you who needs an ambu bag at the bedside. You should be able to get that from as the pH goes, so goes my patient. Do you see what I'm saying? These rules, use them. They're tools. Okay. Before we turn the page, I want to ask you, I want to introduce you to, whoa, that's bright. Don't look at the light. Is that coming in clear? Or, oh, duh. I want to introduce you to my favorite Scotsman. You know how Scottish surnames have Mac, Dougal, McDonough, MacGyver, MAC, you know. My favorite Scotsman, Mac Kussmaul. How many have heard of Kussmauls? Okay, from now on, I want you to, every time you see Kussmaul, I want you to think what? Mac Kussmaul. In fact, if you're talking to a doctor and he goes, he's Mac Kussmaul, I'll be happy. It'll make you look stupid, but I'll be happy. The reason is Kussmaul's is a compensatory respiratory pattern for one and only one acid-base disorder. You only see Kussmaul's with one of the 4 metabolic disorders, one of the 4 acid-base disorders. Which one? Well, MAC tells you that. M for what? And AC for acidosis. So Mac Kussmaul tells you that you see Kussmaul's with metabolic acidosis. Okay, we have some knowledge, but we have to be able to what? Apply it. Remember, you can't apply what you do not know, but what you know, you have to be able to apply. This says, your patient has respiratory acidosis. Select all that apply. +1 reflexes. Diarrhea. Adynamic ileus. Spasm. Urinary retention. Paroxysmal. Atrial. Tachycardia. 2nd degree. Mobitz. Type 2. Heart block. And hypokalemia. I want you guys to get in groups 2 and 3, right where you're sitting, you don't have to move. I want you to talk to somebody, your buddy, and I want you to answer this question. And I want you to use the rule that I taught you. The rule is what? As the pH goes, so goes my patient, except for potassium. Now I really want you to draw some arrows here. I want you to draw arrows. Okay, and I want you to get the answer. So you can do it yourself, then turn to your buddy, discuss it, and then we'll talk about it. And don't say any answers out loud.
All right.
Get it over now.
So we're choosing which one. It means select all that apply. Okay, so we're choosing what is respiratory acidosis. All right, so knowing that as the pH goes, so does my patient.
Acidosis goes down, so you got
Down stuff. I'm going to
Or is
say
that
diarrhea would be going up, wouldn't you?
Wouldn't be diarrhea.
+1 reflexes.
Tension would be down.
+1 reflexes would be down, so it would be that.
Hypokalemia is down.
Adding dynamic ileus.
That would be high. So that isn't, we wouldn't pick that up.
Hypokalemia. Wait a minute, now that's different though. That's
Dynamic is high.
except for potassium. So if it goes down, that means the potassium's up. So So I guess it would be down, low is down. So it would probably be that.
Okay, I want you to count the number of things you selected. Don't say it yet, but I'll ask you for it later. I want you to count the number you selected.
Get the reflex.
Yeah.
So what was the number for the down one? Plus one? Just a plus one.
Down is 0 to 1.
0 to 1.
0 to 1. So that is when we would check is the reflex.
So 2 was normal.
2's normal.
Okay, how many did you select?
How many did you get?
3.
I got 3.
I know, I don't know. Yeah, 3.
How many did you select?
3.
4. You should have selected 4.
Fourth one. What do we miss?
So let's play our
We
game.
didn't have enough time.
What should you automatically notice about this question? It said what?
4.
Acidosis.
Acidosis, the pH is in what direction?
Down.
And everything's going to go the same direction, which is what direction?
Down.
Except for potassium, which is going to go so a high K. So now there's your answer. Now, up or down?
Down.
Select or no select? Yes. Up or down? Select or no select? No. Adynamic, without movement. Up or down?
Down.
Down. Select or no select? Select. Spasm, up or down? Select or no select? Urinary retention?
Down.
Down. Select. Paroxysmal atrial tachycardia, select or no? No. Mobitz type 2 heart block, yes or no? Yes. Why? Block means the impulse is being what? Slowed, blocked, it's down, it's being hindered. So that's a select. Hypokalemia? No, I want a high K, not a low K. So the answer is the +1 reflex, the adynamic ileus, the urinary retention, and the second degree Mobitz type 2 heart block. How many got that right? Excellent, excellent. Did you memorize a list? No? How long would the list be before you got second degree Mobitz type 2 heart block? Right? Okay. So that's what, and they're testing what principle? What principle are they testing? That in an acidotic environment, chemical reactions cease. So everything shuts down, and that's why you do it, see? You weren't supposed to have memorized these. Do you see what my point is? So this should kind of free you from the fear of these select all that applies. Oh, by the way, what's the number one mistake that people make with select all that apply? Most common mistake made with select all that apply questions.
Not even
Selecting one more than you shoulda selected. Number one problem. Now, those of you who are real concrete people, I did not say answer what you think and take away one. Okay, I didn't say that. I said that the tendency for people is to answer what? One more than they should. So here's the deal. With the select all that apply, if you know it's 2 of them, what do? Select those 2 and what? Stop. Because if you go, well, you know, it could be, okay, now that's a killer on select all that apply. You know, could be, don't go there with select all that apply. That is not cool. Because you're heading down a road that's going to get too wrong. If you do not know that it applies, do not answer select all the. You know what I'm saying? If you don't know that this is true, then don't pick it. Is that making sense? All right. The other thing about select all that apply, it's never only one and it's never all of them. You see what I'm saying? Never answer just one on a select all that apply, and don't answer all of them on a select all that apply, because it's never one and it's never all of them. Okay, let's go to the next page. Causes of acid-base imbalance. Causes. What they'll do is they'll give you a scenario, and they'll say, this is what's happening to your patient. And then they'll say, what acid-base disorder would result from this? Do you see they're flipping it around. Instead of saying, what sign and symptom will the acid-base balance cause, they're asking, what will cause the acid-base imbalance. And one thing that people do wrong when they answer these kinds of questions is they get signs and symptoms and causation messed up. Do you realize that in the human body, oftentimes what causes something is the opposite of what the signs and symptoms of that thing are? Does everybody understand what I'm saying? So a lot of times what will happen is diarrhea will cause a metabolic acidosis. But once you get acidotic, it will shut your bowels down and you will get a paralytic ileus. Do you see? One, diarrhea caused it, paralytic ileus results from it. It's the opposite. And when you're sitting there going, man alive, I learned it was this, and now you're telling me the opposite, probably what are you messing up? Causation versus sign and symptoms. So make sure that you, many times if you go back and you do questions now and you get confused, think, wait a minute, are you talking about sign and symptom or are they talking about causation? Then you can go, oh, I see where the problem is now. Does everybody understand that? Okay, so just keep that straight. Okay, having said that, we're talking about causation now. Whenever you get a scenario, the first big question you ask yourself is it lung? That goes in the first blank. Is it lung? L-U-N-G. Is the scenario a lung scenario? If the scenario they give you is a lung scenario, guess what kind of a problem it is?
Respiratory.
It's respiratory. I mean, it can't be any easier than that. However, that only gives you a 50-50 because it could be respiratory acidosis or respiratory alkalosis, correct?
Right.
Well, how do you tell between those? Well, the second question you ask yourself is the client overventilating or underventilating? Is the client or patient overventilating or underventilating? That is going to be critical for your respiratories. If the patient is overventilating, pick alkalosis. If they are underventilating, pick acidosis. Now this is extremely simple. It's almost pathetically simple. Are these not the only four options you have to choose from when you combine them to make these imbalances? It's either metabolic or respiratory, it's either acidosis or alkalosis, right? So you're choosing between these four words, correct? Well, let's look to see how this works. If the client is overventilating, let's take the word ventilate. Which of these three words fits best with the idea of ventilating? Exactly. Now, we're left with what? Over. Of the remaining three words, which word has the closest connection to something being over? Why alkalosis? Because it's over the normal. So that's alkalosis. So if you put them together, ventilating over becomes respiratory alkalosis. See how easy that is? And if I say the patient is under ventilating, what does vent become? Respiratory. What does under become? Acid, because that's under the normal. So under vent becomes respiratory acidosis. You see, you're just translating. You're just translating. See that? How many understand what I'm saying? Okay, do you see how easy this is? You're simply translating. So when they say overventilate, you say, oh, respiratory alkalosis. Underventilate, respiratory acidosis. So let me ask you this. They give you a scenario where a woman is overzealously using her breathing techniques during labor. She's really overzealously using those breathing techniques. What acid-base disorder would she exhibit? Well, is that lung? Yes, she's breathing techniques. Overzealously using breathing. So that's lung. Is she overventilating or underventilating? Overventilating. You translate that to mean respiratory alkalosis, and that would be your answer. You have a child who was a victim of near drowning. What acid-base disorder would it be? Well, is that a lung scenario? near drowning. Yes? Would the kid have been overventilating or underventilating when he was nearly drowning? Under, so he would have respiratory acidosis. Your patient has emphysema and air trapping. Is that lung? Is he overventilating or underventilating? Under, so he would respiratory acidosis. Be careful. Ventilating doesn't mean respiratory rate. The respiratory rate is irrelevant here. Everybody pays way too much importance to the respiratory rate. Do you understand that ventilation has to do with gas exchange, not respiratory rate? For example, I could say that a person had pneumonia in 4 lobes of the lung. Pneumonia in 4 lobes. They're breathing at 50 a minute, and their SaO2 is 78 on 8 liters per mask. You got it? What do they have? Pneumonia in 4 lobes. They're breathing really fast, but their SaO2 is really low. Now, is that person overventilating or underventilating? Under, even though their rate is 50, because rate has nothing to do with it. And everybody pays so much attention to rate, they miss these questions right and left and don't understand why. Because you're paying attention to the wrong piece of information. It's not about the rate, it's about the SaO2. Would you agree with me that if your SaO2 is good and you're breathing slow, you're fine, but if you're breathing fast and your SaO2 is low, you're actually underventilating? So the rate can be tricky. So what am I trying to tell you? When you get acid-base disorder questions, what piece of data in the question is real shaky to use to get your answer? Respiratory rate. Because a lot of times it compensates, which means does the opposite, so you'll totally get the wrong answer. You see what I'm saying? Pay attention to what? SaO2. All right. Somebody's on a PCA pump. What acid-base imbalance would tell you that maybe they need to come off that thing? They're on a PCA pump. What acid-base disorder would tell you they need to maybe come off that thing? Well, you say, okay, well, PCA pump, what do you know about PCA pumps? They what? Depress respirations. Why would they need to come off of it if they were, what? Getting too much, which would make my respiratory rate go really what? My ventilations go really down, which would mean I would be under ventilating, so the answer would be respiratory acidosis. So respiratory acidosis would tell you that maybe you need to back off that PCA pump. Is that making sense? And see, those are questions you may not have even thought you know the answer to, but you can get the answer if you just calm down and use it. Because this is a what? It's a tool. So use the tools at your disposal. Don't say, I can't get the screw out, and the screwdriver's still sitting in the box. Grab the screwdriver and try to get it out. So many times I teach people tools on how to take tests and everything, and then I do test questions with them, and they leave the tools in the box. You know what I'm saying? Get the tools out. Start using them. What if it's not lung? The next box says, what if it isn't lung?
Metabolic.
Then it's metabolic. If it isn't lung, it's metabolic. Well, good news. There's really only one scenario where you will answer metabolic alkalosis, and that's what the next fill in the blank says. It says if the patient has prolonged gastric, vomiting or suctioning, pick metabolic alkalosis. Why? Why does prolonged gastric vomiting and suctioning lead to metabolic alkalosis? You're losing acid. If you lose acid, you become basic. Otherwise, everything else that isn't lung, you pick metabolic acidosis. For everything else that isn't lung, that's another fill in the blank. For everything else that is not lung, pick metabolic acidosis. So let me ask you this. A patient had GI surgery. he has had a NG tube to low intermittent GOM co-suctioning for 3 days. What acid-base disorder would he most likely exhibit? Metabolic alkalosis. Your patient has hyperemesis gravidarum. What acid-base disorder are they most likely to exhibit? Metabolic alkalosis. Your patient with hyperemesis gravidarum is now dehydrated. What acid-base disorder would they have? Now they've gotten dehydrated. That's not prolonged gastric vomiting suctioning. It's something you see with it, but it isn't what it is. So now what would they have? Metabolic acidosis.
Because it caused that.
Because that's what it flipped on the other side and now you're there. Good point. What about this? Person has acute renal failure. What acid-base disorder? Acute renal failure. What acid-base disorder? Why metabolic acidosis? Why? You're right, but why? Is it lung? No. Is it vomiting or suctioning? So it's got to be metabolic acidosis, because everything that isn't lung or vomiting or suctioning is metabolic acidosis. So what about infantile diarrhea? What acid-base disorder? Metabolic acidosis. Why? It's not lung and it's not vomiting. That's the other end. Diarrhea. Okay. What about third-degree burns over 60% of the body? Third-degree burns over 60% of the body, first phase. What? Absolutely, metabolic acidosis, because it's not what? Lung, and it's not vomiting or suction. Okay, what acid-base disorder do you see with idiopathic bullous pemphigus? What? Yeah, metabolic acidosis. Very good. Absolutely correct. Why? I mean, I don't know what it is.
It is long, though.
But if it is long, it's only, you got one body system out of 13. Right? And if it's vomit or suction, you've got 1 out of 1,000 symptoms. So when you don't know what it is, what's your answer? Absolutely, metabolic acidosis. In everybody right now, as you're sitting there, I want you to set your default setting for answering acid-base questions to metabolic acidosis. Okay, everybody, do it. Okay? Do it. So that when what do I never want to hear? I never want to hear you guys go, oh, I don't know what acid-base disorder is because I've never heard of that disease. That's when you absolutely do know what it is. It's what? Metabolic acidosis. I've used that rule for 20 years. I take the Hesse twice a year. I take ATIs. I take Kaplan junk. No, stop. I shouldn't say junk. Why did I say that? Kaplan quality materials. And I do every book that's published, everything that's there. I do that. Why do I do it? It's my job to prepare for you guys. I better know what's out there, and I better know what's current, and I better know how it's being tested. So I've done, if it's been published, I've done it. I've even been to the NCSBN site and done their questions. So I know what these questions, and every time I don't know on an acid-based question, what does Mark Klimek pick?
Metabolic acidosis.
And he's 100% right every single time. I have never missed a question using that. All right? So let me ask you this. What do you have to know for acid-base? Well, what you have to know is if the pH and the bicarb are both in the same direction, it's metabolic. As the pH goes, so goes my patient, except for potassium. Matt Kuzmal. Overventilate, underventilate, translate. Vomiting or suction, metabolic alkalosis. Everything else, metabolic acidosis. If I don't know what to pick, metabolic acidosis. That's acid-base. That's all you have to know. So, say it with me. If the, come on, get in. Okay, if the pH and the bicarb are both in the same direction. It's metabolic. As the pH goes, so goes my patient, except for potassium. Who's your favorite Scotsman? Okay. Overventilate, underventilate, translate. What do I mean by that? Overventilate, underventilate, translate. Yeah, translate the word. Overventilate is respiratory alkalosis. Underventilate is respiratory acidosis. If it's vomiting or suctioning, pick. Metabolic alkalosis. For everything else, pick. Metabolic acidosis. And when you don't know what to pick, pick. Yeah, I use that all the time. That works for you. Okay, those are helpful tools that work. All right, yes?
So this one, just to make this clear, that one question you asked, if you have severe vomiting and you've gotten dehydrated now, that you look at the dehydration.
Dehydration, right.
So now it's
Right. There's a
metabolic
rule
acid.
in test taking
So
is,
watch what they're asking.
yeah, when you want to get a question right, you always pay more attention to the modifying phrase than the original noun. Did everybody hear that? You always pay more attention to the modifying phrase than the original noun. Do you see what I'm saying? So a person with obsessive compulsive disorder who is now psychotic, what's more important? Psychotic than obsessive. Do you see what I'm saying? A patient with vomiting who is now dehydrated. The dehydrated takes precedence over. So the modifying phrase trumps original noun. And people get caught on that every time. Boku questions. They crash and burn on that. Because they're focusing on original noun. It's gone past original noun. It's now modifying phrase is what the question's about. Good question. Okay, let's talk about ventilators and we'll take a break. Ventilators. The first two things you have to know is the alarms. You have to know the alarm systems. And you have to know how the blood gases articulate with ventilators. There is a thing called a high pressure alarm. A high pressure alarm is triggered by increased resistance to airflow. Increased resistance to airflow. In other words, the machine is having to push too hard to get the air into the lungs. It's having to push too hard. There's resistance. And when that happens, the machine will set off a high pressure alarm. Because you understand, when you set up a vent, you set up two alarms. You say, I don't want you to use less than this pressure to get that air in, and I don't want you to use any more than that pressure. You tell it that. And then when it exceeds that, the high pressure alarm goes off. Say if you set the high pressure at 40 millimeters of mercury, and you say, I don't want you to push, machine, I don't want you to push any more than 40 millimeters of mercury to get that air in. If the machine has to, it will set off the high pressure alarm. Because it's telling you it's too hard. I'm having to work too hard because it's high pressure. Does everybody understand that conceptually? Okay, now what would it be due to? Well, obstructions. There are three obstructions. Number one, kinks in the tubing. The tubing could be kinked. Would that increase resistance? Mm-hmm. Sure. So what do you do for that? That's rocket science. Unkink. Okay. Then, second most common obstruction is water condensing within the tube. There's water condensing in the dependent loops. So what do you do for that? Now there are more rocket science here. Empty it. And the third most common cause is mucus secretions in the airway. They've got goop there. Gunk. Junk. Mucus. And what do you do for that? Now what will be... Suction is correct, but what would you do before you suction? And I'm not talking about pre-oxygenating them, because that is true. But is there another strategy that would be done to mobilize secretions before you would actually suction the person? What would you do? Yeah, change position. Turn, cough, deep, breathe. Change position. Turn, cough, deep, breathe. So you would do that first, and if that didn't work, what would you do? Suction. What do you guys know about suctioning airways? What do you think? Good, bad, otherwise? What do you think? Give me your impression. The more you do it, the more secretions problems you cause. So it's a double-edged sword. So how often do you suction patients? Every 15 minutes, every hour, every 2 hours, every 4 hours, or none of the above? None of the above. How often do you suction people? As necessary. And that means when they cannot mobilize it after they've been turned and coughed and deep breathed. In ICU, I'm notorious for getting nurses always negatively talk about me in ICUs because I don't do much suctioning, but I do an awful lot of turning. And I find if somebody's O2 sat's low and they're tacking and they're looking like they need, and I don't get good air exchange and the high pressure alarms are going off all the time, I turn them. Patient coughs and whack, out comes this thing, hits the wall on the other side, and then they pink up and they're just fine, thank you, and I never did suction them. And I'll go and report and they'll say, how many times did you suction him? Oh, I didn't suction him at all. How come you never suction people? Well, his O2 sat is 98 on room air. You got a problem with this? You see what I'm saying? His lungs are clear. He's got 98 on room air. Temperature's normal. You got a problem? Okay? So I do a lot of turning, man. I do a lot of turning and confident deep breathing, and I find I don't have to do a whole lot of suction. Some people, yeah, but not as much. Okay, so that would be a click and drag. What do I mean by a click and drag? Order. What would you do first? High pressure alarm goes off. What do you do first? What do you click first? Unkink. Check for kinks and unkink. Click it, drag it, drop it. Then what would you grab second? Empty water out of tubing. Click, drag, drop. Then what? Turn, cough, deep, breathe. Click, drag, drop. Then what? Suction, click, drag, drop. That would be your order. Turn the page and let's talk about low pressure alarms. What's this saying? Decreased resistance. Remember I told you always set a low level, and if it is below that, there's decreased resistance. So what's the machine saying? Yeah, that was too easy, yeah. I had to work too little. That was way too easy, pushing that breath in. Well, what do you think would cause a low pressure alarm? Decreased resistance. Disconnections. There are 2 disconnections you need to know about. The first one is disconnection of the main tubing. If the main tubing is disconnected, what do? Yeah, it's more rocket science. Reconnect. The other most common disconnection is the oxygen sensor tubing. What is the oxygen sensor tubing? What is that? Anybody know?
Senses the level.
It senses the FiO2 right at the trach area or the airway area. But what's it look like? Anybody know what it is? It comes from the ventilator machine. It's a wire, a black coated wire. It's very small. It's probably about half the diameter of your pencil or pen that you're using there. And it goes right along the tubing, piggybacking it along the tubing, and it comes right where the trach or the endotube is, and it kind of just hooks. It's like do you have a computer where when your battery's low, you take the cord and you hook that little cord in there, makes a right angle? You have one like that? Mm-hmm. Well, it's like that. It hooks into that hole in the tubing, and it measures the FiO2, the oxygen delivered right there. But if that pops off, when the air comes in, what's it do? It goes out that tube instead of into them, and there's less resistance. Do you see how that would work? So you have to just take that sensor and plug it back in. Because so many nurses, it'll be going bong, 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 low pressure, and they're going, but it's connected, and here's the wire hanging down, and they don't see it. So reconnect the main tubing, then reconnect the oxygen sensor. Those are the 2 most common problems. So in general, what are high pressure alarms due to? In general, obstructions. In general, what are low pressure alarms due to? Disconnections. And LPNs, this is the same as RNs. You understand the RN test to LPN is the same information. It's just from a different perspective. For example, like an RN question would say, you have the following 4 patients. Which one would you assign to an LPN? The LPN question would say that you have the following 4 patients. Which one would you accept as an assignment from an RN? It's the exact same 4 people, just looking at it the other way. Do you see what I'm saying? So you really do, LPNs and RNs need to know basically the same kinds of things. They just need to know the difference in the scope of their practice. In some ways, no, I won't go there. Okay. What about acid-base disorders? Respiratory alkalosis. Respiratory alkalosis means the ventilator settings may be too what?
High.
Why did you say that?
Eating too much.
We can turn respiratory alkalosis into another word. What can we turn it into? Respiratory. Ventilate. Alkalosis. Over. So then you read it. Over-ventilating means the ventilator settings may be too. See how easy it is? All you do is take these acid-base disorders, turn them into just normal words, and the answer will jump off the page at you. So what is the other word for respiratory acidosis? Underventilate. So underventilating means the settings are too low. Do you got that? Now how would this be applied in a question? And we'll do this question, then go to a break. The doctor says, wean off vent in AM. Got it? He's writing it today for tomorrow. Wean the patient off the ventilator in the morning tomorrow. The 6 a.m. ABGs show respiratory acidosis. What would you do? A, follow the order. B, call respiratory therapy. C, hold the order, call doctor. Or D, begin to decrease the settings. What would you do? Talk to your buddy. And LPNs, it would be wherever it says call doctor, you can put notify RN. What's your answer? The answer is C. Why did you know it was C? He's underventilating. How do you know he's underventilating? He's got respiratory acidosis. So does he need this ventilator? Oh yeah, he does. Because he's being underventilated on the ventilator. He's on the ventilator and he's already underventilated on the ventilator. Am I going to take him off the ventilator? He's going to be even worse. So what acid-base disorder did you want to see at 6 a.m.? Respiratory alkalosis, which means he's being overventilated. In that case, he probably doesn't need the ventilator. So is this hard or easy? Do you guys, an hour ago, if I told you got to get a bunch of questions on ventilators and acid-base and how you use your acid-base imbalances to know what to do with ventilators, how many would be going, oh my goodness? Okay, how many do you see it's not really hard? It's very simple. Very, very easy. You can be whiz-bangs at this. Why is B a bad answer? Why is B a bad answer? What's that? Yeah, never pick an answer where you don't do something and somebody else has to do something. Because you may feel like doing that, but that isn't the answer. Okay, that's what I call the chicken answer. You know, you're afraid to call, so you have respiratory therapy do it. If a patient says to you, I have cancer, I only have 6 months to live. Do you think there's a heaven or a hell? Where do you think I'll go when I die? What would you do? Do not pick, call chaplain. Okay? Now, you may not feel like you want to deal with that right then and right there, but as a nurse, you're supposed to say what? What do you think about? Do you see what I'm saying? That's the answer. Yeah, you're going to hell. How's it make you feel? Yeah, I can see that. Don't tell anybody at Cedarville I said that. Okay, take a 10-minute break. You guys have been really good. And we'll come back at 25 after. Your big question. How about if we start with a little bit? Okay, come on.
Well, you know what I mean, as far as let's say every Sunday comes signing out except for me, you suck. So I answer
Yeah.
Can we squeeze through here, Karen?
Oh, yeah.
Thank you.
Because you have you're a generalist. What they found out there is you're not a specialist. This is a generalist test. So the questions that are failing are those OB questions where they say, you're to give Parladel to a postpartum woman prior to giving Parladel to postpartum. What's the most important take?
I'll call you on a break right now.
You missed that.
Over at 9:30.
You're going back. That's what a generalist you're going you see a certain trace in you see a certain your mother like is having certain symptoms that look not too good. What would you do first? Check her fetal heart rate, take her temperature, take her blood pressure, take her pulse. She's in trouble. She looks like she's getting in trouble. What would you do first?
Did you write the one down about the guy with third-degree burns over 60% of the body? He had metabolic what?
Exactly, because a generalist, if anything about obedience, really doesn't matter. Darker and darker. Okay, alcoholism. Page 4, alcoholism. We're going into some psych and some med-surg both with this one. I want to talk about the psychological aspects of alcoholism, called the psychodynamics. The number one problem in alcoholism psychologically is the same as the number one problem in any and all abusive situations. The number one problem in abuse is denial. Denial. Abusers have an infinite capacity to deny. In fact, an abuser has to deny in order to continue the behavior. Because what does denial allow that abuser to do?
Keep doing it.
Keep doing it without having to answer for it. They just deny they have a problem with it. Now, I want you to understand, the title of this lecture is what? Alcoholism, but this first part is you can use the alcohol rules for any abuse. So what's the number one psychological problem in child abuse? What's the number one psychological problem in gambling? What's the number one psychological problem in cocaine abuse? What's the number one psychological problem in spouse abuse? Elder abuse. Denial is the number one problem in all abusive situations. Why is it number one? How can you treat someone that denies they have a problem? Right? So until they admit they have a problem, you've got a problem. Okay, definition. A, definition. What's the definition of denial? It is refusal, that goes in the first blank, refusal to accept the reality of a problem. They refuse to accept the reality of it. They say, I'm not an alcoholic. I can quit anytime I want. I'm not a spouse abuser. We just have a really physical relationship. I'm not a child abuser. I'm just a really strict parent and my kids aren't spoiled. Do you see what I'm saying? I'm not a gambler. I like games of chance. I'm not a food abuser. I'm a gourmand. You know, they have all these denials about their problem. So how do you treat denial? Letter B, you treat denial by confronting it. You confront it. Confront. You confront it by pointing out to the person the difference between what they say and what they do. So how you confront someone is this. You say, okay, you say you're not an alcoholic. It's 10 o'clock in the morning, you already drank a 6-pack. You know what I'm saying? You just confront them. What did I point out? The difference between what she said, which was what? I'm not an alcoholic, and what she did, which was drink a 6-pack before 10 o'clock in the morning. You say you're not a spouse abuser, but she has a restraining order against you. You see the confrontation? You say you're not a child abuser, but Protective Services has your children. You see, you say you're not a food abuser, but you're 400 pounds and you're 5'1". Do you see what I'm saying? It's my thyroid. Okay, it's your thyroid. All right. But the point is that they will deny what they have, and you confront it by pointing out the difference between what they say and what they do. That's confrontation. Now, don't get thinking that confrontation is the same as aggression. Don't get those two things mixed up, because aggression attacks the person. And aggression says, you are too an alcoholic, you jerk, you have to admit it. Do you see, what did I attack? What did I attack? Her. You, jerk, admit it. When I confronted, did I attack her?
No.
You what? Say you're not an alcoholic. That's sort of, okay, you say you're not an alcoholic. Did I attack you?
No.
Well, I just said, you say you're not an alcoholic, but it's 6-pack gone by 10. I mean, you're just saying, hey. Mm-hmm. You're not saying right, wrong, good, bad, horrible, wonderful. You're just saying, hey, this is what it is. This is what I see. You confront. So don't get confrontation mixed up with aggression. Aggression attacks the person. Confrontation attacks the problem. On boards, never attack a person. Just another little note. They have these questions where you're interacting with staff, and they'll say something like, you're dealing with a staff nurse that has more seniority than you on your first job, and they just find fault with everything you do. You understand the scenario? Well, how do you handle that? What do you say? Does anybody know what you say? What's bad to say? And think about pronouns. What pronouns would bad answers have, and what pronouns would good answers have in that scenario? You versus I. So explain that to me. What do you mean? What's the good? What's the bad? The good answer has what in it? I. Bad answer has you. So what don't you say there? Why don't you like me? Why are you so mean? The right answer is, I seem to be having I seem to be frustrating you. I seem to be having a problem, or or seeming to not get along well. You see what I'm saying? Always, when you're dealing with psychodynamic problems with staff, use the I. I'm, not you. Do you understand that? That's a real big thing they are testing a lot now. Okay, same thing with physicians. Physicians, when you question them on the phone, don't say, you wrote the order incorrectly. You say, I'm having a difficult time interpreting exactly what you want. Do you see the difference? Okay. So, when they are in denial, what do? Confront. Deny, confront. Deny, I want you to link that in your mind. Deny, they deny, you confront. They deny, you confront. However, be careful because there's another place where denial is operative, and that is loss and grief. Don't people go through denial in loss and grief? Have you heard of the stages of death and dying, loss and grief?
Yeah.
What are they?
Dabda.
DABDA. D-A-B-D-A. D-A-B-D-A. Denial, anger, bargaining, acceptance, depression, acceptance. Denial, anger, bargaining, there's your DAB. And depression, acceptance, there's your DA. DABDA. So, denial is an accepted, healthy, normal first reaction to grief and loss. So what do you do for the denial of loss and grief? Do you confront it? What do? Support it. The word is support. You want to support it. So my point is this. When you get a patient in denial, what do you have to pay attention to get the question correct? Is it loss or abuse? Is it loss or abuse? With abuse, you what? Confront. With loss, you support. I live in Cedarville. It's college of 3,000 in a town of 3,000. So there's one student for every person in the town. But we were basically a farming community with a college. And we have a lot of one-handed men in our town. Why? Baler accidents. The balers amputate their hand. So we have a lot of farm machinery, one-handed baler accident guys. Can you imagine a farmer comes in, his hand gets amputated, and it's all wrapped in a bandage. The next morning, you're taking care of him, and he says, "I can't wait to go home and play piano." Problem. He only has one hand, right? So he's in what? What is he refusing to accept? The reality. Is that denial, refusing to accept the reality?
Yes.
So he's in denial. What would you never say to him? You say you're going to play piano, but you only have one hand. That's called what? Confrontation. Now, is confrontation okay for denial? Yes, as long as it's abuse, but not if it's loss. And this guy is lost. So what do? You say, "Oh, well, how long have you played piano? What's your favorite kind of music? Did you take lessons?" What are you allowing that denial to continue? You're supporting it because it serves a function. Is everybody getting the difference? But if you got an alcoholic says, "Oh, I'm not an alcoholic. I can quit any time I want." He's in what? What's the strategy? Confront. What would be really horrible to do? Support. You wouldn't say, "Oh, how long you been drinking? What's your favorite beverage? Did you take lessons?" Did you ever go to have that, hurricane over there at, MacGyver's bar? You don't support it. So you see where you got two totally different answers for denial. Just pay attention to that. Okay, let's talk about the number 2 psychological problem that abusers have, and that is dependency, codependency. Dependency is when the abuser gets the significant other to do things for them or make decisions for them. In other words, the abuser says, "Oh, would you call my boss? Would you go do this? Would you do that?" And they do it. So who is dependent? The significant other or the abuser? The abuser is dependent. Okay. Now, codependency, on the other hand, is when the significant other derives positive self-esteem from making decisions for or doing things for whom? The abuser. So the abuser says, "Call my boss, tell him I'm sick." That's an example of what? Dependency. The significant other calls the boss, says, "He's sick, he can't come to work." Hangs up, says, "Oh, aren't I a wonderful spouse? Because I did that, because I don't know anybody else that would do it for that jerk." What are they? How do you know they're codependent? Did they get positive self-esteem? Yeah, what did they say? "Oh, aren't I a wonderful spouse because I did that?" See, they have this rather pathologic yet symbiotic relationship. One is dependent, the other gets positive self-esteem from meeting those dependency needs, and they just feed off the other. What does the abuser get out of the relationship? What does the abuser get out of the
Gets to keep
relationship?
doing it.
What's that?
Kids keep doing.
Yeah, a life without responsibilities. He gets to keep doing whatever he wants, abusing. What does the significant other get out of it?
They feel good. They feel
Positive self-esteem out of it. And then we sit there and we say what to the significant other? Leave him. What are you doing in that relationship? Get out of it. Right? But they can't get out of it because what's tied up in that whole thing? Their self-esteem. So, it's really kind of tough to treat. Well, then how do you treat it? How do you treat it? Well, number one, you set limits and enforce it. You set limits and enforce them. That goes fill in the blank. Set limits and enforce them. In other words, you start teaching the significant other to say the 2-letter word no. And then they have to keep doing it. Will you call my boss? No. Would you go buy me some? No. Would you drop me off at the track? No. Would you get me a ham sandwich out of the refrigerator? Well, see, that would be okay. I'm not saying say no to everything. I'm saying say no to those things where you're feeding into everything, all right? But that's not good enough. That alone will not work. Because you must work on the self-esteem of the codependent person, or it will never work. Because as soon as the codependent starts saying no, what will the dependent abuser start saying? You don't love me anymore. You don't love me anymore. You're a mean, nasty old whatever. Because you are just horrible. You're horrible. And what's that person playing right at? Self-esteem. They know what side the bread's buttered on. And they go right at that person's self-esteem, and within 10 minutes they got them emotionally manipulated right back into the whole system. So in order for this to work, what does the codependent person have to say? I'm saying no, and I'm sticking to it because I'm a good person because I'm saying no. Oh, you're nasty. I don't care what you say. I'm a good person. And that's how you have to work on it. The thing is, I worked at Lafayette Clinic in Detroit, Michigan for a couple of years, and it's mostly alcohol rehab and seizure. And we found that when we treated codependency, dependency successfully, when we treated this problem, guess what we lost? The relationship. The codependent person would go, I'm a good person, I don't need you, and why am I here? And they'd leave. So, we'd solve the problem but lose the relationship. Real common. Okay, turn the page. Let's talk about manipulation. What's the definition of manipulation? It's when the abuser gets the significant other to do things for him or her that are not in the best interest of the significant other. The nature of the act is dangerous or harmful. What goes in the blanks is interest and harmful. Interest and harmful. So how is this like dependency? How is manipulation like dependency? Yeah, in both situations, the abuser is getting the other person to do something for them. Then how in the world do you tell the difference between those two things? What's that? Well, neutral versus negative. Look at what they're being asked to do. If what the significant other is being asked to do is neutral, no big deal, no harm done, no harm, no foul, it's simply dependency, codependency. If what the significant other is being asked to do is inherently harmful or dangerous to the significant other, that person is being manipulated. So let me give you 2 examples, and you tell me which one is denial, which one is dependency, and which one is manipulation. A 49-year-old alcoholic gets her 17-year-old daughter to go to the store and buy alcohol for her. That is what? Why?
This is an alcoholic.
Well, no, because
Getting hurt.
because a 17-year-old going and buying alcohol is illegal in the state of Ohio. So it is illegal. So she's being asked to do something illegal. Now, what about this? A 49-year-old alcoholic asks her 50-year-old husband to go to the store and buy alcohol for her. Of what is that an example? Why is it dependent? It's the same thing, buying alcohol.
She's old enough. She knows he has a problem, and she's old enough.
I mean, well, and she's of age. There's nothing. How harmful is it for a 50-year-old man to go to a store and buy alcohol? Any harm? No. So that's simply dependency. But when the 17-year-old goes to buy alcohol, that's illegal. There's harm. That's manipulation. Let me give you an example. Tuesday evening or last Friday evening. Remember Tuesday, last Friday, around here? Okay. Your neighbor calls you. No, your brother calls you. Sister-in-law calls you and says, "Would you pick up little Billy from basketball practice at school so he can spend the night at your house because of the snow?" Now you have a four-wheel drive what? Hummer, Jeep. What's best in the snow? Not ice, but snow. What? Four-wheel drive, some big. Okay, you got a big earth mover, four-wheel drive earth mover. Okay, and you live 3 blocks from the school, and you say, "Okay, sister-in-law, I'll do that." You are being what? She is being dependent on you. You're being codependent because you'll say, "Oh, aren't I a wonderful brother-in-law for doing this," right? What if your sister-in-law calls you? She's got the four-wheel drive all-terrain vehicle. And she lives 3 blocks from school. She asks you to pick up her son and take him to your house. You have a Kia Sophia with ball tires, and it starts every other time. It leaks oil, got no heat. Do you see what I'm saying? And you live 20 miles from the school. And what's happening here? You're being what? Manipulated, because it is inherently dangerous for you to get in that car and go that distance when she could do it easily, safer, better herself. Whereas in the first one, it was safer and better for you to do it than... Do you see what I'm saying? Dependency and manipulation are similar. It's just the only way you tell the difference is one, you're being asked to do something which is bad for you, that's manipulation, versus something that's neutral, that's dependency, codependency. Can you tell the difference now? Okay, good. All right. How do you treat manipulation? You set limits and enforce them. So you start saying what 2-letter word? No. Number 2, it is easier to treat than dependency, codependency, because nobody likes being manipulated. I have never heard a person say, "Oh, I must be a wonderful person for being manipulated." Do you know what they all say? "I must be an idiot for falling for that." Do you hear any positive self-esteem going on? No. So there's no positive self-esteem issue going on with manipulation like there is with dependency, codependency. You see why it's easier to treat? Okay, let's just summarize. How many patients do you have with denial? If Bob is in denial, how many patients do you have? 1, 2, or 3, or 4? Bob is in denial. How many patients do you have? 1, 2, or 3, or 4? 1. Bob is dependent. How many patients do you have? 1 or 2? 2, because you got to get the codependent. Bob is a manipulator. How many patients do you have? 1 or 2? 1. you see what I'm saying? Because you don't have to do anything with the person who's being manipulated because there's no self-esteem issues. So with denial, you got one patient. With dependency, you have two patients. With manipulation, you have one patient. Does that make sense? Okay. All right, let's talk now about things specific to alcoholism. Let's talk about Wernicke's or Korsakoff's. Wernicke's and Korsakoff's. Typically, they are separate, but boards often lumps them together. Wernicke's is an encephalopathy and Korsakoff's is a psychosis, but they tend to go together. You find them in the same patient. So Wernicke-Korsakoff's is number one, psychosis induced by vitamin B1 or thiamine deficiency. This is a scenario where you lose touch with reality. You go insane because you don't have B1.
What's induced?
Psychosis, which means insanity or loss of touch with reality. These are psychotic people, not just a little bit emotionally disturbed. These are psychotics. The primary symptom, number two, is amnesia with confabulation. Amnesia with confabulation. Amnesia means memory loss. Confabulation means making up stories. Why do they make up stories?
I don't know.
Because they forgot. Well, in that case, then I'm psychotic. Because I often make up details that I have forgotten. Right? So then why are they psychotic and me not? Fair question. Why? So everybody that forgets something and makes up a story to fill in what they forgot is insane, psychotic. True or false? False. Well then, explain to me the difference. Why? Why are these poor people called in psychotic and we're not? Because they believe it. See, when I fill in details because I forgot, I know it's not really true. But they really believe it. The lie is just as real as reality. And their memory loss is not, oh, I forgot what I did last night when I was drunk. No, it is, what happened to the 90s? They don't remember anything in the whole 1990s. They'll lose entire decades of their memory. So what will they do? Make up stories as to what they were doing during the 90s. I had a guy that, with Wernicke's, he was Ronald Reagan's national security advisor during the 80s. The guy had never made it past third grade. Now, whatever you thought of Reagan, he wasn't that bad that he would have had a third grader running the national security. You know what I'm saying? So he definitely was never Reagan's national security advisor. He thought he was. He could tell you meetings, dates, times, people. He had this whole psychotic reality built around Ronald Reagan's terms in office. And he believed it. He literally believed it. He believed it as that was as real as anything that was happening right then and right there. So, how do you deal with that? How do you think you deal with that? You got a Wernicke's Korsakoff's guy who thinks he is Obama's Secretary of Defense. And so he's got to get up and go to a cabinet meeting right now. How do you deal with that? What would probably be a bad way to deal with that? What's that? Okay, we don't usually agree or disagree.
Confrontation.
We don't confront. Why?
Because they'll get angry.
Why?
Because you're telling them that what they're saying isn't true and they believe it.
Right. And it's due to brain damage. So are they ever going to learn what's true and what's real?
No.
So is this permanent or not? Typically permanent. So you don't present reality because they can't learn it. So what do you do? See, this is the questions they ask you. They give you a person with Wernicke's, and they say that Wernicke says he's gone to a presidential cabinet meeting at 8 o'clock this morning. How do you deal with that?
Distract.
Okay, distract is not as good a word as redirect. Redirect is a really good word. And that means to take what he's all about that you can't do and rechannel it into something he can do. So can he go to Barack Obama's cabinet meeting this morning. No. So what you do is you say something like this. Well, why don't you then get a shower? When you're done, we'll go watch CNN to see what the news of the day is in Washington, D.C. You see that? Is he going to do that? Probably, because do you see what I'm saying? And you don't get into a fight with him about, no, you're Joe the milkman, you're not Ronald Reagan's national security advisor. Do you see what I'm saying? Because that's fruitless and pointless. So when somebody has Wernicke's and Korsakoffs and they talk crazy, what do? Redirect. You don't present what? Reality. Because presenting reality is for those people that you think that can learn it, and these people can't learn it. So redirecting them is the way. Now let's talk about characteristics. Number one, it is preventable. You never have to get this in the first place. How can you prevent getting this in the first place? Take vitamin B1. But by the way, vitamin B1 is a coenzyme necessary for the metabolism of alcohol. You don't have to know this. It's necessary for the metabolism of alcohol. So if you don't have B1, you won't metabolize alcohol. It won't go into Krebs cycle. Does that sound familiar? It won't get burned up for energy. So what will it do? Accumulate. And where will it go? Brain, and it will destroy brain cells. That's how this happens. So all they need to protect the brain is to take vitamin B1, and then any alcohol they drink will be what? Metabolized. So they don't have to stop drinking. All they have to do is take their one a day with their vodka in the morning and they'll be fine. They will be perfectly fine. You get a lot of good compliance with this. Okay. B, it is arrestable, which means you can stop it from getting worse. How can you stop it from getting worse? Take B1. Stop drinking? Is stop drinking necessary? No. C, it is irreversible. Now, not everybody has irreversible, but it's about 70% irreversible, so you always say irreversible. Do you understand on boards you always answer with the majority? If something is majority of the time fatal, you say it's what? Fatal. You don't say, well, 5% of the time it's not fatal, so I'm saying it's not fatal. No, don't do that. Go with the majority. So it is irreversible. So it's preventable, it's arrestable, and it's irreversible. 2 good news, 1 bad news. All right, let's turn the page and talk about some drugs that have to do with alcohol. Antabuse or Revia. Antabuse or Revia. Does anybody know the generic name for these drugs? Disulfiram. Disulfiram. Number 1, it is aversion therapy. Aversion therapy. It's a form of aversion therapy. Now, what aversion therapy is this. The word aversion means a really strong hatred for something. A gut hatred for something. What we want alcoholics to develop is a gut hatred for alcohol. That's what we're trying to do here. Well, how do we do it? Well, we give them this drug. Now, you don't have to write this down, but just sort of listen to this for a second. When you take this drug and it gets to a blood level in your blood, if you drink alcohol, it will interact with that chemical in your blood and make you super sick to your stomach. Really super sick. Horribly ill. Let me ask you, have you guys ever been to a restaurant and gotten sick afterward from eating at that restaurant? Anybody? Will you eat at that restaurant anymore? Now, if you go, you probably won't order, you may order something else, but you're not going to order what made you sick because you have developed a what? Aversion to that restaurant. Okay, because if I gave you a $20 bill right now and said, go eat at that restaurant and buy that meal, would you do it? No. Would you take my $20? Yeah. You go somewhere else and buy something else, but you wouldn't go there. So I couldn't even pay you to eat there, could I? Well, we want the alcoholic to have that same reaction to alcohol. In other words, we couldn't even pay them to what? Drink. So if you couldn't even pay an alcoholic to drink, I think that's pretty much a cure. Now, the only problem with this drug is it works in theory better than it works in reality. Or else we'd have had a cure for alcoholism years ago. So it really doesn't work as well as they say it does. But you still need to know how it's supposed to work and whatnot. So the thing the boards wants to know is how long does it take to get into their system and how long does it take to get out of their system? In other words, what's the onset and duration of its effectiveness? And that answer is 2 weeks. 2 weeks. So how long do they have to be on the drug before it starts to work?
2 weeks.
And how long do they have to be off the drug before they can safely drink again? 2 weeks. So usually the way it happens is doctor prescribes Antabuse. You sort of have to live sort of like a transition, like a recovery place, a transition home, where for 2 weeks they make sure you take the pills. And then you're let out into the community. And it will work. And every time you drink, you'll get deathly ill. So, but if you decide you want to drink at a high school reunion, when do you have to stop taking your Antabuse?
2 weeks
2 weeks before the reunion, or you're not going to be able to do it. All right, now, number 3, patient teaching. Teach these patients to avoid all forms of alcohol, to avoid nausea, vomiting, and possibly death. Now, death isn't what we're going for. That would cure the problem, but it's not what we're going for. Now, do you suppose you have to teach an alcoholic, hey, let me talk. Let me tell you what has alcohol in it. Whiskey does, wine does, beer does, tequila. They know that. What you have to teach them that they have to avoid is stuff that they wouldn't think that they have to avoid that they do. And number 1, mouthwash. They need to avoid mouthwash. Even if they swish and spit, they're still going to get sick. Number 2, aftershaves. Even if they put it on topically, they're going to get nauseated. Now, they won't get violently ill from that, but it will make them nauseated. Perfumes and colognes should not be used. Same reason. Insect repellents, like mosquito sprays, off, deep woods, cutter, those are all bad. They'll make you sick. Any over-the-counter that ends in the word elixir, E-L-I-X-I-R. Because what do all elixirs have in them?
Alcohol.
Alcohol. Dimetapp elixir, Robitussin elixir, Dayquil elixir, NyQuil elixir, Tylenol PM elixir, Benadryl elixir. Alcohol-based hand sanitizers. In Greene County, about 6 months ago, we had our first case of alcohol hand sanitizer poisoning. This alcoholic got into Bob Evans and drank every single bottle of hand sanitizer he could get his hands on to keep the shakes away. Because he knew it had alcohol in it. In fact, I've heard that they've taken it out of the prison systems because guys are learning how to distill it and sell it. Another thing they're not allowed to have is uncooked icings. Remember those uncooked, those no-bake icings that you make? Because what do no-bake icings have in it? Vanilla extract, which is powerful. That's Granny's way of getting.
Wow. I didn't know that.
All right, and remember this one. Here's the one that everybody gets suckered in on. Do not pick the red wine vinaigrette. They can have the red wine. Why are they trying to sucker you in on there? Wine. Do you see what I'm saying? And you go, oh, wine, they can have red wine vinaigrette. They just can't have the cupcake with the unbaked icing on it. Okay. Okay, is that all the blanks filled in there, guys? Okay. Now let's talk about overdoses and withdrawals. Bad news. You got to know all your drugs, all the overdoses, and all the withdrawals. Good news. You only have to answer 2 questions to get them all correct. It's an easy way of knowing them. So here we go. Every abused drug, did I say every drug? Mm-hmm. Every abused drug is either an upper or a downer. Would you agree with that?
Yes.
Why are drugs that are not uppers nor downers, why are they not abused?
Because it doesn't.
They don't do anything. Right? Although there is an exception. What is the #1 most abused class of drug that's not an upper or a downer?
Nicotine.
Laxatives in the elderly. The elderly abuse laxatives. But that isn't upper or downer. That's inner or outer, I guess. I don't know. But every abused drug is an upper or a downer. Correct? Okay. Have you ever had anybody come up to you on the street and say, hey, want to buy some Nexium? They're not selling that on the street because it's not an upper or a downer. So, letter A. Do you see in the box letter A? When you get an overdose or withdrawal question, what's the very first question out of your mouth? Is the drug an upper or a downer? That's the very first thing you must establish. That is the first step you take in getting the question correct. Now, let's talk about uppers versus downers. The names of the uppers are caffeine, cocaine, PCP/LSD. What are those? PCP, LSD, what are those called? Psychedelic hallucinogens. Sounds like up to me. And then another class are the methamphetamines. METH amphetamines, methamphetamines. Crystal meth, all that stuff that you buy at the grocery. You know, you buy the Sudafed, all the decongestants, and you cook it down. That's the upper meth. New that you're going to have to know is Adderall, which is the ADD drug, the attention deficit drug. And a lot of kids with ADD are selling their Adderall to their friends at school rather than taking it. ADD is the first 3 letters of Adderall. Okay. But that's another upper, and that's going to be tested probably starting April 1. It's going to be a new one. Now, that's only 5 drugs: caffeine, cocaine, PCP, LSD, methamphetamines, and Adderall. Those are uppers. Well, what do you think the signs and symptoms are when you're on an upper? Things go up because you're on an upper. Figure that out. You know, uppers make you go up. You know, that's pretty hard to remember. So what are they going to have? Give me some signs and symptoms. Principles. Euphoria. Tachycardia. Restlessness. Irritability. Bowels. What are you going to? What's the bowel status going to be? Borborygmi, diarrhea. What are the reflexes going to be? What numbers? 3 and 4. Flaccid or spastic? Spastic. Are they going to respiratorily arrest or seize? Should you have a suction machine or an ambu bag? Are you getting this idea? Uppers make things go up because they are uppers. All right? Downers. What are the names of the downers? Am I going to memorize anything? No. Why? Everything that's not an upper is a, because every abused drug is either an
Upper.
or a,
Down.
there's no such thing as a tweener. So you can't get that. Now, if they want a tweener effect, what do they take? An upper and a downer together. But there's no one drug that gives you a tween effect. Now, there are how many uppers? 5. You know how many downers there are? 135. You know, Dilaudid, MS-Contin, morphine sulfate, codeine, Demerol, fentanyl, Wabane, Nubane, Thorazine, Stelazine, Fluphenazine, Piperazine, Chlorpromazine, Prolixin, Ativan, Xanax, Valium, Librium, phenobarbital, pentobarbital, secabarbital, heroin, hashish, marijuana, alcohol. Do you know what I mean? It's all what? Downers, because it's not an upper. So only memorize. I hate lists, right? But if we can memorize a short one and know everything else is a, that seems like some payoff for me. So what do downers make you do? Go what direction? Because they are downers. So what are you going to see there? Lethargic. Everything that we said, just flip it, and what's going to be the big danger?
Respiratory depression.
Respiratory
Depression.
arrest. Depression and leading to arrest. What do you think about this? Your patient is high on heroin. No, high on cocaine. What's critically important to assess? And one of the answers is B, which says making sure that the respiratory rate is above 12. What do you think? He's high on cocaine. Is a critical measurement making sure that the respiratory rate is above 12? No, why?
It's going to be high.
There's no way he's going to even be close to 12. You got the wrong patient, but they're trying to sucker you into thinking, oh, respiratory rate. No, you know what I mean? Yeah, respiratory rate's important, but not in this patient, because this patient wouldn't have a respiratory arrest because they're high on an upper, which makes everything go up. You'd rather check their reflexes. Do you see what I'm saying? And we go, oh, ABCs. Could you hear that? Airway, oh, respiratory rate less than 12. Wait, ABCs is not a great rule, guys. If you've been living by ABCs, you've been shortchanged for a very long time. It's a very poor rule. I will show you better rules than ABCs. ABCs is a vast oversimplification. How many have used ABCs to get answers? How many have used ABCs? How many have gotten about as many right using it as you get wrong using it? How many you get quite a bit wrong using it? How many get it all right when you use it? Are you understand? How many would say ABCs doesn't really work that well for me? It doesn't. It shouldn't, because it doesn't. Okay. It's a vast oversimplification, but we'll get to that later. All right, B. You see where we're at? B. After you know whether the drug is an upper or a downer, the second thing you ask yourself is, are they talking about overdose or withdrawal? Because they're opposites, and you got to know which one you're talking about. You have to pay attention. Is the question talking about overdose, which is too much, or withdrawal, which is not enough? If you don't pay attention to that, you will miss the question. So what's the first thing you have to pay attention to in a drug overdose question? Is the drug an up or a downer? What's the second thing you have to pay attention to? Overdose or withdrawal. Once you do those, you've got your answer. Your answer is so simple, it's pathetic. Let's look how it works. Under letter B, do you see where it says overdose or intoxication? Do you see that? You have what? Too much. Now, put it together. Put the answers to the two questions you asked together, and you get your answer for the question. In other words, if they say overdosed on an upper, you have too much what? upper, and everything goes up. So you're going to pick those up things because you have too much upper. But what if they say downer and intoxication? In that case, you have too much downer, which makes everything go down, and it's going to go the opposite of what the other one did. Do you see the point here? However, what if they talk about withdrawal? In withdrawal, you don't have enough. You have too little. Well, let's put it together. If you have withdrawal, downer, you don't have enough downer. If you don't have enough downer, everything goes... No, okay, I'm doing it backwards. Yeah, on your page it says you don't have enough upper, right?
Too little.
So too little upper makes everything go down, and then too little downer or not enough downer makes everything go up. Does everybody see the logic in that? So upper overdose looks like what other situation? Upper overdose looks like what other? Downer withdrawal. And downer overdose looks like upper withdrawal. So in what two situations would respiratory depression and arrest be your highest priority? In which two situations would respiratory arrest and depression be your highest priority? Downer, overdose, and upper withdrawal. Exactly. Which two would seizure be your biggest risk? Upper overdose and downer withdrawal. Do you see what I'm talking about? So what's the first question you ask yourself? Up or down. Second question, overdose or withdrawal. Too much or not enough. Put it together. Just pick the obvious answer. Let me show you how I want you to work this. Squad calls you and says they're bringing in a patient, they're 10 minutes out, he's an overdose on cocaine. What would you expect to see? Select all that apply. Person's overdosed on cocaine. It's coming into your ED. What would you expect to see? Select all that apply. What's your first question? Up or down? And the answer is? Upper. Second question. Overdose or withdrawal. In this case, you have what? Which is? Putting two and two together. Too much upper. Right? So, answer your question. And remember, this is a central nervous system drug, not an autonomic. Talk to your buddy. See what they say.
Yeah, but wouldn't that reflexes deal with the spinal cord?
No. Yeah, they still do.
They deal with the spinal cord.
Yeah. You're still seeing it. What do you say, Borderline was?
Border. It's hyperactive reflex.
Okay, how
I've
many
got
did you
valve
select?
cells. 4.
You should have selected 4. Okay? So, first task, cocaine is in.
Upper.
Upper. Overdose means too much. You got too much upper, everything's going to go what direction? So draw your arrow up, then go hunt. What about irritability?
Yes.
Plus 4 reflexes?
Yes.
Respiration less than 12?
No.
Difficult to arouse?
No.
Poor breathing?
Yes.
Increased temp?
Yes.
You're correct. Those 4. You're caring for a client who's withdrawing from cocaine. What are you going to answer? The opposite.
Yeah.
Now you're going to pick respirations under 12 and difficult to arouse. They start doing that on you, you start moving. They need some Narcan. Okay. Are you seeing the idea? So do you have to memorize all these drugs? No. Turn the page. Let's talk about drug abuse in the newborn, or drug addiction in the newborn. This is a real hot topic because we have a lot of babies born nowadays to addicted moms. Always assume, here's the blanks, always assume intoxication, not withdrawal at birth. Always assume intoxication, not withdrawal at birth. So if they say you have a baby at birth or in the first 24 hours, what would you assume the baby is in? Intoxicated. After 24 hours after birth, you'd assume he's in what? Withdrawal. So how old does the baby have to be before you go withdrawal? 24 hours. Now how do you work this? Well, what about this question? You're caring for an infant born to a Quaalude, that dates me, addicted mom. Nobody uses lewds anymore. A Quaalude addicted mom. 24 hours after birth, select all that apply. Okay, so you got a Quaalude addicted mom. You're caring for this infant 24 hours after the baby's been born. Select all that apply. Difficult to console. Low core body temp. Exaggerated startle reflex, respiratory depression, and seizure risk. Talk to your buddy.
So that's what I
Quaalude's
need.
down there, right?
Body temperature down. Treated. Start reflexes. Down.
Why'd you say start with? Why'd you say start with?
So that's a downer.
Hours.
And you're in withdrawal.
Many things that go down.
Low temperature and respiratory depression.
That last one says shrill, high-pitched cry. How many did you select?
2. Only got 2.
You should have selected 3. Okay, so Quaaludes, what are they?
Downer.
How do you know they're downers?
They're not
It's not on the upper list. It's not caffeine, not cocaine, not PCP, LSD, or Adderall, or methamphetamines. You don't know what it, how many didn't know what it was? What should you have said? Downer. When you don't know what it is, pick downer. You got a 100 to 1 chance of being right. I mean, 99 in 100 chance of being right. So you would say this is a downer, and the baby is what?
Withdrawal.
Withdrawing. This has been 24 hours, so he's starting into withdrawal. So he doesn't have enough downer, so everything's going to go up. So, difficult to consult. Yes, oh, hey, there is 4. I'm sorry, I blew it. There's 1. Okay, low core body temp. No. Exaggerated startle. Yes. Respiratory depression. No. Seizure risk. Shrill high-pitched cry. Yes, I'm sorry, I didn't. I wasn't thinking. Now, how many of you are really good at Quaalude newborn situations? How many thought you were? Do you see what I'm saying? It's not that hard. In fact, boards doesn't really expect you to know this. They just want to see if you know some what? Principles that central nervous system depressants 24 hours after birth make the baby go the opposite way. Does that make sense? And they'll pick these things and you're going, oh, I don't know Quaaludes. Oh, I don't know Quaaludes. Oh, I don't know what Quaaludes. Shut up and answer the question. If you don't know Quaaludes, you should know the answer. It's a downer. And then go with it. Because that's what the good test takers are doing. They're putting their money on the best bets. And that ain't the Colts. Okay, alcohol withdrawal syndrome versus delirium tremens. Alcohol withdrawal syndrome versus delirium tremens. You have to know the differences between them. They're not the same. Sometimes people think DTs, delirium tremens, is alcohol withdrawal syndrome. No, they're totally different things. When board says alcohol withdrawal, they mean you're withdrawing from alcohol. When they say delirium tremens, you're in delirium tremens. They are very different. Do not think they're the same. Letter A. Every alcoholic goes through alcohol withdrawal. They all do 24 hours after they stop drinking. So when an alcoholic stops drinking alcohol, within 24 hours, they will all go into withdrawal syndrome. Every single one of them. However, only a minority get delirium tremens. You don't have to know the percentage. It's under 20%. By the way, when do you go into delirium tremens after you stop drinking? Do you know what time frame? 72 hours. So what always comes first? Alcohol withdrawal within 24. Then a couple of days after that, you go into DTs. Here's a statement. You do not have to write this down, but if you understand this statement, then you're good to go. You understand what I said. Alcohol withdrawal syndrome always precedes delirium tremens. However, delirium tremens does not always follow alcohol withdrawal syndrome. Did you got that? Mm-hmm. Okay. So if you have DTs, you had what?
Alcohol withdrawal.
But just because you have alcohol withdrawal doesn't mean you're going to get DTs.
What was the second part of that? The alcohol withdrawal syndrome always
Precedes delirium tremens, but delirium tremens does not always follow alcohol withdrawal syndrome. Okay, next difference, letter B. AWS. AWS is the abbreviation I'm using for alcohol withdrawal syndrome. AWS is not life-threatening. DTs can kill you. C. Patients with AWS are not a danger to self or others. Patients with DTs are dangerous to self and others. The word "are" goes in there, A-R-E. They are dangerous. So here are two really big differences. AWS, it won't hurt anybody. It won't hurt you. You're stable. You're fine. DTs, you're unstable. You could die. Second big difference. AWS, they are not going to hurt anybody. Yeah, they're loud and obnoxious, because they're withdrawing from a downer, which makes everything go up. They're going to be loud and obnoxious, yeah, but they're not going to hurt anybody. But a D-tiers, you have to assume is dangerous, because they are dangerous. All right, now, those differences will translate into differences in care, which we will outline in the table below. Let's fill in this table about the differences between AWS and delirium tremens. First column, first row. Does everybody know what box I'm in? First column, first row, under AWS. Regular diet. Next box down. Same column, first column, second row. Semi-private anywhere. Semi-private anywhere. Which means they can be in a semi-private room anywhere on the unit. Same column, third row down. We're just going down that first column. Up ad lib. Up ad lib, which means they can go around anywhere they want to go. And last box in that column, no restraints. You do not restrain these people because they are not a danger to self or others. Now let's compare and contrast that with the DT's client, delirium tremens. Second column, middle column, first box, first row. NPO, clear liquids. NPO or clear liquids. Why? Why seizure? Why up? Yeah, because they were drawing from a downer, everything's going to go up, and the big up is seizure. And with seizure, you get aspiration, so you want an NPO or clear liquids.
Or, you said?
Yeah. On board, sometimes they'll say NPO, sometimes they'll say clear liquids. They won't have them against each other because that would be too tough to pick, but it'd be either one. The second box down, private near nurse's station. Private room near nurse's station. Why? They're dangerous and they're unstable. See, could you put an alcohol withdrawal patient on a pediatric overflow unit? Sure. They'll be known as Uncle Wally, but and he'll be everybody's best friend, and the parents will say, but he won't hurt anybody. But in D-tiers, you gotta watch these D-teasers. In fact, D-tiers probably should be in ICU. Why?
They're dangerous and unstable.
Dangerous and unstable. But no self-respecting head nurse of ICU will allow them through the doors. Why? Because they're screaming and yelling like banshees, and they don't want that destabilizing the rest of their population. So they usually get stuck on step-down units. But if you, as an LPN, would you accept the assignment of a DT's client? No, because they're unstable. As an RN, would you accept the assignment? Yes, but what would you have to do with the rest of your assignment if you accept DTers on med-surg? Decrease your workload. Somebody else may have to take 7 while you take 3. Okay? And remember, it's a perfect world on boards. Everybody will be fine with that. The other nurse will think they'll be fine with that. Yeah, I'll take 9, you take 2. It's fine. So what kind of reasoning is really a kiss of death on boards? What line of reasoning? What kind of thought process that you would do in answers which would really be bad? Saying, oh, I wouldn't do that because what? I don't have enough staff. I don't have enough experience. I don't have enough time. I don't have enough money. We don't have enough resources. No, on boards you have what? A perfect world. You have all the money, all the time, all the staff. Everybody's cooperative. Everybody's happy. Everybody wants to make it happen. They even don't mind their assignment being changed every hour. Okay. Okay, let's talk about the next thing down. They are on restricted bed rest, which means no bathroom privileges. If they have to use the facilities, we have bedpans and urinals for them. And lastly, they must be restrained. Why must they be restrained? Because they are dangerous. Now, with what would you restrain them? Certain types of restraints are futile and not used. Some are appropriate. What would be some that would be appropriate and some that would not? Do you know?
Wrist restraint.
What about soft wrists? Yes or no?
Yes.
No, they'll get out of that. That's not enough. That's not safe enough. What about 4-point softs? No, that's not. They can get out of that. They need to be in a vest or 2-point locked leathers. Now, what does 2-point mean? 2 extremities. Which 2 extremities? No, not the 2 arms. An arm and a leg. Which arm, which leg? Opposite. You always lock down one arm and the opposite leg in 2-point. That's what it means. That's what you're supposed to do. Now you rotate that every 2 hours, so what do you do 2 hours later? You switch it. Now, what would you do first? Their right arm's locked down, their left leg's locked down. What would you do first? Lock the left arm, then the right leg, then release the... Yeah, don't release them first. You'll only make that mistake one time. And then you'll go, oh, okay, I got it now. You'll remember. Now, what do they both get? Well, they both get an antihypertensive, a blood pressure pill. Why would they get an antihypertensive? Why?
Because everything's going up.
Why is everything going up?
Drop.
Perfect. You guys are so excellent. 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 You got it. You're getting it. Okay, they're both on a tranquilizer. Why do they both get a tranquilizer? Because they're up. And why are they up? Because they're withdrawing from a downer. And they both get a multivitamin containing B1. Why? Wernicke's and Korsakoff's to prevent that. I always say, no B1, you B1. One of those crazies. You know, no B1, you'll B1. And then that last box I shaded. And I shaded that so that you obsessive compulsives, 2 weeks from now, when you go over this lecture, there was nothing you missed. You don't need to call everybody in the class and find out what was in that last box, what was in that last box. Nothing goes in that last box. Okay? All right, let's talk about some drugs, and then we'll take another break. Drugs. Aminoglycosides. This is a powerful, powerful class of antibiotics. As far as antibiotics go, they're the big guns. You know what I'm talking about? When nothing else works, pull out your aminoglycoside, you know? It's like the aminoglycosides are to infections like that scene in Indiana Jones when the big Arab guy comes out with a scimitar, you know, and he starts like this, and Jones pulls out a gun and shoots him. Well, they're like the gun. You know, they're going to blow it away. But you don't use it unless what? Nothing else works. These are dangerous. Now, Boards loves to test these. Why does Boards love to test these drugs? Because they're dangerous, and this is a test of safety. And do you know these drugs? They're in the top, from my experience, these show up probably in the top 5 most commonly tested groups of drugs on Boards. You don't have to know this because I'll repeat it several times, but probably the most common group of drugs you have to know for Boards are your psych drugs, and we'll get that on Sunday. The second most common are the insulins, which we'll talk about tomorrow. The third most common are the anticoagulants, which we'll talk about tomorrow. The fourth is digitalis, which we'll talk about today. The fifth are the aminoglycosides. Then you got to know your steroids, your calcium channel blockers, your beta blockers, your pain meds, and your OB drugs. Those are the big 10, and we hit all of them. Okay, so these are real important to know. Now, here's the deal. For aminoglycosides, think the following. A mean old mycin. When you see the word aminoglycoside, from now on, I do not want you to think aminoglycoside. I want you to think a mean old mycin. Do you hear the similar sound? Amino, amine old. Amino, amine old. So when you see aminoglycoside, think what? Amine old mycin. Okay, now, what does that tell you? Well, here's what that tells you. The letter B. They are antibiotics used to treat what? Well, if they are mean, old drugs, what kinds of infections would they treat? Serious or non-serious? Life-threatening or non-life-threatening? Resistant or susceptible? Gram-positive or gram-negative? Gram-negative. So you got the resistant, serious, life-threatening, gram-negative infections are treated by what? A mean old mycin. So you treat a mean old infection with the mean old mycin. Do you hear what I'm saying? So would you use these drugs to treat sinusitis?
No.
Why?
No. It's not.
It's not a mean old infection, so don't use a mean old glycoside. What about tuberculosis? Ooh, that's a mean old infection. I use a mean old mycin. What about septic peritonitis?
Yeah.
Is that a mean old infection?
Mm-hmm.
Yep, so I use a what? A mean old mycin. What about otitis media?
No.
Middle ear infection. Is that a mean old infection?
No.
No. Do I use a mean old mycin? No. What about bladder infection? No. What about fulminating pyelonephritis? Yeah. Septic shock.
Yeah.
Infection of third-degree burn wounds over 80% of your body.
Yeah.
You got it? What about viral pharyngitis?
No.
Strep throat?
No.
No. So use a mean old mycin when you got a mean old infection, and never any other time. So mean old tells you what it treats, mean old infections. The mycin tells you what they end in. Good news. All aminoglycosides end in mycin. They all do. And that's letter C. All aminoglycosides end in mycin. But you know what the bad news is? Not all drugs that end in mycin are aminoglycosides. Rats. Wish that would work, but it doesn't. But don't despair, because most drugs that end in mycin are mean old mycins. There are 3 of the mycins which are not these drugs. And the 3 mycins which are not mean old mycins, are erythromycin, zithromycin, and clarithromycin. What do all the mycins that are not mean old mycins have in them? Thro. So I say, if it ends in mycin, it's a what? Mean old mycin. But if it has throw it off the list. Do you hear what I said? If it ends in what? Mycin, it is a mean old mycin. But if it has throw in it, throw it off the list. It is no longer a what? Mean old mycin. So would you use clarithromycin, zithromycin, and erythromycin for sinusitis?
Yeah.
Yes. Would you use it for tuberculosis? No. Would you use streptomycin for otitis media, sinusitis? No. Would you use it for tuberculosis? Yes. So the mycins are mean old mycins, except the thromycins, which are little old harmless, no big deals. So watch out for your thromycins. They're a little tricky. So if you see thromycin, do what with it? Throw it off what list?
The
The mean old list, so it's just a little old. Some examples: clindamycin, cliomycin, bleomycin, dactinomycin, adriamycin, streptomycin, kanamycin, bleomycin. You know, all these mycins. Now, what are the toxic effects? Letter E. This is what they really key in on. What are the 2 toxic effects? Now, what do all these drugs end in? Mycin. What English word sounds like mycin? Mice. So when you see mycin, I want you to think mice. What is the most famous feature of the world's most famous mouse? Ears. So that's to tell you these drugs are what? When you see mycin, I want you to think of mice. When you think of mice, I want you to think of ears. And when you think of ears, I want you to recall, oh, they are ototoxic. Because oto means what? Ear. Oto means ear. What's ophthalmo mean? Ophthalmo. Eyes. Oto means rhino means nose. Oro means
Mouth.
very good. So what do you monitor? If it's toxic to your ears, what do you monitor? Hearing. Ringing in the ears. What's that called?
Tinnitus.
Yeah. If you're saying tinnitus, that's wrong. It's tinnitus or tinnitus. That last letter is a U, not an I. You see what I'm saying? It's Tinnitus. Tinnitus or tinnitus, not tinnitus. And everybody says tinnitus and it's wrong. I even hear it on commercials on TV. Okay, and vertigo or dizziness. Why vertigo or dizziness?
Equilibrium.
Because the ear also has equilibrium, doesn't it? Balance. So what are the 3 things you worry about with the ear? Hearing, ringing, and dizziness. But if you had to pick between those 3, which one would you pick? Hearing. Hearing would beat the other 2. Okay, number two. The human ear, now that we're thinking ears, why are we thinking ears? Because of mice, right? Because of mycin. Well, here's the human ear. You see the human ear? If we connect the dots, what's it shaped like?
Kidney.
The kidney. So just remember the human ear is shaped like the kidney. So the second toxic effect of these drugs is nephrotoxicity. Nephro, N-E-P-H for kidney. Nephrotoxicity. So what do we monitor?
Urine.
Not urine. They'll have that there, but don't go for it. Creatinine. Don't go for BUN. Don't go for daily weight. Don't go for output. Go for creatinine. The creatinine is the best indicator of kidney function. The creatinine is the best indicator of kidney or renal function. If they told you serum creatinine versus 24-hour creatinine clearance, which one of those would win as the best? The 24-hour creatinine clearance would be better than the serum creatinine, but the serum creatinine would be second best and beat everything else. So you got the 24-hour creatinine clearance, the best indicator of kidney function, serum creatinine number 2, and everything else a distant third. Oh, by the way, I didn't tell you guys. Duh. I don't know why. I knew I was missing something at the very beginning of this whole review. Please feel free to record. Okay, so if you want to record what I'm saying, feel free. Just record away. Okay? So, anyhow. Now, do you see this ear kidney thing here? I want you to have a visual of the number 8 Do you see how the number 8 fits in a kidney real nicely? You see how that shape fits? I want you to remember that the number 8, that's number 3 there, the number 8 drawn inside the ear reminds you of 2 things about these drugs. Number 1, they are toxic to cranial nerve number 8, which is the ear nerve. And you administer them every 8 hours. You don't give them Q6, Q4, Q2, continuous drip. You give them every what? 8 hours. All right, let's turn the page. What's the route? IM or IV? IM or IV is the route. You give these drugs IM or IV. Next point. Do not give these drugs PO because they are not absorbed. Do not give them PO. They are not absorbed. So if you give a oral mycin, what will happen? It'll go into your gut, dissolve, and do what? Go right through, and you're making expensive stool. Because it's not going to be what? Absorbed. And if it's not absorbed, it will have no systemic effect. That's why it has to be given IV or IM. Not because it's going to hurt you, it just isn't going to do anything. Now, except in 2 cases. There are 2 cases where we want to give these mean old mycins orally. And the first case is hepatic encephalopathy, called hepatic coma. Have you heard of liver coma or hepatic coma? I hope you've heard of it, at least heard of it a little bit. It's when your ammonia level gets too high. Do you remember that? The ammonia gets up there and it pickles your brain, and you go into a coma and you could die. Well, what is the treatment goal in hepatic coma? Reduce what blood level? The ammonia. The goal in hepatic coma or hepatic encephalopathy is to get the ammonia down. That's the goal. Well, oral mycins will do that. Because what will oral mycins do? Well, they will dissolve in your mouth, right, in your gut, and go through your gut and kill gram-negative bacteria in your gut. So it will sterilize your bowel. Do you know what the number 1 producer of ammonia in your body is? The E. coli in your gut. And if I can kill the E. coli in your gut, what do I do to the ammonia level? I decrease it. And would that help here?
Yes.
Yes. And because these people have liver damage, we don't want this drug to ever get to their what?
Brain.
Liver.
Or liver.
Because it could hurt the liver. Will it ever get to their liver if taken orally? No. It'll go in one end, sterilize the bowel, and go out the other end. Do you see where this is a perfect drug for this? It's going to kill the E. coli, reduce the ammonia level, and it won't harm the damaged liver because it's not going to be absorbed. It's designer drug. Plus it makes you have diarrhea, which makes you get rid of stuff too, which is double better. The other time they want you to give it is in pre-op bowel surgery. Why would you want to give an oral mycin? Why would you want to give an oral mycin before bowel surgery? Why? To sterilize the bowel. Clean it out. Better than enemas. So for a few days before bowel surgery, what might a patient take? An oral mean old mycin. Will we have any ototoxicity or nephrotoxicity with this? No. Why? It's not absorbed. Now, if it went IM or IV, we would have ototoxicity and nephrotoxicity, but because it's not absorbed, we won't. So in both cases, the hepatic encephalopathy and the pre-op bowel, what did the oral mycin do? It sterilized your bowel, did it not? So what is the number 1 action that an oral mycin will have? Sterilize the bowel. So these oral mycins are called the bowel sterilizers. Now, there are any of these drugs would do it, but there are two of them that are used exclusively for bowel sterilization, and they are neomycin and kanamycin. Neomycin and kanamycin. So what do I want you to remember about neomycin and kanamycin? That they're bowel sterilizers, right? Because that's all they're going to be used for. They're taken orally for the purpose of sterilizing your bowel. So you have, whenever you see neo or can, what should you think of? Bowel sterilization. Now, how do I want you to remember that? I have this. Do you see where it says this? Do you see it says, remember this military sound off? Do you see that? Do you remember, did you ever see or hear or experience a military situation where the troops are marching down the road or jogging down the road and the drill sergeant says, da 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 da, and the troops go, sound off, 3, 4. You know what I'm talking about, like a cadence? Do you got what I'm talking about here? Well, think of this military cadence. It's rather weird, but it'll work for you. The question that the drill sergeant asks, you see the cue there? The question the drill sergeant asks is, who can sterilize my bowel? Okay, who can sterilize my bowel? That's what the sergeant asks. Well, the troops are going to shout something back. In answer to that question, the answer will be, Neo can. Because he said what? Who can? So they say Neo can. Neo what? Mycin and can mycin. So neomycin and kanamycin. So whenever you see neo or can, what should you think? Who can sterilize my bowel? You'll know they are bowel sterilizers, and you'll know what you're talking about. All right? Now, don't look at your book. Don't look at your book. I say aminoglycoside. You say?
Aminoglycoside.
Okay, which tells you they treat what? Renal infections. Like what? Serious, life-threatening, resistant, gram-negative things. They all end in?
Mycin.
Except for the throat. Correct? When you see mycin, you think of what rodent?
Mice.
Which makes you think of?
Ears.
Which tells you they are?
Ototoxic.
So you monitor their hearing, ringing,
Dizzy.
and dizziness. And the ear is shaped like the?
Kidney.
So they are also?
Nephrotoxic.
So you monitor their?
Creatinine.
And what number do you draw in the ear?
8.
So cranial nerve number 8 is damaged, and you give it every?
8 hours.
What route? Do you give it PO? Why?
Not absorbed.
Not absorbed. But if you give it PO, what will it do?
Sterilize your bowel.
What two situations do you want bowel sterilization? Hepatic encephalopathy and pre-op bowel. Who can sterilize your bowel? Neomycin and kanamycin. All right. So do you know those drugs?
Yeah.
Get it from mean old mycin. Okay, so you can know the whole shoot match. There isn't a question they would ask you about these drugs that does not cover. That covers it all. Okay. I had a nurse I was touring Miami Valley Hospital about 4 or 5 years ago, and a nurse comes up to me in the hallway and says, "Who can sterilize my bowel?" And I said, "Excuse me?" And she says, "Who can sterilize my bowel?" And I said, and she says, "Answer the question." And so I said, "Neo can?" And she said, "Yeah, I had your class 1.5 years ago." And I felt like saying, "Honey, you can delete this stuff after this. I mean, you don't have to keep this stuff forever." But evidently it stuck with her. Maybe it'll stick with you guys too. Okay, let's talk about trough and peaks and go on a break. Trough and peak levels there at the bottom of the page. Trough means when the drug's at its what? Lowest, and peak is when the drug's at its highest. I call them tap levels because that tells you the order you do things in. What do you do first? T, draw your trough. A, administer your drug. P, draw your peak. So I teach students tap. trough, administer, peak. So when is the peak drawn? After the administration. When is the trough drawn? Before the administration. TAP. T-A-P. Well, what's the reason for drawing TAP levels? What we call narrow therapeutic window. Have you heard that term, narrow therapeutic window? And that means there's a very small difference between what works and what kills. So if a drug has a very small difference between what works and what kills, what will we draw on them? TAPs. If they have a wide range, will we draw TAPs on them? No. So let me ask you this. What's the smallest dose of Lasix you ever gave or saw given? Lasix, furosemide, the diuretic. I've seen 10, 5 or 10. What's the most you've ever seen? 80, 120. So it goes anywhere from 10 to 120. Is that a narrow or a wide range?
Right.
So would you draw troughs and peaks on Lasix? No. What about DIG? What's the lowest you've given of DIG? 0.125. What's the highest you give of DIG? 0.25. That's only 0.125 difference. That's pretty narrow. Would you do a peak and a trough on a DIG? Yes. So these mean old Misons all have what drawn on them? TAPs, because they have what? Narrow therapeutic windows. Now, I want you to understand, mean old Misons are not the only class of drugs which have TAPs drawn, but they are a major class in which you draw TAPs. Therefore, that's why I'm talking about it here. Do you understand what I'm saying? This discussion of troughs and peaks could apply to a lot of other drugs besides these, but it definitely applies to these. So what boards will want to know is when you draw it, when you draw the trough, when you draw the peak. Good news. You don't even have to know what the drug is, because it depends on the route, which is great. This would be a fantastic question to get a drug you never heard of, because it doesn't matter. The route matters. So if they say, when would you draw the peak on a patient getting L-asparaginase IV push? What does not matter at all? L-asparaginase. What matters? IV push. Okay, so let's talk about this. Troughs. We'll fill in the trough column first. When do you draw a sublingual trough? A trough before. When do you draw the trough before you give a sublingual med? 30 minutes. 30. That's 30. I'm not saying 13. 30. 30. 30 minutes before the next dose. So if the med is being given at 10, sublingually, when do you draw your trough? 9:30. 30 minutes before that next dose. Let's talk about IV. We're going down the column. When do you draw a trough before an IV med? 30 minutes before the next dose. 30 minutes before the next dose. IM, when do you draw the trough? 30 minutes before the next dose. When do you draw a sub-Q? 30 minutes before the next dose. And lo and behold, what do you think the answer is for a PO med? 30 minutes before the next dose. So how hard is a trough question?
Not hard.
Not hard, because it doesn't matter what drug, and it doesn't matter what route. It's always 30 minutes. So how many trough questions do you want on your licensing exam?
Dobbs.
75. And LPNs, you want 85.
Yeah.
Because you're going to ace it. So don't sweat it. Great place. Other people are going to be sweating bullets and you're going to be laughing. Okay, the peak. Now, sorry to say, the peak is going to change. It's not going to be like the trough. But here again, it won't depend on the drug. It will depend on the route. Because I'm going to say something that is correct. Do not write this down, but this is true. The same drug given by two different routes at the same time will have two different peaks. I give PO morphine and IV push morphine at the same time. I'm going to have two peaks. One for, it's the same drug. However, two different drugs given at the same time by the same route will peak together. Morphine and Phenergan. two different drugs given IV, same route, at the same time will peak together. So what determines the peak, the drug or the route? The route. So always pay attention to the route. So let's talk about it. When do you draw a sublingual peak? 5 to 10 minutes after the drug is dissolved. 5 to 10 minutes after the drug is dissolved. IV, 15 to 30 minutes after the drug is finished. Why did I say finished? Not when you what? Hang it. You don't start your clock when you hang it. You start your clock when it's finished. When the bag is empty. Then you go 15 to 30 minutes after that. What if they told you you were going to give... Sorry, didn't mean to slam on that. You're going to give 100 mil of a drug at 200 mil per hour. You understand that? You're going to give 100 mil at 200 an hour. So how long is that going to take to run in?
30 minutes.
30 minutes. Okay, you hang it at 10 a.m. So when's that going to finish? 10:30. When would you draw the peak?
10:45.
Well, they say A, 10:15.
No.
B, 10:30. C, 10:45. Yes. D, 11 o'clock. Yes. They do this all the time. Two right answers. Right, one's 15 after it's in, one's 30 after it's in. It's in the, isn't that the range?
Yeah.
Which one are you supposed to pick? 11. Whenever you get two in the same correct range, whenever you get two values in the range and they're both correct, play the Price is Right. Who wins on Price is Right? Highest without going over. So who's the highest here without going over? 11. And that's who wins all the time. For example, just to show you how this works in every case. Do you remember antidepressant meds? Antidepressant meds? How long does it take the typical antidepressant med to work? 2 to 4 weeks. 2 to 4 weeks. If boards told you that the client had been on it for 1 week already, got it? It's been on it for 1 week already, and they're saying, it didn't work and it didn't help and I feel horrible, what would you teach them? A, it may take another week to work. Is that true? Might it?
Yes.
Yes, that's the 2. And then B says it may take 3 more weeks to work. That's also true. So you got 2 right answers, 1 week and 3 weeks. Which one wins? 3 weeks, because you picked the highest without going over. When would a child be able to be potty trained during the night? 3 years or 5 years? Well, that's 3 to 5 years. Nighttime potty training for urine. So what would be your answer? 3 years or 5 years? 5, and you'd be right. Do you see what I'm saying? So always, whenever you're sitting there and you have 2 right answers, they both are correct numbers, pick the highest without going over. And that will always win. Okay, that's not just on this, but on everything. Okay, the IM. The IM is 30 to 60 minutes. You draw the IM peak 30 to 60 minutes after you give it. So if you were between 30 and 60, what would you pick? 60. See, they love to test this. You gave an IM Demerol for pain. When would you check them for relief? In 30 minutes or in an hour? Well, it's going to peak in 30 to 60. So it's either going to pick in 30 or 60. What would you say? 60. Yeah, because you want to give it enough time. You see what I'm saying? You could check them in 30, but you should at least check them within an hour. Okay, sub-Q. Here I want you to write the word SEE. C, S-E-E. C diabetes lecture, which we'll talk about tomorrow. Because the only subcutaneous peaks they talk about are the insulins. And we'll just talk about it then, okay? They don't talk about terbutaline, sub-Q, or anything like that. And then in the PO box, put forget about it, because they don't test PO peaks. It's all too variable. All right, to come back at 7:20, and we'll finish up for the day. Page 11, calcium channel blockers. Another top 10 group of drugs. But the good news about this one is there isn't a whole lot you need to know. You just have to know some basics about these heart drugs. Somewhere in the margin of this lecture, I want you to write the following. Calcium channel blockers are like Valium for your heart. Calcium channel blockers are like Valium for your heart. Now, why would I say that? I think that makes it easy for you to remember what they do. Because what does Valium do for your body and for you in general? What's it do? Calms you down. So what do you think calcium channel blockers do to the heart? They calm it down. So if you get a question about a calcium channel blocker, think, oh, that's going to calm my heart down. That would be just like giving my heart some Valium. Now, did I say it was Valium? No, it's not Valium. It has nothing to do with Valium. But it's like Valium for your heart. So if your heart is tachycardic, could it stand a little relaxant?
Yes.
So what class of drug could you give? Calcium channel blocker. If you're in shock, does your heart need to relax when you're in shock? No, you need it needs to get cooking here. So would you give a calcium channel blocker? No. If your heart was in heart block, would you give a calcium channel blocker? No. If your heart was having tachyarrhythmias, would you give a calcium channel blocker? Okay, so if you had a heart attack and you wanted to rest your heart, what would you give? Calcium channel blocker. So calcium channel blocker is given when you want to rest your heart. When your heart needs stimulated, please don't give a calcium channel blocker. That's not a good idea. So this is like Valium for your heart. Now, how do we say that really fancy? The way we say that fancy is the following. You see here where it says letter A, calcium channel blockers are negative inotropic, chronotropic, and dromotropic. When you see the fancy words negative inotropic, negative chronotropic, negative dromotropic, don't freak out. All that's saying is what? It's like Valium for your heart. So negative inotropes, negative chronotropes, negative dromotropes relax your heart. They calm it down. Now, the chart below shows you the difference between the positive inotrope, chronotrope, dromotropes and the negative inotrope, chronotrope, dromotropes. What do positive chronoinodromos do? Look down through there. What do? They strengthen, speed up, stimulate. So they are called what? Cardiac depressants or stimulants?
Stimulants.
And negatives are cardiac depressants. So a positive inochronodromotrope is a cardiac stimulant. A negative inochronodromo is a cardiac depressant. Do you see the difference? In that chart, which column should you highlight in this lecture because it applies to the calcium channel blockers? The last column. So circle and highlight the last column because that's where calcium channel blockers fit into the picture. They are negative inochronodromotropes. They weaken, slow down, and depress the heart. Letter B. When would we want to do that? What do they treat? Well, they treat A, AA, and AAA. The letter A is your friend here. A, AA, and AAA. Well, what does A stand for? Number one, they are antihypertensives. They are antihypertensives. How does that work? They relax your heart and blood vessels. And if you relax your heart and relax your blood vessels, what does your blood pressure do? It goes down. Does that make sense? If your blood pressure was high, would you take a Valium for your heart or a stimulant for your heart? If your blood pressure is high, would you want a Valium for your heart or a stimulant for your heart? Valium. And that would mean you'd use a calcium channel blocker. Do you see what I'm talking about? Okay, the second AA stands for anti-anginals. They are anti-angina drugs. Well, how does that work? It's going to relax your heart so it uses less oxygen, so there goes the angina away. It works by decreasing oxygen demand. It treats angina by decreasing oxygen demand because it relaxes the heart. What's the worst thing in the world for a person with angina? What's the worst thing that can happen to a person with angina? With their heart. What's the worst thing that can happen to their heart in a person with angina?
Speed up the heart.
Speed up. Speed up. And then it has problems. So we want to do what to the heart?
Slow it down.
AAA. Anti-atrial arrhythmia. Anti-atrial arrhythmia. So what does it treat? Will it treat ventricular tachycardia? No. Why? Because that's ventricular, and this only treats atrial. Will it treat atrial flutter?
Yes.
Atrial fibrillation?
Yes.
Premature ventricular contractions?
No.
Premature atrial contractions?
Yes.
Paroxysmal atrial tachycardia?
Yes.
Atrial bigeminy?
Yes.
Ventricular bigeminy?
No.
Huh. Hey, how I say that? I love medical transcriptionists that don't know what they're writing. We always have fun reading those charts on night shift. I remember one time I was working nights, I was cracking me up. We were reading this guy's history and physical, and the doctor dictated it, and the transcriptionist wrote out the history and physical, and they make mistakes. She said that this guy had this guy has ventricular bigeminy. I go, whoa, that's cracking me up. That's funny. It's a lot of fun. Okay. So all you have to know what arrhythmias this treats is to know if it starts with what letter?
A.
A. And if it's an A, it's yes. And if it's a V, it's no. What? There's a trick. What about this one? Supraventricular tachycardia, SVT. Would calcium channel blockers treat SVT? Yes or no? How many say yes? You're correct. Yes. Why? What does supra mean? And what's above the ventricles?
Atrial.
Boom. So it's supraventricular is the only ventricular which is actually saying atrial. Does everybody get that? Otherwise, you're good to go. Because it treats A, AA, and AAA. Well, what are the side effects? H and H. The letter H is your friend here. Headache and hypotension. Headache and hypotension. Why hypotension? Because it relaxes the heart and the blood vessels. Why the headache? Because you get vasodilation in the brain, and that gives you like a migraine. By the way, headache is a great thing to check on a Selectol that apply. Because what do you have with low sodium? Headache. What do you have with a high sodium? Headache. What do you have with a high glucose? Headache. What do you have with a low glucose? Headache. What do you have with high blood pressure? Headache. What do you have with low blood pressure? Headache. You know, I mean, headache's pretty I'm going with headache. Okay, names of calcium channel blockers. Names. Anything ending in dipene. Anything ending in dipene. Amlodipine, nifedipine, the dipenes. I always say you're dipping in the calcium channel. Not pene. Why not pene? Why do I not want you to memorize everything ending in pene? Because there are loads of drugs that end in pene that are not these. It has to be a dipene. Dipene. Dipene is your calcium channel blocker ending. And then there are two others you have to know by name. Verapamil and cardizem. Verapamil and cardizem. So the dipenes, verapamil and cardizem. Dipenes, verapamil, cardizem. Those are your calcium channel blockers. Which of those is continuous IV drip? Can be given to cardizem. So when you give a calcium channel blocker, now think about this. When you give a calcium channel blocker, what vital sign do you need to measure before you give it?
Blood pressure.
Why? What's the side effect?
Hypotension.
Hypotension. So you measure the blood pressure. What are your parameters? What are your guidelines? You get a blood pressure. So what? What are your guidelines? How are you going to use it?
It's below 60. Or no, wait a minute, I'm thinking the heart.
You're thinking pulse rate. You're thinking pulse rate.
over 60.
Not that. Okay, which one? Yes. Hold the calcium channel blocker if the systolic, that's the top number, is under 100. Take the blood pressure, or measure, don't take it, measure it. Measure the blood pressure, and if the systolic is under 100, then you hold the calcium channel blocker. So what do you have to monitor continuously or fairly quickly, intermittently, while they're on a cardizem drip? The blood pressure. And there again, if it was 98/52, what would you do? What would you do with the drip? Slow it down, measure it again. So you titrate. Do you know what I mean by titrate? Change the IV rate to keep the blood pressure what? Systolic over 100. LPNs, they would say if somebody's on a cardizem drip, you notice all the following. Which one would you report to the RN? It's a systolic falling below 100. Same information, just ask from a different perspective. Okay, cardiac arrhythmias. The ones we're going to do for the rest of the night are short, so that as the day goes on, your brain gets more spaghetti-like, and I just want to keep it faster so you don't get no big long ones in the middle of the night. Cardiac arrhythmias. Knowing how to interpret rhythm strips. Now, turn to page 13, the next page down. Next page. Do you see at the bottom of the page there are 4 rhythm strip tracings? These are the 4 you must know by sight. You have to know these by sight. The first one is normal sinus rhythm. How do you know it is normal sinus rhythm? There's a P wave, a QRS, and a T wave for every single complex. There's a P wave before every QRS, and every QRS is followed by a T wave. But what else tells you it is normal sinus rhythm? Do you see the peaks of the P waves? How equally distant they are from one another? That tells you you're not dealing with something called a sinus arrhythmia. So that is normal sinus rhythm because there's a P for every QRS and the QRS complexes are evenly spaced. When you see that, that's normal sinus rhythm. It doesn't really matter if they go up or down. Do you know what I mean? You could have a P wave going up, QRS going down. That's okay. That's still normal sinus. The second one is VFib, ventricular fibrillation. It is a chaotic, squiggly line. The third one, it looks like a 1970s wallpaper border. That's VTAC, ventricular tachycardia. It's got those sharp peaks and jags. Is there a pattern? Yeah. Is there a pattern with ventricular fibrillation? No, there's no pattern with VFib. There is a pattern with VTAC. And the last one is called what? Asystole. Please don't miss that one. Honestly, don't miss it. I mean, you're going to go down on that one. Big time. Crash and burn time. Okay, let's go back to page 12 now. Now, I just want to hit those right out the gate. Now, could they show you Wolff-Parkinson-White syndrome? Yeah. But why do I not teach you that?
You don't need to know it.
You don't need to know it. But you said, but Mark, you said if they show it to me, don't I need to know it? What's the answer? No. What do you need to know? You need to know the answers to the questions that everybody else knows. And everybody else knows what asystole looks like. And everybody else knows what VFib looks like. And everybody else knows what VTAC looks like. And everybody else knows what normal sinus looks like. Nobody else knows what Wolff-Parkinson-White syndrome looks like. So if you miss that, it doesn't hurt you. You understand these questions are all given degrees of difficulty? So do you have to get every question right? No. What questions do you have to get right? The ones that everybody knows. The easy questions. You can miss every single hard question on the boards and pass with flying colors. Do you understand what I'm saying? So what I want, why do I teach you what I teach you? I want to teach you the stuff that everybody knows. So that you real quickly get correct the answers to the questions that everybody else knows, so that real quickly you get to what kind of questions? Hard ones that no one knows. Now you're going to feel how? Horrible, because you don't know any of this stuff. But that's good. Do you know what I'm saying? My goal is to, as fast as I can, get you to the hard questions. The questions that nobody else knows, including you. So that you feel really stupid. Do you see what I'm saying? I want halfway through this test, I want you to be going, what? What is that drug? What disease is that? What are you talking about? Who's that? What's this? You know, because you understand, you don't have to know everything. You just have to know what everybody else knows. What a little less than average. And so we're not going to, that's what kills me about a lot of these review books. A lot of these review books have all these rhythm strips in it, which is ridiculous. And these people have to memorize these rhythm strips, like 50 of them. And only 4 of them really are going to hurt you if you don't know. So why do those other books put those rhythm strips in their review? Why do they put them in there? Because they what? Heard that they're on there. They heard that they're on there. And so they what? They heard that something's on there, so what do they do immediately in their book? They throw it in, and their books get what? Thicker and thicker and thicker. My books are what? Thin. Let's focus on the stuff you need to know, and not the crazy stuff. I always say there's 3 levels of nursing knowledge. Stuff you need to know, stuff that's nice to know, and stuff that's nuts to know. And most of nursing books are made up of nuts to know.
Yes.
Have you ever asked a teacher, just tell me what I need to know? And they say, well, read the book and the notes. Well, that's helpful. Well, part of what you're paying me for is to take all of that's in those books and narrow it down to this. So that if you know this, you know what everybody else knows. And soon you'll get to stuff that no one knows. You won't know everything, but hey, that's cool. So don't think you have to know everything. Because if you try to learn everything, you'll master nothing. Did you hear what I said? If you try to learn everything, you'll master nothing. And that's what students do. They just try to learn more. No, more isn't the solution. Okay? Focusing on what you really need to know and then how to apply it. That's what we're talking about. Okay? Back on page 12A, terminology. Whenever the question says QRS depolarization, it's talking about ventricular. If it says blankety blank, 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 QRS depolarization is blank, 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 you can always narrow it down to one of two. Both of those would say what word? Ventricular. You can rule out anything that says what? Atrial. If you see QRS, you can rule out anything that says ventricular, atrial, and go with what's ventricular. However, number two, if it says P wave, that will refer to something atrial, and you can rule out anything ventricular. Unless they say a lack of a P wave. Well, I mean, that's not really talking about a P wave. All right, let's use that to answer letter B, the 6 rhythms most tested on NCLEX. Number 1, they will use this phrase, a lack of QRSs. There are no QRSs. 0. None. What do you think that's called? Asystole. That's a flat line. That's asystole. Number 2 has to be a form of what?
Atrial.
Atrial. Why does it have to be atrial?
That's P wave.
Said P wave. And when you see sawtooth, you always pick flutter. Flutter is always described as sawtooth. I always think of the movie Jaws. I saw the teeth and my heart did flutter. Sawtooth, flutter. Numbers 3 and 4, do you notice that they have the same adjective, the word chaotic? Chaotic is always the word used to describe fibrillation. Fibrillation. So what is number 3? How do you know it's atrial? And what's number 4? Ventricular fibrillation. How did you know it was ventricular? How did you know it was fibrillation? Chaos. These are the words they use. Okay? What is number 5? Some form of what? Atrial or ventricular?
Ventricular.
How do you know it's ventricular?
QRS.
QRS. And when it says bizarre, bizarre always applies to tachycardia. Bizarre is the word they use for tachycardias. Chaos is the word they use for fibrillations. Don't get that confused. Chaos is for fibrillations. Bizarre is for tachycardia. So if you put 2 and 2 together, what is number 5? Ventricular tachycardia. Do you see how this can be easy if you just know your words?
Why did they do that?
What's that?
Why did they do that? Why did they put chaotic then? Why did they do that?
Why
How
did
would
they-
we know that?
Oh, why didn't they teach you that?
I mean, why did they put that in the HESI test? Why did they put those words in there?
They did. They did. You mean they?
I mean, yeah, why do they? They are, I mean, they're trying to mess us up?
No, actually, what they're doing is they're seeing if you know what those words mean. You see what I'm saying?
So we were supposed
Do you
to be
know
taught.
what chaos means?
Somewhere along the line, we should have been taught this.
Yes. Somewhere
we
along the
weren't.
line,
And we weren't.
you should have been taught
Not
that chaos was fib, flutter was sawtooth, bizarre was tacky, QRS was ventricle, P wave was atrial. You see what I'm saying? You should have been taught that.
Wow.
Okay. Well, what about a periodic wide bizarre QRS? That's a PVC. Why is it ventricular? And why is it wide and bizarre? Because it's like one snapshot of a tachycardia. Right? It's just one piece of tachycardia. So, is it possible, could you call a salvo of PVCs, you know, a salvo of them, a group of them in a row, a salvo of them, what else could you call it? A short run of VTAC, couldn't you? Because it's the same idea. Now let me ask you this. Do physicians care about people having PVCs? Generally speaking, no. How high a priority is a client with a PVC? If you had to prioritize 4 clients and one of them has PVCs, how high would you prioritize that guy? Low, moderate, or high? Low. All right? Now, under 3 circumstances, you could elevate that person to moderate. Not high priority, just moderate priority. And here's the list right here below. If there are more than 6 PVCs in a minute, or more than 6 PVCs in a row, or if the PVC falls on the T wave of the previous beat. That's called R on T phenomenon. If one of those is true, you elevate the priority of your PVC client to moderate. So PVCs never reach what level? High. They never reach high. The most a PVC client can reach is moderate, and that's if there's more than 6 in a row, 6 in a minute, or falling on the T wave. Otherwise, how high do you prioritize your PVC patient? Low. Isn't it true that after an MI, after a heart attack, if they're having PVCs, what do you know? Is that good or bad? That's good. So actually it means they're reperfusing. So that it doesn't raise their priority, it even lowers it, because they're doing great. So anybody ever work coronary care or telemetry? If you call physicians in the middle of the night to tell them that the patient is having PVCs, what is the most common order you will receive?
Don't ever call me again.
And how will they say that?
Hang up.
Discontinue the monitor. They'll tell you to DC the monitor. Why? Because if you don't have the monitor, you can't see the PVCs. And if you don't see the PVCs, you won't call them. So you learn real quick, you know. Don't call a doctor about PVCs unless you want to lose your monitor. Okay? All right. Lethal arrhythmias. How high a priority are these? Moderate, low, or high? These are high priority. There are 2 of them that are super high priorities. They're lethal, meaning they will kill you in 8 minutes or less. The first one is asystole. Right? If you're asystolic, you got 8 minutes, or that brain's gone. V-fib is also the lethal one. What do asystole and V-fib have in common? No cardiac output. And if you've got no cardiac output, you do not have brain perfusion. And if you don't have brain perfusion, you're dead in 8 minutes. So if they give you 4 patients and one of the patients has asystole or V-fib, how high do you prioritize that patient? They're probably number 1. Probably number 1. Letter D. One of these arrhythmias is a potentially life-threatening. It is not life-threatening. It is only potentially life-threatening, but that still makes it a fairly high priority. And that is ventricular tachycardia, VTAC. So therefore, what is the difference between VTAC and the asystole V-fibbers? VTACers have a cardiac output. So that makes all the difference in the world. Were you ever in a code situation and they're given drugs or something and the rhythm changes? On the monitor, the rhythm changes because of something they did. What's the first question the doctor will always ask? What's that? Do you get a pulse with that? Why? What are they asking? Is there a cardiac output with that? You see? And so even if the rhythm changes to something that looks good, if there's no pulse, there's no cardiac output, it's just as bad as what was there before. Okay? All right. Turn the page. Let's talk about treatment of these problems. Treatment, yes.
On that number 6, where periodic is underlined, is periodic mean PVC then?
Yes.
Okay.
Because it's not a continuous phenomenon. It's only occasional. Okay, let's talk about the treatment. The first 2 are PVCs and VTAC. They are both ventricular, correct? Do you see this? See my fingers? What letter do they make?
V.
A V. For ventricular, now watch what happens. For ventricular, use, what letter is that?
L.
Lidocaine. For ventricular, use lidocaine. For ventricular, use lidocaine. So I always tell people to remember that. Ventricular lidocaine, ventricular lidocaine. Now I know that lidocaine is not used in a lot of squads now in the bigger cities because they're using amiodarone. But boards is going to talk more about lidocaine. After April 1, it would be amiodarone. Amiodarone. So I guess after April 1, I'm going to have to say, see the V for ventricular? Amiodarone. No, I'll have to get something else. Why do squads in rural areas still stock lidocaine instead of amiodarone or VTAC and VFib? I mean VTAC and PVCs. Yes, it's like 1/10 the cost and has 4 times the shelf life. So why would you buy a super expensive drug that's going to expire in 3 weeks when you won't use it that much? But if you work squad in Franklin County, you're going to use it up so fast, might as well have amiodarone. But if you work Vinton County or something like that, you good luck. Amiodarone is going to spoil before you ever use it. Okay, supraventricular arrhythmias. What's that a synonym for? Supraventriculars. Atrials. For atrial arrhythmias, use the ABCDs. Atrial starts with what letter? A. So remember the ABCDs of atrial treatment. So for ventricular, you use what? Ventricular, use lidocaine. For atrial, use the ABCDs. So what are the ABCDs? A stands for adenocard. ADENOCARD, adenocard. ADENOCARD, adenocard, which is adenosine. This is the one you have to push in less than 8 seconds. So is it a fast or slow IV push? Fast. Now, why do I bring that up? Well, here's why I bring it up. The reason why I bring it up is when you're talking about IV push, when you don't know, you go slow. You heard that? When you don't know, you go slow when you're pushing. Now, I'm worried because you go, oh, I don't know adenocard, so I'm going to what? Slow. No, this is the one you gotta know. It's the super fast. You got 8 seconds. They call it slamming. Have you ever heard of that? You gotta slam this drug. You gotta push it in 8 seconds, and then the other nurse pushes 20 milliliters of flush right after it. So you're going wham, and they're going wham. So you gotta use a big vein. You can't use one of these. You have to use what we used to call it the intern vein. Something so big an intern could hit it. So we used to use the intern vein, one of those big ones. Now the problem with this is when you slam it fast, what could they go into? Asystole. And they could go into asystole for about 30 seconds. But they'll come out of it. You just have to trust. They'll come out of it. They really will. It's kind of scary. 30 seconds of asystole is scary. But what do? Sit there, relax, they're going to be okay. So what's the big thing you have to know with adenocard? Push it fast and don't worry about asystole. Oh, unless it's longer than 30 seconds. Okay, B. B stands for beta blockers. Beta blockers. And what do all beta blockers end in?
LOL.
LOL. Yes. They all end in LOL. LOL. Timolol, atenolol, nadolol, carvedilol, bredolol, propranolol. Those are all beta blockers. This is the best class of drugs, best named class of drugs in the universe. Every drug that is a LOL is a beta blocker, and every beta blocker is a LOL. It's great. every drug should be that way. Yeah, I always used to say, when we were in school, we used to do stupid things. You see that right there? That's baby beta. See the little curly Q? Actually, in bigger, it would look like this. Yeah, that's baby beta, and she's what? Blocked in. She can't go either way. Beta blocker. So, LOL, beta blockers. Now, beta blockers are negative INO, negative chrono, negative dromo. Negative INO, negative chrono, negative dromo. So they're like what? And so they're like Valium for your? So they'll treat A, AA, and AAA. And what are we talking about here? AAA, anti-atrial arrhythmia. Correct? So what will beta blockers have as a side effect? Headache and hypotension. Just like the calcium channel blockers. So don't make a big difference between calcium channel blockers and beta blockers, generally speaking. The only thing is that calcium channel blockers are better for people with asthma. Because beta blockers, broncho, constrict. So people that have other diseases like COPD probably should be on a calcium channel, although a beta does all the same things and has all the same side effects. Oh, and so therefore, what's the C? Calcium channel blockers. Because beta blockers and calcium channel blockers are like Valium for your heart. They're negative INO, negative chrono, negative dromo. They treat A, AA, and AAA, and they have the side effects of H and H. Both of them. The D stands for digitalis. Digoxin, Lan-oxin. You have to know these names because they will only give you one name for this drug. They'll say Lan-oxin. You're supposed to know that's digitalis. They will not give you both. If you do not know that Lan-oxin is digitalis, you don't know what everybody else knows. So know it. So what are the ABCDs of treating atrial arrhythmias? Adena, beta, calcium, dig. Adena, beta, calcium, dig. Adena, beta, calcium, dig. Adena, beta, calcium, dig. Those are the ABCDs of atrial treatment. So what do you use for ventriculars? Lidocaine. What do you use for atrials? Adena, beta, calcium, dig. The ABCDs. All right. Okay, what do you use, number 4, what do you use for VFib? It rhymes. For V-fib, U-D-fib. For V-fib, U-D-fib. In other words, what's D-fib mean? Shut up. And asystole, what do you use for asystole? Epinephrine and atropine. Epinephrine and atropine. In that order. What's the first one you give? Epinephrine. Then if that doesn't work, you give atropine. Now, the way I remember this is, look at the word asystole. All right? What's the first letter? A, which stands for atropine. What's the last letter? E, which stands for epinephrine, but give it reverse. So A for atropine, E for epinephrine. What I do is I always do this. Asystole, atropine, epi. And I have that, you see this visual? I sort of have this visual of it coming down, and then I just go, give it opposite. So what do you do for VFib? What do you do for VTAC and PVCs? What do you do for atrial flutter and atrial fibrillation? Adena, beta, calcium, dig. What do you do for asystole? Epinephrine and atropine. Very good. If you know that, you know more than what most people know about those emergency things. Okay, let's talk about chest tubes. The purpose of a chest tube is to reestablish negative pressure in the pleural space. reestablish negative pressure in the pleural space. So the pleural space is a place where negative is good. Because don't we tend to think of negative as bad? But negative is good in your pleural space. Negative makes things stick together. Got me? Okay, what's your name? You're Shauna. Okay, Shauna and I are going to demonstrate some things. I will try this thing out first. Shauna is the chest wall. I am the lung. She is the chest wall, I am the lung. Now, we're actually three-dimensional, although we're only showing you a one-dimensional picture. There's actually, you know what I'm saying? Everybody get the cross-section here we're looking at? Okay, so she's the what? I'm the, okay, what's out here? Atmospheric air, right. So this is skin and bones and muscles, right? And then I'm a what? Lung, and what's in here?
Air.
The what? The alveolus. I can't make 3 of them at once. I know you're used to a picture with 3, but I can't do that. Okay, that's the alveolus. Are you getting the picture? Now, on the inside of the
Chest wall.
is a lining called the parietal pleura. So this is the what? Parietal pleura. It lines the inside of the chest wall. Okay, now on the outside of me, there's another lining. What's this called? Visceral pleura, and it lines the outside of the lung. Between the
Chest wall.
parietal pleura and the pleura is the pleural space. So we got this space here called the what? Pleural space. Now, what kind of pressure should be in there? Negative. Now, what does negative pressure do to things? Pull them together or push them apart? Negative. Pull together like a vacuum. Positive pressure pushes things away. So, what are we going to do here? If there's negative pressure in here, what's going to happen? We're stuck together. Because there's what? Negative pressure in the pleural space. Now, how is this going to work? Okay, we're going to breathe in. Now, when we breathe in, the chest wall expands outward. Okay, so we're going to take a few steps out that way. So now we're going to breathe in, and you watch the air going into the what? Alveolus. Okay, here's the air. Now, ready? Let's breathe in. Oh, what happened to the air? Came in. Now let's breathe out. Did you see? Now let's breathe in again. Now let's breathe out again. All right, now there's good what? Air exchange because there's
Negative pressure.
and the. Okay, now take your gun and shoot us. She's got a silencer on. Bang! Okay, a bullet comes. Now what has entered the pleural space? Air and blood, creating what? Positive pressure, which is going to do what to us? Push us apart. Okay, now I want you. So we're no longer what? Stuck together. She has muscles. What don't I have? Muscles. She does the work of breathing. I just hang along for the ride. Now, what we're going to do is, now that there's positive pressure in here, I want Shauna to breathe in and then breathe out. And I want you to watch what happens to the air exchange. Okay, breathe in. Breathe out. Breathe in. Breathe out. What's happening? She's doing a lot of what? Work. But there's no air exchange because there's positive pressure in the. Okay, now take that chest tube you have there in your hand. You know, pretend you're sticking it in here. Okay. Now give me some suction. Okay. Now what did we just do? Re-established negative pressure in the pleural space. So now she can breathe in, breathe out, breathe in. Now we heal, and what does she do? Pulls out the tube, and we're good to go. Thank you. Very good. Very good. So she's going to sit in the back from now on. So what's the purpose of a chest tube? reestablish negative pressure in the pleural space so that the lung expands when the chest wall moves. Is that making sense? Why you need that tube in there? Okay. Now, when you get a chest tube question, look at the reason for which it was placed. Letter A there, number 1, says in a pneumothorax, the chest tube removes what? Air. Pneumo means air. So in a pneumothorax, what created the positive pressure? Air. So I've got to put a chest tube in to remove air so I can reestablish the negative pressure. Okay, but in a hemothorax, the chest tube removes blood, because what's causing the positive pressure? Blood, and I got to remove it to reestablish the negative pressure. And in a pneumohemothorax, what's in the pleural space? Air and blood, and I must remove both air and blood to reestablish the negative pressure in the pleural space. So if Boards gives you a question and says that you have a patient with with chest tubes in for a hemothorax, what would you report to nurse LPNs or doctor RNs? What would you report to the nurse or the doctor? Number 1, the chest tube is not bubbling. 2, the chest tube drained 800 ml in first 10 hours. The chest tube is not draining. The chest tube is intermittently bubbling. Well, you have to say to yourself, what do I expect from a hemo? What does a hemo chest tube put in for a hemothorax? What's it supposed to do? Drain what? Blood. So, which one of these says it is not doing what it is supposed to do? Number 3. So which one would you report to the nurse or the physician? Number 3. Because it is not doing what it is supposed to do. Do you see what I'm saying? But what if I said this? A pneumothorax. What would you report to the physician? Well, you could have 2 of them. What would they be? 1 or 2, right? What's wrong with 1? It needs to bubble. It's not doing what it's supposed to do. What's wrong with 2? It's doing something it's not supposed to do. And in that case, it would be a hard, do you see what I'm saying? It would be a hard one to do. But the point is that, do you see how that, it definitely wasn't number 3. Do you see when I changed? Did you see that when I changed from a hemo to a pneumo, what was the right answer is no longer even an option for the right answer. So if you're going to get chest tube questions correct, what must you pay particular attention to? The disease for which it was placed. And that will tell you what you should expect. Does that make sense that you're going to have to watch that? Otherwise, you wouldn't get it right. Okay, the other thing you have to pay attention to is letter B, the location of the tubes. The location of the tubes. And the 2 locations are apical, A-P-I-C-A-L, and basilar, B-A-S-I-L-A-R. Apical, number 1 is apical, A-P-I-C-A-L. And number 2 is basilar, B-A-S-I-L-A-R. Apical and basilar. Now, apical means the chest tube's way up high. And if you put a chest tube way up high, what are you going to remove? Air, because air rises. So apicals remove air. Basilars are at the bottom of the lungs, so they will remove what? Blood, because blood is subject to gravity. So apicals remove air, basilars remove blood. A for A, B for B. What do I mean by that? Apical starts with A, and that removes air, which starts with A, and basilar starts with
T
and it should remove.
blood.
So if they say your apical chest tube is draining 300 milliliters per hour, your apical is draining 300 per hour, what do you think? Good or bad? Bad. Your basilar is draining 200 mils per hour. Fine. It needs to come out. You know? Your apical tube is not bubbling. Your apical tube is bubbling. Your basilar tube is not bubbling. Fine. Your basilar tube is bubbling. Why? You know what I'm saying? So do you see where location depends? So what will they put in for a hemo? What will they put in for a pneumo? And what will they put in for a pneumohemo? One of each. Which brings up the next three questions. Examples. How many chest tubes and where would you place them for unilateral pneumo, hemo, thorax? Unilateral pneumo, hemo. Two. You'd use a apical for the pneumo and a basilar for the hemo. B, how many chest tubes and where for a bilateral pneumo? Again, how many? Two. But what would they both be? Apicals. You'd use an apical on the right and an apical on the left. Then letter C, how many chest tubes and where would you place them for post-op chest surgery? Here again, two. An apical and a basilar on the side of the surgery. Because you are to assume that chest surgery or trauma is unilateral unless otherwise specified. So if they just said he had chest trauma, would you assume it's unilateral or bilateral? Unilateral. Chest surgery, unilateral or bilateral? Unilateral. You always assume unilaterality. Never assume that it's bilateral. So the only time you're taking care of bilateral is when they say bilateral. Alrighty? Oh, there's a trick question though about chest tubes. How many chest tubes would you need and where would you place them for a post-op right pneumonectomy? None. Why? Pneumonectomy means removal of the what? Whole lung. There's no lung, there's no pleural space, there's nothing. So if there's no pleural space, why do you want to reestablish pressure in something that does not exist? Correct? So you do not use chest tubes for pneumonectomies. You use them for lobectomies, wedge resections, those kinds of things. All right, turn the page. Let's talk about troubleshooting. Do you guys remember seeing closed chest drainage devices like a Pleurovac, Thoravac, Pneumovac, Emerson? And they're those plastic containers that the tube is connected to. Well, what do you do if you knock that over? I mean, you didn't break it, you just knocked it over. What do? Set it back up and have them take some deep breaths. Is it a medical emergency? Does the physician need call? Does the RN need notified? Do you need to do anything other than have them take a couple deep breaths? No. It is no big deal. Do you understand that? So do not get all uptight when you knock over that device. But number two, what do you do if the water seal breaks? The actual device, that device breaks. Now, is that the same thing as we were just talking about, or is this something totally different? Totally different, because now positive pressure can get in the pleural space. So what do? Let's say you break it. What do?
Clamp it.
Clamp it. That's the first thing you do is clamp it. Why? So nothing gets in. Then what do you do next? Well, there's a couple of steps they're going to put in between there. Clamp it.
Put it in sterile water.
There's a step before that. That's the third step. Clamp it. It's too obvious. Cut it away from the broken device. You know, take your scissors and cut that tube away from that broken device because it's no good anymore, right? So cut it all away. Then, what do you do to the end of that tube then that's been cut away? You said it in the back here. Stick that end of that tube under sterile water, okay? Now, what are you going to do next? Unclamp it. Why unclamp it? Because now you've reestablished the water seal. Do you understand? It doesn't need clamped as long as it's under water. And it's better to be underwater than to be clamped. Why is it better to be underwater, the end of the tube underwater, than for the tube to be clamped? Why is it better?
Sterile.
No, not sterile necessarily. Air can't go in, but stuff can come out. If it's clamped, what's the problem? Nothing can go in or out. And you want stuff to come out. You don't want stuff to go in. So clamping is only a stop-gap measure. It doesn't solve the problem. What solves the problem? Sticking the tube underwater. So what is the order? If they gave you a click and drag, when the water seal breaks, what would be the first thing you'd click and drag? Clamp, then what? Cut, then submerge, then unclamp. It's alphabetical. Clamp, cut, submerge, unclamp. Clamp, cut, submerge, unclamp. That is your order. So if they said to you, what is the first thing you're going to do when the water seal breaks? The first thing, what will you pick? Submerge the end of the tube underwater or clamp the tube? Clamp. Because when they say first, they're asking about what? Order, right? But what if they say this? They ask you the exact same question with the exact same answers, and they change one word in the question. The word they change is from first to best. And they say, what is the best thing to do when the water seal breaks? What is now the answer? Submerge it under sterile water, the tube under, the end of the tube underwater. Why is it the best? Because it actually solves the problem by reestablishing the water seal. The clamping was only what? A temporary fix. It's not the best, it's the first, but it's not the best. So do you understand that a best question is different than a first question? Very different. A first question is asking you all about order. A best question is asking you what's the one thing you would do if you could only do one of these. So if you could only do one, clamp it and nothing else, or put it under the end of the tube underwater and nothing else, which one would you do if you could only do one? Submerge. So it's what? Best. Because what's the best answer? The one that you would do if you could only do one. What's the first one? The one you do first. And that may be the same and it may be different. But a lot of people screw up questions because they're answering firsts instead of bests or bests instead of firsts. And they're not paying attention to what the question is asking. For example, and this is really important to get because people have trouble with this. You notice a person has ventricular fibrillation on the monitor. VFib, good or bad? Bad. No cardiac output. You run to the room, they're non-responsive, and they don't have a pulse. What's the first thing you're going to do? A, place a backboard. B, begin chest compressions. Now, first is about what? Order. So, you're between those two, right? So if you pick place backboard, what are you saying? I'm going to place the backboard first, then I'm going to start chest compressions. If you pick chest compressions, what are you saying? I'm going to start chest compressions, then I'm going to place the backboard. Well, what would be better to do first? Place the backboard. And remember, it's a perfect world, so where's the backboard? Right there. Boom, it's there. Don't say, well, it could take 10 minutes for somebody else to bring the code. No, it's a perfect world, it's there. Okay? So, what's the first thing you do? Place the backboard or begin chest compressions? Place the backboard. But what if I say this? Person has VFib, they're unresponsive, no pulse. What's the best thing to do? Place the backboard or begin chest compressions? Well, if you do one of those, you don't get to do the other one. You understand? In a best question, how many things do you get to do? One. And if you do one, you don't get to do the other one. So if you pick backboard as the best, what are you saying you're going to do? I'm going to roll them over, put them on the backboard, and go, oh, okay, now. And it's still not getting the pulse. Hopefully somebody will come along before 8 minutes, right? But if you pick chest compressions, what are you saying? I'll do chest compressions while they're on the floor. They get no backboard.
Right.
Well, would you rather do chest compressions without a backboard
Right.
or a backboard without chest compressions?
Compression.
Which one's best? The chest compressions. Which one's first? The backboard. Are you getting this? First versus best? We're going to talk a lot about this in the next 3 days, so you get good at this. Most people don't even catch the difference. They just right over. No, not you guys, but a lot of you. Number 2, what do you do if the chest tube gets pulled out? Have you ever seen that? I've done it. Yeah, I did. I worked at Southwest 9 and when St. East was open in Dayton, Ohio. I worked in the intensive care unit from the open hearts, and they had these chest tubes and everything. Well, this guy's huge. He's like 10 times my size. Well, that's not hard to beat, but he was really big. And I knew that I had to get him in bed, and I had one chance. Otherwise, we're both going down. And I had to do it all in one motion. So I got there like this, wide stance. The bed's here, he's here. I got the belt, and I think, okay, now. And I thought, oh, your stance isn't wide enough, so I went. And when I went like that, I stepped on his chest tube.
Oh, no.
And I did not know it. And I went, okay, 1, 2, 3. And I lifted him up, and out came because I'm standing on it, got pulled out. But I didn't know it. And so he's there, and he's talking and whatnot, and I'm going, where's the blood on my pants? I said, blood all over my pants? What's this? Here's the chest tube lying on the floor. So I thought, oh, great. But he says, oh, I feel pretty good. I feel a lot better now. Let's try for the other one. But what's the first thing you do? What do you think the first thing you do is? Take a gloved hand and cover the hole. What's the best thing to do? Cover it with a Vaseline gauze. So what's the first thing you do? Cover it with your gloved hand. What's the best thing to do? Vaseline gauze. Because if they say you accidentally pulled out the chest tube, what's the best thing to do? Best thing. And you're between cover it with your gloved hand versus Vaseline gauze. If you pick cover it with your gloved hand, what are you saying? I'm going to cover it with my gloved hand, and that's all I'm going to do. So you're going to follow them around all day long with the gloved hand. No, you're going to put a Vaseline gauze. That actually solves the problem. Do you see the difference? But if they ask first, you're going to put gloved hand, then Vaseline gauze. But best is Vaseline gauze. Forget about the gloved hand. Are you seeing this difference? It's real important, real critical that you see this. Bubbling. They love to ask about bubbling chest tubes. You've seen these questions around? Yeah. Okay, ask yourself 2 questions. Where is it bubbling and when is it bubbling? If you do not ask yourself those 2 questions, you're going to get it wrong. You can get this question right if you ask where and when, because it is going to depend on where and when. Because sometimes bubbling is good and sometimes it's bad. It depends on where and when. So let's talk about it. If I say bubbling, 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 what do you say? Where? I say water seal. Do you see where I'm at? Then what do you ask me? And I say intermittent. Is everybody where I'm at? So intermittent bubbling in the water seal is good. Document it. It's never bad. It's always good. Document it. Okay, I say bubbling, bubbling. You say what? Where? I say water seal. You say? When? I say continuous. This is bad. There is a leak. You do not want continuous bubbling in the water seal. That means there's a leak in the system. You've got to find it and tape it. Put tape over it till it stops leaking. LPNs, this is perfectly within the scope of your practice to put tape on these things to stop the continuous bubbling. I say bubbling, bubbling, bubbling. You say what?
Where?
I say suction control chamber. You say, and I say intermittent, that's bad. The suction is not high enough in that case. If you're only getting intermittent bubbling in the suction control, your suction is too low. You got to go to the wall. You know what I mean by the wall? You know that dial at the wall? And you got to turn it up until what happens? Bubbles how? Continuous. Because if I say bubbling, bubbling, you say, where I say suction control, you say, and I say continuous, that is good. You document that. So, 2 scenarios are good and 2 scenarios are bad. Did you notice that? And what did you notice about the 2 chambers? They're opposite. What's good in one is bad in the other. Now, I do not memorize all 4 of those. I don't. I memorize 1. And then I deduce all the other 3. The one that makes the most intuitive sense to me is this. Think about this. If something is sealed, which chamber am I talking about? If something is sealed,
Water seal.
should you have a continuous bubble? No. That means it's what? Leaking. So that is bad. So intermittent in the seal is, and the suction control is the opposite of that. Because it just makes sense to me. If this were a 2-liter bottle of pop, and it was on the grocery store shelf, and it was sitting there going bubble, 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 bubbling how? Continuously. Would you buy it? No. What's your conclusion about it? The what? Seal is broken. Is it? Don't you in life? When things bubble continuously, you think, oh, the seal's broken. Well, in a chest tube, if it's bubbling continuously, the water seal is broken, and so that's bad. Do you see how I want you to remember it? Did you ever notice that when you do chest tube questions that it is so frustrating because sometimes you're saying it's bubbling is bad, sometimes you're saying, and they say, no, it's okay, and then the next time you say, oh, it's okay, and then they say, no, it's bad, and then the next time you say, oh, it must be bad, and then they say, no, it's okay, and you're going, just make up your mind, is bubbling good or bad, and what's the answer? It's both. It depends. And that's what you're not picking up. You have made all chest tubes the same, right?
Yeah.
And they're very different. See, my philosophy is make something simple if it's simple, but don't oversimplify if it's actually more involved. So hopefully that will help you with your chest tube questions to know when bubbling's okay and when bubbling's not okay, and when draining's okay and when draining's not okay, and what the purpose of it is. Do any of you like analogies? Learn by analogy. Dog is to meow as bark is to cat. You know that you're not good at analogies when I say meow is to cat as bark is to, and you say tree. You know you're not very good at it, But here's an analogy that might help you. A straight catheter, you got where I'm at? A straight catheter is to a Foley catheter as a thoracentesis is to a chest tube. Did you get the analogy? Because what's a straight cath? In and out. What's a Foley? In, secure, drain in. Keep continuous drain. What's a thoracentesis? In and out to reestablish negative pressure. What's a chest tube? Stick it in, secure it, leave it in. So, do you see the point? So just think of a thoracentesis as an in and out chest tube. And that will help you answer questions there too. So which one has a higher risk of infection? Thoracentesis or chest tube? Because what has a higher risk of infection? A straight cath or a Foley? Right? Same idea. Rules for clamping tubes. Never clamp a tube for longer than 15 seconds without a doctor's order. You're not allowed to clamp chest tubes for longer than 15 seconds without a doctor's order. So if you break the water seal, what is the first thing you do? Break the water seal. First thing.
Clamp.
Now, how long do you have to get that thing cut off and underwater? 15 seconds. Or you got to what? Unclamp it. So have those sterile water bottles nearby. It drives me crazy. When I work as a nurse and I get people with chest tubes, I go into the room and guess what's all over the walls and all over the over bed table and everywhere? Clamps. I can find like 6 clamps in every room. What can I not find within 100 yards? Sterile water. Which one can I simulate and don't need? A clamp, because I can kink the tube off with my fingers. What can I not simulate? Sterile water. Wish I could, you know. Number 2, use rubber tip double clamps. Use rubber tip double clamps. In other words, if you're going to clamp something, what should they be covered with? The teeth. Rubber. Why should the teeth of the clamp be covered with rubber? Because otherwise you're going to puncture it. That's stupid. And why double clamps? Why 2? Because we're nurses. Okay? There's no research-based evidence to prove that 2 clamps is better than 1. It's just the way we are. Okay?
Double.
Okay, congenital heart defects.
Rubber tip double clamp.
And then we'll do some real brief ones and be done for the day. Congenital heart defects. Everybody knows what congenital heart defects are? Okay, good. Every congenital heart defect is either trouble or no trouble. What I mean by that is either a congenital heart defect causes a lot of problems or it's no big deal at all. There is no in-between defect. That's kind of bad but kind of good. It's either what? All bad or all good. It's either all bad, all good, nothing in between. They're either what? Trouble or they are no trouble. Now, to memorize congenital heart, I want you to memorize one word, and only one word, and that word is trouble. Now you notice it has 7 letters. Do you notice that shaded box has 7 blanks? I want you to write the word trouble in there, but capitalize the consonants. Keep the vowels small and lowercase. Capital T, capital R, small o, small u, capital B, capital L, small e. Now, all congenital heart defects are what? Trouble or not. So what's the big word you have to memorize for congenital heart? Trouble. Okay, now if you memorize that, how many have that already memorized? You memorized it in the last 10 seconds. Okay, you can repeat that. You now know 95% of all congenital heart defects. How do I know that? Here's how I know it. If a congenital heart defect is trouble, let's say you guys have trouble defects. Does logic say you need or don't need surgery? If they're trouble?
Need.
When? In order to what? Live. Okay, if you guys have a no trouble defect, do you need surgery? No. Might you have it? Possibly when? Years later, if it causes a trouble, but we don't expect it to cause any trouble because it's not trouble, right? Okay. Well, you guys have a trouble defect. What is your growth and development? Slow,
Yeah.
delayed. Why? Because you have a defect which is?
Trouble.
What is your growth and development? Why normal? Because your defect is no trouble. What's your life expectancy? Normal because it's no trouble. What's you guys' life expectancy? Short because it's trouble. What are your parents experiencing a lot of? Stress, grief, financial, all kinds of caregiver issues. What about your parents? No more problems than the average person on the street. Do you go home on an apnea monitor? No, why? Because it's not trouble. You go home on an apnea monitor.
Yes.
Because you have what?
Trouble.
How long do you stay in the hospital after you're born?
Long time.
Weeks? How long do you stay? 24 hours, 36 hours, and you're gone. Why? Because it's no trouble. Who follows your care? What medical professional follows your care? Which doctor? What kind of a doctor? Pediatrician or a nurse practitioner, pediatric nurse practitioner, right? Who could follow you guys? Who will follow you? Pediatric cardiologist. Do you understand what I'm saying? So if it's trouble, make it trouble. And if it's no trouble, don't make it See, because the way they'll ask this question is they'll say, you are teaching the parents of a child born with tetralogy of Fallot. What will you teach them? And it will say, this decreases life expectancy. This, do you see what I'm saying? Or it'll say, it's just fine, it's no problem. Well, which one do you pick? Well, it depends on whether it's what? Trouble or not. If it's no trouble, what do you tell the parents? Big deal. If it's trouble, what do you tell the parents? Whoa, not good. Now, boards will not give you pictures of defects and ask you what they are. Why? That's not your job. You don't make the diagnosis. The radiologist does. What do you do? What's your role in congenital heart defect? Teaching the parents the implications. And if that's your job, if it's trouble, teach them things that it's going to be a lot of trouble. And if it's no trouble, pick the answer that says this is no trouble. Do you see where you're going to be able to pick the answer out? How many agree you'll be able to know what to teach the parents as long as you know whether it's what? Trouble or not, correct? Okay, now the other thing about trouble is, do you see, is they always want to know, does the defect shunt blood right to left or left to right? Remember that? How many remember left to right, right to left shunt? Okay. Look in the word trouble. Look at the way it is spelled. Is there any help for us in remembering which way trouble defects shunt blood?
Right to left.
Why did you say right to left?
R is first.
Because R comes before L in the word trouble. So a trouble defect is right to left. Why? Why is a trouble defect right to left? Somebody said, because it recirculates deoxygenated blood. No, because that's the way it's spelled. It's too late for me to teach you all this stuff. If something can be simple, let's make it what? Simple. And I am not teaching you the word Telurber. I am teaching you the word what? Trouble. And in the word trouble, what comes first? R, then L. So trouble defects are
Right to
right to left because trouble is spelled that way. So what way are no trouble defects shunting blood? Left to right, because that's not the way trouble is spelled, because it's not trouble. So if a kid has a right to left shunt, what do you tell the parents about surgery? Kid has a right to left shunt, what do you tell the parents? Right to left, that's the way trouble is spelled, so it must be trouble. So I'm telling the parents, oh yeah. Okay, but if a kid has a left to right shunt, what do you tell the parents about the growth and development? Left to right. Left to right, that's not the way trouble is spelled, so it cannot be trouble, so we say normal. Are you getting this? Mm-hmm. Okay, the other thing they want to know is the kid cyanotic or acyanotic? Remember that? Mm-hmm. Cyanotic, acyanotic. What does cyanotic mean? Blue. Do we have anything that can help us with that? B, the word B, the letter B in trouble. See, we're using the consonants. We're not going to use the vowels. Just going to use the consonants here. So B means blue. So what types of shunts are blue? What types of shunts are blue?
Right to left.
Right to left means blue. So left to right means not blue, which is pink, acyanotic. You got me? So why are right to lefts blue? Because trouble's spelled that way. Yes. Don't talk to me about deoxygenated blood, because I don't care. I just want to know, can you do this? Okay, now, what do you know about a congenital heart defect? If you know it is trouble, start listing the things you know about it. If it is trouble, what do you know? Shunts blood, what? Right to left. Cyanotic. Needs. Delayed. Decreased. Life expectancy. Needs pediatric. Exercise intolerance. Needs some meds. Needs an apnea monitor. Is going to stay longer. Parental guilt. Financial difficulties. Caregiver stress. Right? Because it's what? Trouble. But if it's no trouble, what do you tell the parents? No trouble. You know it's left to right. You know it's blue. You know it's no big deal. So with troubles you go, whoa. With no troubles, you go, ah. Right? Now, there are 40-some congenital heart defects, correct? Some of them are trouble and some of them are not. How do you remember which ones are trouble? Well, just memorize them, right? Memorize which ones are trouble, correct? And then you'll know which ones are, and the others are no trouble, right? No, because I told you to memorize what?
Trouble.
One word, and that would be trouble. And that would be memorizing more than a word, wouldn't it? You'd be memorizing a list. Well, what consonant have we not yet used?
T.
What position does T hold in the word trouble? First. It just so happens by total sheer coincidence that all congenital heart defects which start with the letter T are trouble. If it does not start with a T, it is not trouble. So, do you see where it says examples of trouble, examples of no trouble? Let me give you some examples and you tell me where you're going to put it. You have a patient with ventricular septal defect. Ventricular septal defect. What is it?
No trouble.
Why?
Let me give
It
it
starts with a V. That's not a
T.
T, so it's not.
Trouble.
So it shunts blood from the
Left
left to the right. The kid is
Acyanotic.
acyanotic. Can you tell the parents?
Yeah.
No problem.
Don't worry about it. Okay, your kid has tetralogy of Fallot.
That's a problem.
That starts with a what? Starts with a what? T, and that means it's trouble. So it shunts blood. Right to left kid is cyanotic. Can you tell the parents? Oh. Okay, patent ductus arteriosus. Patent ductus arteriosus. That starts with the letter
P.
P. That's not a
T.
So it's not.
Trouble.
So it shunts blood. Left to right, the kid is pink. Can you tell the parents? Okay. Patent foramen ovale. Starts with a
P.
P. That's not a. So it's not. So you tell the parents. Truncus arteriosus. Starts with a.
T.
And that means it's.
Trouble.
So it shunts blood from the kid is blue. And you tell the parents. Whoa, not good. Transposition of the great vessels. Trouble. Tricuspid atresia. Atrial septal defect. Pulmonic stenosis. Totally anomalous pulmonary vasculature, TAPV. Do you know what it is? Do I care? No, they don't care what it is. They want to know what you're going to tell the parent. And since it starts with a T, you're going to say what? Oh, surgery. Right? Okay, now there's only one exception to this rule, and only those of you from Columbus know it. Those of you from not Columbus don't hear of it, because Columbus is a nationwide center for the treatment of these children. It is a research place for left ventricular hypoplastic syndrome, which you don't, if this were a class in Cincinnati, no one would know it. How many have heard of it? Raise your hand. Now that is shocking for a Columbus. Well, how many of you are actually Columbians? Okay. Well, I'm surprised you haven't heard about it, but boards will never bring up what? Left ventricular hypoplastic syndrome, because it's like 0.1% of the whole congenital heart defect. They're going to bring up those more popular ones. You see what I'm saying? So for boards, if it starts with T, it's what?
Trouble.
If it doesn't start with T, it's...
No.
So are you going to memorize your defects?
No.
No. Just the word trouble. Okay? So that'll save you some time, won't it? So that whole chapter you got. Now there's just a couple more things you need to know. All congenital heart defect kids will have two things, whether trouble or not. Number one, they'll all have a murmur. Why do they all have murmurs? Because of the shunt of the blood. They're either shunting from the left to the right or the right to the left. It really doesn't matter. You're going to hear a murmur. What I don't want you to think is, oh, only troubles have murmurs. And no troubles don't have murmurs. No. They all have a murmur. You got that? And they all have an echocardiogram done. Because they got to find out why. So even your no trouble kids will have an echocardiogram done. The last thing about congenital heart defect is you need to know the 4 defects of tetralogy of Fallot. The 4 defects of tetralogy of Fallot. Now, I have been working for 20 years to come up with a good way to remember these, and I haven't come up with a good way. I've come up with an okay way. If anybody knows a good way, let me know. Okay? The best way I know is the saying, varied pictures of a ranch. Imagine you went out west to a dude ranch and you have all these pictures on your cell phone. You have varied pictures of a ranch. Well, what I did with these is, do you see the word varied? What did I do with it? Capitalized what letters? The first and last. Pictures, what did I capitalize? First and last. Of a. First and last. Ranch. First and last. Well, do you know what VD, PS, OA, RH are? Those are the initials of the 4 defects. So varied becomes VD, which is VD. What would VD stand for in the heart? Ventricular defect. What would PS stand for in the heart? Pulmonary
stenosis.
stenosis, exactly. What would OA stand for in the heart?
Overriding aorta.
Overriding aorta. And what would the RH stand for? Right hypertrophy.
Right.
So here's the good news, everybody. You don't have to recall these. You just have to recognize them. What is the difference between recall and recognition? What's recall? Remember it from nothing. What's recognize? Spot it when you see it. So here's the deal. All you need to do is, in the way they'll do this is they'll say, your patient has tetralogy of Fallot, select all the defects that apply. So you're going to pick out a what? A VD, a PS, an OA, and an RH. Do you understand what I'm saying? And you don't really have to memorize even what they are. Just a VD, a PS, an OA, and an RH. Varied pictures of a ranch. And they don't know about this, so they don't have like 2 VDs, 2 PSs, 2 RHs. You see what I'm saying? So you should be okay with that. Now, does anybody have a better one? The only one I saw that was kind of interesting, it is kind of timely given the time of year we're talking about, is they wanted to get the VD, PS, OA, RH, but they wanted it to have something to do with heart, because that one has nothing to do with heart. So they said Valentine's, starts with a what?
V.
Day,
D.
starts with a what?
D.
Pick someone out a red heart. H. Valentine's Day, pick someone out a red heart. VDPSOARH. So I don't care what you do, but I suggest you remember VDPSOARH. Okay? But Varied Pictures of a Ranch does it for me because I always mess up. I always go, Valentine's Day, pick out someone, pick someone out, I go, so it's kind of sloppy, but I have to tell you that because that's on there all the time. What are the 4 defects of tetralogy of Fallot? It's the only defect where they ask you what it is. So what do you have to memorize to know all of your congenital heart defects? Trouble and VDPSOARH. And you should get the whole chapter. All right, just in conclusion, I want to do a couple things so that you know where we're headed, and just a few short things. Page number 32, infectious disease and transmission-based precautions. Infectious disease and transmission-based precautions. Page 32, it's one page, I want to do it right now. There are 4 transmission-based precautions. Standard, universal, contact, droplet, and airborne. Which one did I leave out? Standard, universal. Why? I'm assuming you know that. If you don't know that, I don't want you to pass. But so the ones you probably need help with are droplet, contact, and airborne. So let's talk about it. Contact isolation. It is for anything enteric. Enteric, which means what? Can be caught from intestine. Fecal oral. Fecal oral. So that would be C. diff, Clostridium difficile, remember that one? Hepatitis A would be there, that's enteric, that's intestinal. Any of those cholera, dysentery, those ones where the bug's in the diarrhea and you don't wash your hands and then you touch somebody and then they eat their food and they... Okay? Sometimes people get confused at hepatitis A and hepatitis B, which one's which. I always say hepatitis A the A stands for anus. I mean, it doesn't, but when you see hepatitis A, think hepatitis anus, which tells you it's what? Fecal oral. Hepatitis B is hepatitis blood, so it's by the blood. Question?
They taught us anything with a vowel comes from the vowel.
Anything what?
The vowel.
Oh, anything with a vowel comes from the vowel. What do they mean by that? Oh, okay. The types of hepatitis. Anything with a vowel comes from the vowel. Whereas anything that isn't a vowel comes from blood and body fluids. That's an interesting one. It's cool. But they don't ask E. They just talk about hepatitis anus. Okay. Really, that's all they test. All right. The other one you use for contact is staph infections. Staph. S-T-A-P-H, not S-T-A-F-F. These are staph infections. S-T-A-P-H. Staph infections. And RSV. RSV. Does anybody know what RSV is?
Respiratory. Is that the thing the babies get?
Yes, it's the one that the little 1- and 2-year-olds get with bronchiolitis. It's no danger to us, but to them it can be fatal. Respiratory syncytial virus. RSV. They will give you both names. Now, the interesting thing about RSV is how is it transmitted? Droplet. But what precautions is it on? Contact. See, there's where you don't get confused on this. You put RSVs on contact precautions even though it is transmitted via droplet. Because with little kids, they catch it from touching other things that other kids touched and put in their mouth. It's not because they're sneezing on each other. So you could put them on droplet and it still would pass. See, what they did is they used to put RSV on droplet, but it was still going all over the place because it was by the contact with objects that it was passing. So when they put them on contact, it stopped being passed, even though it's transmitted via droplets. Does everybody make sense? So how is RSV usually transmitted? Kid takes a toy, puts it down, next kid takes the toy, and then they get it. So contact works best, even though it's transmitted via droplets. So don't get confused there. It is transmitted droplet, but it's on contact precautions. And herpes infections. So enterics, staph, RSV, and herpes. These infections are contact isolation. Now, what is involved in contact isolation? Now, I'm going to give you all the latest, newest things because they're really up to on this. So this may have changed if you've come to another review. So you need to make sure if you're refreshing that you get this down. Alrighty? Because some things have changed. In contact, they are now saying private room is preferred. So therefore, while it is not required, it is preferred. Therefore, you would say yes to the private room. You understand? So that's a change. Yes to the private room because it is preferred. However, these kids can be put in the same room as long as you cohort. What does cohort mean? Same. So if you got 2 RSV kids, can you put them in the same room? Yes, but otherwise an RSV needs to be in their own room. Somebody said, well, at Cincinnati Children's, we put them all in the same room. Yeah, you're putting 6 RSV kids in the same room. Go at it. That's cool. What about an RSV kid with a suspected RSV kid? Yes or no? No. They have to be cultured and positive before you can put them in the same room, before you can cohort. So cohorting is done on the basis of culture or symptom. Culture, not symptom. You understand that? Mask? No. Gloves? Yes. Gown? Yes. Hand washing? When's that ever wrong? Yes. Eye face shields? No. Not unless you need them for universal, right? But you don't need them specifically for this. Special filter mask? No. Patient wear mask? No. Disposable supplies, dedicated equipment? Yes. What is the difference between a disposable supply versus a dedicated equipment? Give me an example of a disposable supply.
Pressure cuff.
What's that?
Blood pressure cuff.
No, we don't throw the pressure cuff away. Do we throw the thermometer away? Like I was thinking of paper plate, a plastic utensil. What is a dedicated equipment? Stethoscope, a blood pressure cuff that stays only in their rooms. So what are the toys with these kids? If it's a kid, what's the toy? Disposable or dedicated? Dedicated. Only they play with them, no other kid plays with them. Of course, the 2 respiratory syncytial virus kids can play with it, what? Together. Negative airflow, no. Okay, droplet. Droplet is for bugs that travel 3 feet on large particles due to sneezing and coughing. They are for meningitises, all meningitis, and H flu. Have you heard of H flu?
Yeah.
Haemophilus influenza B? H flu? What's the big bad disease that H flu causes? Does anybody know which one it is?
Meningitis.
It can, but it's more likely to cause epiglottitis. You're right. H flu meningitis is common, but H flu causes epiglottitis more. Remember, that's that airway disease that if you stick something down their throat, they're going to obstruct, so you don't look down their throat or mess with their throat. So what do? Here's another change. Private room is preferred. Not required, but it is preferred. So on boards, you would select private room. It is preferred. Unless you are what? Cohorting. Based on? Culture. And if it is meningitis, what did they all have to have? Lumbar punctures, right? Because that's where you culture the meningitis. Private room is preferred. Mask. Yes. Gloves. Yes. Gown? No. You don't need the gown. Hand washing? Yes. Special eye face shields? No, not unless you're doing something for universal. Special filter mask? No. Patient wear mask when leaving room? Yes. Disposable supplies, dedicated equipment, what do you think? Yes. And negative airflow? No. Okay, airborne. Airborne is for measles, mumps, rubella, tuberculosis, and varicella chickenpox. Now, private room. Required, unless you're cohorting. Mask? Yes. Gloves? Yes. Gown? Not necessarily. The gown is more for contact. It really, really is. Hand washing? Yes. Eye face shields? No, not really. You don't need them for this. Special filter mask only for TB, only for tuberculosis. Patient wear mask when leaving room? Absolutely. In fact, they really shouldn't be leaving the room in the first place. But if they do, they have to wear the mask. Disposable supplies, dedicated equipment is probably a good thing, but it's not as essential as in the other two. So you could let that one slide. You could let that, because it's what? Airborne, not droplet or contact. And negative airflow, yes. Now the interesting thing about tuberculosis is, how is tuberculosis spread? By what method? Droplet. But what precautions is it on? Airborne. See, so what are the two that don't make a lot of sense? RSV and TB. They're both what? Droplet. One is however on contact, the other is on airborne. But they're both transmitted via droplet. Question?
Where's shingles going to be placed on?
Shingles would be herpes zoster, so it is a contact. It's by the varicella, but it's not a respiratory varicella. It's a contact varicella. Good question. The other thing that I want you to know, because they're really, they're like white on rice on this one, is personal protective equipment, PPE, and they want to know what order you put it on and what order you take it off, because it's a drag and click, or click and drag. Well, here's the deal. You always take it off in alphabetical order. You take it off in the alphabetical order. So, what would be the first thing you'd take off? Gown, mask, gloves, or goggles? Gown, gloves, mask, or goggles? Make it alphabetical. What would come first? Gown, goggles, mask, or gloves?
Gloves.
Gloves, followed by? Goggles, followed by? Gown, followed by mask. So it comes off, and it's hard for you right now to think alphabetical, right? But when you see it, and when's alphabet? On or off? Off. Off is alphabetical. On is the reverse alphabetical for the G's, but mask comes second. So what would you put it on? It's reverse alphabetical for the G's, and mask comes second. So it's G, M, G, G. Gown, mask, goggles, gloves. And then it comes off, gloves, goggles, gown, mask. So off is easy because it's alphabetical. On, you got the G's are reverse alphabetical order, but the mask gets put in second. G, M, G, 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 M. You see that? So that's the best way to go with that. Okay, turn the page to 50, and we'll be done for the day. And it'll be about 10 after 9, 20 minutes early. Did I go too fast, or
No.
everything all right? Okay. Tomorrow morning is going to come really soon, guys. Okay. By the time we end tomorrow, we will have barely spent 24 hours together. By the time we end tomorrow. That's quite intense. Okay, math problems. I refuse to teach a math class because everybody's math problem is a little different. Math is best learned individually, not in a class. So what I want you to do is I want you to try these math problems tonight or tomorrow night. Okay? The answers are at the bottom of the page. Now, I was real sloppy with rounding, so as long as you're close to what I have, you're probably right, I'm probably wrong. But as long as you're close to what I have, you're probably okay. It's probably just a rounding error I made, and it's not your problem. So what I want you to do is do these problems, see if you come up with the answers. If you come up with the answers at the bottom of the page, guess what? We don't need to talk. But if you can't get any of them, we better talk. Well, when should we talk? During lunch, at the breaks, you know what I mean? Talk with me. So, because we can help you with this. The first two are what we call dosage calculation. It's when what the doctor orders isn't what's on the bottle. There's no conversion involved. It's just a simple desired over have times available, or if you're like me, just set up a ratio proportion. Because I was a math major, chemistry major first, and I had 3/4 of calculus and differential equations. So when we went to nursing, and they were teaching me this stupid little formula, desired over have, and I've had more math than all my faculty combined, you know, it was like, what? You know, but if you know how to do it, do it. Okay, and the next one is the IV drip rates. And these are mostly the RNs. You're going to have to know these. LPNs, you may probably not have to know these. But that's the volume times drop factor over time in minutes. Volume times drop factor over time in minutes. That's your formula to memorize for that.
We know that, don't we?
Okay. And remember, mini drip is 60 drops per mil. Mini or micro is 60. Macro is what?
10
10.
or 10 or
10 or 20 or 15 or 12. But boards will say it's 10, which is really stupid because all manufacturers are different. Micro and mini are always 60. 60 drops per mil. That's your drop factor. So when they say micro and mini, your drop factor is what? 60. So you're going to multiply by 60 and then divide by 60. So what? Why bother, right? I love mini drip calculations for iDrip. Why do I like mini drip for IV drip rates? If you just divide the volume by the hours, you got your answer. Because all you're going to do is multiply by 60, then divide by 60. If you're going to do the same thing, why bother?
Right.
Okay. The next two are pediatric dose questions where you're using the child's weight. And LPNs, they will give you these. And it's 2.2 pounds per kilogram. They will always give you the kilogram weight. Always. They will never go the other way. They don't give you kilograms and ask for pounds. They always give you pounds and ask for kilograms. So you're going to be what? Dividing pounds by 2.2. You will always, listen to this, you will always be dividing by 2.2. You will never be multiplying by it. So take the weight, divide by 2.2, then do your math. Pay attention to whether they're asking the total amount per day or the amount to be given at just one time. Do you see what I'm saying? Because if it says TID, 15 milligrams per kilogram per day TID, that means the whole daily dose is, and then you've got to divide it into what? 3 to get what you're going to give at one time. But if they say, what's the daily dose, you give the whole. Do you see where you have to pay attention to what they're asking for? Are they asking for a dose at one time or the whole daily dose? Because you could do the math right and still miss the question if you don't pay attention to that. And the last two are IV replacement questions. This is more for RN. And there's no formula for that when it's just thinking with math. Now, just a couple things about math real quick. Do you use leading zeros? Yes or no? Leading zeros.
Yes.
As long as it maintains what? Place. So what about this? I'm sorry. 0.00300. How many zeros are not needed and how many zeros are needed?
4's not needed.
4 are not needed
2 is
and 3 are.
3.
Okay, needed or not needed?
Not.
Needed or not needed?
Not.
Needed or not needed?
Yes.
Needed?
Yes.
Needed?
Yes.
Not needed?
No.
Nope.
Okay. So no, you can use leading zeros as long as they maintain place. You do not use trailing zeros, ever. Alrighty? Also, boards will tell you to what you are to round, which I love. I think it's fantastic. They made that change about 4 or 5 years ago to where they say round to nearest tenth. So you don't have to sit there going, what should I round to? They told you nearest tenth. And then you do not have to put units. If they say, how many milliliters will you give, just write 10. Don't write 10 ml. because that says how many milliliters we give? 10 milliliters. Do you see what I'm saying? You don't need these units. You just need the numbers. All right, and write the numbers. Don't write 10. Okay. Any questions? All right, see you tomorrow at what time? 9, bright and early. I have an hour long to get home. Who has longer? How long? Oh, are you staying in or are you leaving? I'm leaving.
It isn't really.
Carpool.
It isn't really a whole hour though, is it?
What's that?
It's not really a whole hour because I'm spring.
Okay. All right, we're going to start out with crutches, canes, and walkers. On page 17. Any questions? Probably just went home and slept.
Yeah, we did.
Not much came to mind. Okay. Crutches, canes, and walkers. One of the major areas of human functioning is locomotion. And so they do test it. So certain things show up on boards with greater frequency than what you might expect them to. And locomotion is one of those. And so to test that, they test casts, traction, canes, crutches, walkers, things that were really probably not emphasized in your school much, were they? That wasn't a major emphasis, I doubt. But on boards, people will always say, like, well, I was surprised at how many things I had about traction or about casts or about things like that. And that's because one of the 8 areas of human functioning they test is locomotion. So you do have to know some of these things. Plus, they're also really good areas for patient teaching because a lot of boards is teaching. What do you teach? What's your goal? What's the teaching? And then it's also risk reduction, as far as reducing risk to skin, risk for immobility problems and that. So let's talk about crutches. The first thing is how do you measure crutches? The reason why they want you to know how to measure crutches correctly is for risk reduction so that you don't cause nerve damage. The first thing is the length of the crutch. How do you measure the length of the crutch? It's 2 to 3 finger widths below the anterior axillary fold to a point lateral to and slightly in front of the foot. Now, what they'll do is they'll say something like, you see an RN or an LPN or an aide measuring a person for crutches. You notice they're doing all of the following. What would you correct? And you have to pick something where they're doing it wrong. Or they'll say which one shows the right, and you have to pick out the correct. The deal is they'll often write sets of instructions where you're measuring from the wrong point to the wrong point. For example, they'll say, to get the length of a crutch, you measure from the axilla. You don't measure from the axilla. You measure 2 to 3 finger widths below the anterior axillary fold. So they'll give you the wrong upper point. Or they'll say you measure to the heel. You don't measure to the heel. You measure to the little toe. You don't measure to the little toe. In other words, you don't measure to any landmark on the foot. You measure to a point lateral to and slightly in front of the foot. So if any of the answers say axilla or any landmark on your foot, they are incorrect. They are wrong. Rule them out. So any instructions with a landmark on the foot or say axilla, they're wrong instructions for how long the crutches need to be. Letter B, the next thing you have to measure is the hand grip. The hand grip can be adjusted up and down, and what you need to know there is when the hand grips are properly placed, the angle of elbow flexion will be about 30 degrees. So those are the two things that they're all about with crutch measuring, the length and the angle of elbow flexion when you put the hand grip properly placed. Those are the only two things you need to know about measuring crutches. The next part of it is how to teach crutch gaits, because you're supposed to be able to educate people on how to walk with crutches. There are 4 crutch gaits: 2-point, 3-point, 4-point, and swing through. Now, how do you teach each of them? 2-point gait is rather simple. These names are really obvious. You shouldn't forget these names because these names tell you exactly what you're doing, with one exception maybe. In 2-point gait, pretend my arms are crutches, all right? In 2-point gait, you move a crutch and the opposite foot together, followed by the other crutch and the other foot together. And so you kind of walk like this. 2 things, 2 things, 2 things, 2 things, 2 things. So it goes 2, 2, 2, 2, 2. Well, if you were going 2, 2, 2, 2, 2, what would you name the gait? 2-point. Doesn't it make sense?
Yeah.
Because in 2-point, you're moving 2 things together. What 2 things? A crutch and the opposite. It's always crutch and opposite. So that's real simple to teach. In 3-point gait, you're moving 2 crutches and the bad leg together. 2 crutches and the bad leg. So how many things is that? 3. So it goes, if this is my bad leg, it goes 3, 1, 3, 1, 3, 1. So what would you call a crutch gait that goes 3, 1, 3, 1, 3, 1? 3-point, seems logical. So what are you moving together in 2-point? How many are you moving together in 2-point? 2. How many are you moving together in 3-point? 3. So how many do you move together in 4-point? 4. No. Because that would be, what would that look like? That would look like this. Right?
Yeah.
And if you could do that, you don't need crutches. So obviously that falls apart. So you move 2 things together in 2-point, you move 3 things together in 3-point, but in 4-point, you move everything separately. Because how many things do you have? Well, you have 2 legs and 2 crutches. 2 plus 2 equals 4. So how does 4-point go? Well, 4-point goes like this. You move a crutch, any crutch, just pick a crutch. But once you move that crutch, now you're locked in. Your sequence is now locked in. Because now what must you move? The opposite foot followed by the other crutch followed by the other foot. So 1, 2, 3, 4. 1, 2, 3, 4. That's 4-point gait. It's very slow, but very stable.
What kind of imagery is that used for?
We'll be talking about that on the next page because that's exactly the next thing we need to tell you. Because you do have to know that. Okay. Swing through, on the other hand, is for non-weight bearing. For example, amputations where you can't bear weight on a stump. Or whenever they say non-weight bearing. And what swing through is you've seen it. I can't illustrate it because I don't really have crutches. But it's where you can't bear weight on this leg. And so you plant the crutches, all right? And then you swing through, you see, and then you never put this leg down. And you've seen them. They kind of go whoosh, whoosh, and they just
father-in-law's missing a leg.
And that's exactly what they do. And they just swing it. And it actually can be really fast. Have you seen people go pretty fast with this? They just move, and that leg never touches down. Okay? So when do you use swing through? Non-weight bearing. I did have a student who called me after she took her test, and she says, that crutch stuff was on there, but what you taught me didn't help. Oh, okay. Rather accusatory, but hey, whatever. And I said, well, why didn't it help? And she said, well, you were telling us about the different crutch gaits, and she said, the one they gave me, nothing you taught us helped. And I said, well, what did they tell you? She said, well, he had an amputation. So I didn't know which crutch gait to use. And I said, well, what do you mean you didn't know? She says, well, 2-point wouldn't work, 3-point would. She says, and then swing throughs for non-weight bearing. And I said, well, amputation, you can't bear. Do you see what I'm saying? Why do people make those kinds of mistakes on tests? They're not thinking. Why are they not thinking? they're anxious.
Not like she
And they're not taking steps to manage that anxiety. Now, I will never tell a student, when you take this test, don't be anxious. That's stupid. You can't tell a person not to be anxious, because they're going to be anxious as whatever they're going to be. But what you have to teach them is how to what? Manage the anxiety. And she wasn't managing the anxiety. And I was thinking, but if you think about it, could you really do 3-point? 1, 2, 3. You can't do that with an amputation. You have to do swing through. Now, what if they said they had an amputation with a prosthetic device? Could you bear weight? Yeah. Okay. Letter D on the next page, which is what you asked, which is when do they use these? In what situations do they use these? You also have to know that. Now, this is easy because there's a little saying we often use, and that's even for even, odd for odd. Even for even, odd for odd. Now, how does that work? Well, let's plug it in. Letter D, number 1. Use the even numbered gates, which are what? 2 and 4, correct? When the weakness is evenly distributed. That's even for even. Meaning use an even numbered gate when you have an even number of legs messed up. Use 2-point for a mild problem and 4-point for a severe problem. So generally, answering your question, when do you use 4-point? With severe bilateral weaknesses. When do you use a 2-point gate? Mild bilateral weaknesses. Because if you see, what my point is this, is if they give you a question about what crutch gait will you teach, all you have to do to get it right is ask yourself how many legs are affected. If it's an even number of legs, which would be what? 2, then pick 2 or 4. Even for even. Okay, D, number 2 here. Use the odd numbered gate, and there's only one odd numbered gate, and that is 3. When one leg is odd. That's the odd for odd. So if you say, how many legs are affected? 1. Well, what kind of a number is 1? Even or odd? Odd. So pick the odd numbered gate, which is 3. But if you have 2 legs affected, is that an even or an odd number? Even. So pick an even numbered gate, 2 or 4. 2 for a mild, 4 for a severe. And if they can't bear weight, you go swing through. And if they're an amputation, you go swing through. So I'm going to give you some examples, and I want you to tell me which crutch gait you would teach, all righty? And I just want you to write it down. Number 1. Early stages of rheumatoid arthritis. Early stages of rheumatoid arthritis. Left above the knee amputation. First day post-op, right knee replacement, partial weight bearing allowed. Right or left? Left. Did I say left or right? Right total knee replacement, first day post-op, partial weight bearing allowed. Advanced stages of amyotrophic lateral sclerosis, ALS. Advanced ALS. Left hip replacement, second day post-op, non-weight bearing. And just write down the crutch gait you're going to teach. Next one, bilateral total knee replacement. Bilateral total knee replacement. First day, post-op, weight bearing allowed. Bilateral total knee replacement. First day, post-op, weight bearing allowed. And last patient, bilateral total knee replacement, 3 weeks post-op. Okay? So do you have your crutch gaits down? Okay, what's it read? What's the first one? 2. Why 2? Did I tell you how many legs were affected? No, but it was a systemic disease. And what should you assume if it's a systemic disease? Both legs. So that's is to an even or odd number. Even. So you would have picked 2 or 4. Why did you pick 2? Early. Okay, then what was the next one? Swing through. Then what? 3. Then, which one? Everybody's sitting there like, are you just not answering, or is everybody getting 4? Okay. Then swing through. Then 4. Then 2. Did you get those? Any questions about any of them? Okay, good. Just remember, even for even, odd for odd. All right, stairs, going up and down stairs with crutches, letter E, going up and down stairs. Again, it's going to be patient teaching. Remember the saying, up with the good, down with the bad. Up with the good, down with the bad. In other words, when you go upstairs with crutches, go up with your good. That means lead with your good. So what goes first? Crutches or the foot? Foot. So crutches go what? Second. Up with the good. Up with the good. See that? However, down with the bad. Down with the bad. See that? Down with the bad. But it actually makes sense. Because could you go up with the bad? Okay, I'm going to put the crutches up first. Okay, now the crutches are up. Okay, now how do I... See, you can't get up because the crutches are there. And when you come down, would you really lead with your good leg? You know, that would throw... You'd be down a bit faster than you thought. It would just throw you down. So it's always up with the, down with the, and the crutches always move with the bad leg. Canes. Hold the cane on the strong side. People hold canes incorrectly, notoriously. If I have a weak right leg, in which hand do I hold the crutch? The left. But I advance it with the bad leg. So when you walk with crutches appropriately, you're walking like this. If this is your bad leg, you're going like this. And see, when you put your crutch down, you have a nice wide base of support, which keeps you upright. When people do it wrong, they hold the cane on the bad side. And what they do is, here's the bad leg, here's the cane, and they go like this. When they go like that, it's a point. So they have to shift their weight over that base of support. And then they rock back. And they go like this. And if you see anybody doing that, what do you know? They have the cane where? Wrong hand. They need to switch it over and walk correctly. So whenever you see people walking that way, they're wrong. Okay? Even if they are a television doctor. Okay. I will correct people in the mall. I've been known to do that. That's why my daughters will never walk with me when we go anywhere. I embarrass them. But I'll go up to somebody and say, interesting, how have you been taught to use that cane? Because I see that you're actually using it incorrectly. Sometimes they listen, sometimes they don't. But nurses, once you're a nurse, it corrupts you, doesn't it? You're different now that you're a nurse. One of the things that my daughters also, they won't walk with me in a hotel hallway. Because what do I do when I go down a hotel hallway? Because you do it too. You go like this. You're walking down a hotel hallway and this is you. What are you doing? You're looking in rooms, aren't you? Because as a nurse, you cannot go down a hallway without looking through rooms, correct? So I'm looking in all these open doors like this, and my daughters are going, Dad, stop looking in the room. Well, my response is, if they didn't want me looking in the room, they should have closed the door. But I mean, you can't, can you do it? Can you walk by an open door without looking in? I mean, you may have been able to before you were a nurse, but you can't do it now that you're a nurse. It's unavoidable. Try to walk down a hallway next time in a hotel and say, I will not look in any empty rooms. You'll go nuts. It'll drive you crazy. Okay. Walkers. Pick them up, set them down, walk to them. Pick them up, set them down, walk to them. In other words, it's slow. Yeah, it's slow. No big deal. They pick it up, they set it down, they walk to it. They're supposed to pick it up, set it down, walk to it. Pick it up, set it down. What do? They go like this and then they go. Right? They don't do it right. Okay, and number 2, if they must tie their belongings to the walker, have them tie it to the sides, not the front. Why? Tipping over. What's that? I didn't hear you.
Can you repeat that?
Okay. If they must tie their belongings to the walker, have them tie belongings to the side of the walker, not to the front of the walker. So even though it is done by 99% of everybody you see, Boards does not like stuff tied onto the fronts of walkers. Alrighty? And Boards doesn't even like wheels on walkers or tennis balls on walkers. You see, even though it's done. Any questions about crutches, canes, and walkers? Just a little refresher, because I figured that if you got a question about that and you hadn't had it in a long time, it might throw you, when it's very simple and very easy to master. All right, let's totally switch gears on page 19 and talk about delusions, hallucinations, and illusions. In other words, some psych. Let's talk psych. Do you see where your first point, letter A, says neurosis versus psychosis? I want you to cross up the word neurosis, and I want you to put non-psychotic, so that the statement now says non-psychotic versus psychosis. Because this is probably one of the most important points I could talk to you about in psych. Because this is probably the most common reason why people with whom I work miss psych questions. Because right out of the gate, they turned left instead of turning right. They went the wrong way out of the gate. And the reason why they go the wrong way out of the gate on a psych question is the very first thing you have to do to get a psych question correct is decide, is my patient non-psychotic or psychotic? That's the first thing you must do in a psych question. You must decide, am I dealing with a psychotic or a non-psychotic? Why does that matter? How many think that might be an important point.
Whether you're dealing with reality or not.
Exactly. It's huge. It'll determine treatment. It'll determine goals. It'll determine prognosis. It'll determine medication. It will determine length of stay. It will determine legalities. It will determine everything. So if you don't even know if you're working with a psychotic versus a non-psychotic, how in the world do you expect to get the question correct? And you won't. You may guess right once in a while, but over the long haul, you're going to do horrible. So one of the very first thing you must do, and I want you to start doing it, whenever you take a psych question, what's the first question you'll ask yourself? Is the patient psychotic or non-psychotic? Now let's talk about those differences. Number one, a non-psychotic person. Do you see wherever you see the word neurotic, just replace it with non-psychotic? A non-psychotic person has insight and is reality-based. A non-psychotic person, yes, they're emotionally ill. Yes, they have emotional distress. Yes, they have mental and behavioral disorder. But they are not psychotic. They have insight. Insight means they know what's wrong with them. They know they have a problem. They know what the problem is. They know how it's messing up their life. And they are reality-based, meaning what they're believe and see and hear and smell and feel and taste in is what you believe and hear and see and smell and feel and taste. So these people are mentally distressed and emotionally distressed, but they're not psychotic. So how do you treat these people? What kinds of answers do you go and select? Now, if you've been doing psych questions right, you know what I'm talking about. So what do you pick? What kind of answers do you pick in that case? What techniques do you use in that case? You guys never made this differentiation when you take psych tests? What was that?
What was the question?
The question is the first thing you have to do when you get a psych question is decide if your patient is a psychotic or a non-psychotic. And if you find out, if you say, oh, this is a non-psychotic patient, then what approaches, what kinds of answers, what kinds of techniques, what kinds of approaches do you look for as being the right answer for this non-psychotic, mentally disturbed patient? Good therapeutic communication. What do I mean by that? Good therapeutic communication.
Asking them to talk about how they feel.
Why? Because isn't that what you do for everybody? Do you do that for med-surg patients? Do you use good therapeutic communication skills with med-surg patients? Do you use good therapeutic communication skills with pediatric clients? Do you use it with OB clients? Community health clients? So the point is this. If a person is mentally disturbed, mentally distressed, emotionally disordered, but they are non-psychotic, the right answer is the right answer that would be right for everybody and anybody that just displays really good communication skills. Like, tell me more about what you're experiencing right now. Or that must be very difficult. Or all that has happened has been fairly overwhelming for you. Or how are you feeling right now? Or, those kinds of things. Tell me more about. What do you mean by? Can you explain to me more fully about? See, those are answers. Have you ever had those questions where they give you a med-surg patient and ask you what would you say, and they're just testing reflection, clarification, amplification, restatement? Remember those therapeutic communication skills you learned in basic nursing that you use with everybody? Well, that's what you want to do with a non-psychotic. There's nothing special that you're supposed to do or know differently with a non-psychotic than any med-surg, peds, or OB patient. So if they say to you, Alice is depressed, and she says, I hate this depression, it's ruining my life, I have absolutely no energy to do anything. Now, is she psychotic or non-psychotic? How did you know she was non-psychotic?
She recognized the problem.
She recognized her problem. She had insight. So that makes her, but she is depressed. So what would you say? Well, you wouldn't use any real fancy sick psych strategies. You would just say to her, well, how are you feeling right now? Or what is currently causing distress for you? Or how much energy do you have today? Do you have enough energy? You know what I mean? That you just, whatever you would ask anybody else, just good communication skills. So how hard of a question is a psych question for a patient with a psych problem who is non-psychotic? Is it hard or easy? It's easy because you're just going to use good, general, therapeutic communication. And there's nothing special you were supposed to have known about it. Okay, now, however, let's talk about the next group, the psychotics. Letter B, or number 2. The psychotic person has no insight and is not reality-based. In other words, they don't know they're sick. They think everybody else has the problem, not them. Have you ever met these people? What do they say about themselves? I'm not sick. Who do they blame? Everybody's got, it's the doctor, it's the nurses, it's my neighbors, it's my wife. So you have to understand that psychotics don't think they're sick. And if they say they're sick, because I've heard psychotics say, I'm a schizophrenic, undifferentiated type. And they'll even quote the ICD-10 code for insurance purposes. But yet then they say that the Martians are causing all their problems in life. Well, that's not insight. Because insight means you know you're sick and you know how it's messing up your life. Well, they may be able to state the disease, but that doesn't mean they have insight. Do you hear that? How many have heard psychotics tell you that they've actually told you their diagnosis, but they have no insight? Okay. Now, these people are treated very differently, because what does not work with these people? Good therapeutic communication skills. Because that assumes that people are rational, reality-based, and know they have a problem. Well, these people don't have any of that. So what you've got to memorize is unique, specific strategies, which I will teach you on the next page. But for right now, let's move into symptoms. Delusions, hallucinations, and illusions are psychotic symptoms. Only psychotic people get these. Non-psychotics do not have delusions. Non-psychotics do not have hallucinations. And non-psychotics do not have illusions. So the minute your patient has a delusion, they have crossed the line and they are now in the camp of psychotic. So remember Alice that was depressed that I talked about a couple minutes ago? If they said, Alice is depressed, she says, I can't stand this depression, it's ruining my life, what symptoms would you expect? You got the question? What symptoms would you expect in this lady? Select all that apply. Okay, would you pick decreased energy level? Yes. Psychomotor retardation, meaning everything kind of slows down. Delusions of persecution? No. That would be totally out the window. Why? Because she is non-psychotic, and non-psychotics don't have delusions, hallucinations, and illusions. So you could automatically rule that out. Now, if they are psychotic, you rule those in, because they do have those. So let's talk about these psychotic symptoms in depth, because I'm going to teach you what they are and then how to treat them. The first psychotic symptom is a delusion. A delusion is a false, fixed, F-I-X-E-D, fixed, which means they don't change it. A false, fixed idea or belief. There is no sensory component. With a delusion, you're not hearing, feeling, tasting, seeing, smelling anything. It's all up here. You're thinking it. You're not feeling it. You're not sensing it at all. It's just a thought. Now, there are 3 types of delusions. The first is a paranoid delusion, which is a false fixed belief that people are out to harm you. Like the police are out to kill me, the mafia's out to kill me, my wife is having me committed so she can run off with the psychiatrist, the kids are lying about me so they can get my house, the neighbors are shining lasers on me to hurt me, that kind of stuff. Grandiose delusion is a false fixed belief that you are superior. So this is where you think you're Christ or Muhammad or Genghis Khan or, whomever. Or you generically think that you're the world's smartest person. You're the world's greatest person. The future of the universe hinges on you. Those are all grandiose thoughts. The third type of delusion is a somatic, which is a false fixed belief about bodies, about a body part, about your body. In other words, I have X-ray vision. I can melt stone with my eyes. My brain is a Martian superconducting proton accelerator. There are worms inside my arm. My body is hollow. You're pregnant, you're 83, and you're male. Those are delusions, somatic delusions. Now, hallucinations. How are hallucinations different? A hallucination is a false fixed sensory experience. You see, with a delusion, there was no sensation going on. With hallucination, it's purely sensory. You see, hear, feel, taste, hear, feel, taste, smell, all those things. So how many senses do we have? We have 5. So how many types of hallucinations? 5, 1 for each sense. The most common hallucination is letter A, auditory. An auditory, A-U-D-I-T-O-R-Y, auditory hallucination, where you hear things. And primarily, they are voices telling you to hurt yourself. So the most common hallucination is an auditory hallucination, and the most common auditory hallucination is voices telling you to harm yourself. That is by far and away the most common hallucination reported. The next most common hallucination is a visual, which is seeing things that are not there. The third most common is tactile, T-A-C-T-I-L-E, which is feeling things that are not there. And the last 2 are gustatory, G-U-S, and then the word tat, T-A-T, and then O-R-Y, gustatory, which is tasting things that are not there. And the last one is olfactory, O-L and then the word factory, which is smelling things that are not real. So you have auditory, visual, tactile, gustatory, olfactory. The first 3 are the most common in that order. The most common is auditory, second most common is visual, third most common is tactile. The last 2, gustatory and olfactory, are relatively rare, and you don't usually hear of them much. Now let's turn the page and talk about an illusion. What is an illusion? Well, an illusion is a misinterpretation of reality. A misinterpretation of reality. You're misinterpreting what's going on. It is a sensory experience. Sensory. Well, that's just great. Because now what 2 are we going to confuse? Because they're both sensories. Hallucinations are sensory, right? And illusions are sensory. Well, that's bad, because now how are you going to tell them apart? And that's what that next part says. Number 2, differentiation between illusions and hallucinations. In other words, how do you tell the difference between a hallucination and an illusion? Well, here's how you tell the difference. With illusions, there is a referent in reality. With an illusion, there is a referent in reality. Now let's talk about what that means. A referent, R-E-F-E-R-E-N-T, R-E-F-E-R-E-N-T, referent. What a referent is something to which a person refers when they say something. So, with an illusion, there is a referent. There's actually something there. They just misinterpret what it is. With a hallucination, there is absolutely nothing there. So it's probably best understood by illustration. If a client says, "Listen, I hear demon voices." Listen, I hear demon voices. Of what is that an example? That is a hallucination. Why? It was sensory, and there was nothing there. What about this example? A client overhears nurses and doctors laughing and talking at the nurses' station and says, "Listen, I hear demon voices." Now they said the exact same thing. Of what is that an example? Why is that an illusion? It was the same thing. They said the exact same thing. The question bothered to tell you that there was actually real people talking, making real sounds that they misinterpreted. In that case, it's an illusion. What's this? During your interview, a client stares at the wall and says, "Look, I see a bomb." They stare at the wall and say, "Look, I see a bomb." B-O-M-B. Hallucination or illusion? Hallucination. What about this? During your interview, the client looks at the fire extinguisher on the wall and says, "Look, I see a bomb." What's that? That's an illusion. Why? Was there something there? Was there a referent? Was there something in reality to which they referred? Yes, that was the fire extinguisher. So, is it really going to be hard to spot an illusion on the test? Why is it going to be easy? Because they're going to add a whole bunch of words, a whole big sentence telling you there was actually something there. And when you see all that there, you go, "Oh, that's an illusion." Okay? So it's sort of like an illusion is a hallucination with a referent, basically. Now the bigger question is letter E. How do you deal with these psychotic symptoms in a psychotic patient? When dealing with a patient experiencing psychotic symptoms such as delusions, hallucinations, and illusions, the first thing you, the nurse, must ask yourself is, what is their problem? In other words, what kind of psychosis do they have? I hope you guys were taught that there are basically 3 types of psychosis. Were you taught that? Because if you weren't, I don't understand how you're supposed to answer questions. Because these 3 different types are huge differences. The first type of psychosis is what they call a functional psychosis. Now, you don't have to know the names of all of these. You just have to know there are 3 types and what they mean. The first type of psychotic is a functional psychotic. And what do you suppose that means? Functional. They can function in everyday life. Can they have a family?
Yeah.
A marriage?
Yeah.
A relationship?
Yeah.
A job? They can do all that and live alone, take care of themselves, pay their bills, pay their taxes. They can function. But they are what? Psychotic. They can function, but they're psychotic. Now there are 4 diseases that make up 90% of this category. And they are what I call the schizo major manics. The schizo major manics. Now what are those? Schizo for schizophrenia. The second schizo is schizoaffective disorder. I hope you've heard of that. The third one is major depression. Major depression, not depression. You understand? Depression is not psychotic. Major depression is psychotic. So it has to have major there. And then manic. People that are acutely manic. So are bipolars functional? Yes. But are they always psychotic? No. They're only psychotic in what phase? The manic phase. The rest of their life, they're... In fact, you guys could be bipolars and I wouldn't even know it. You could all be bipolars for all I know. So what are the 4 functional psychoses? Schizo, major, manic. All right. Now, the next psychotic is the psychosis of dementia. Dementia. Now, what's these people's problem? Why are they psychotic? Why do they not know reality and have no insight? Why do dementia clients not know reality, and why are they not having insight? Why do they lack insight? What's that?
Memory.
Well, why is the memory messed up? Thought I heard it. Brain damage. Actual damage to the brain. The brain is actually damaged. Now, in the functional, is the brain damaged? No. It's just the chemicals are out of balance and they don't really have it. They haven't learned adaptive behaviors well. But in this case, with the dementia, there's actual brain damage. And that's why they're psychotic, the brain damage. These would be people like Alzheimer's. Do you ever know anybody that after a stroke, they're kind of psychotic after a stroke due to the damage? That would be this. Have you heard of organic brain syndrome? That would fall under this category. Anything that says senile or dementia falls in this category. And lastly, number 3, the third type of psychotic is psychotic delirium. Delirium. D-E-L-I-R-I-U-M. D-E-L-I-R-I-U-M. Delirium. And we'll talk about these people. But here's the deal. What's the first thing you must do to get a psych question correct?
Ask if they're psychotic or non-psychotic.
Psychotic or non-psychotic. If you decide they're non-psychotic, what answers do you pick? The best good therapeutic communication response. That would be true for anybody. If you decide that they are psychotic, then what step must you take?
Functional or not?
Decide which of the 3 categories that person falls in. Are they functional? Are they dementia? Are they delirious? Because you're going to use different approaches for each of these. Because not all psychotics are the same. So let me illustrate how you're going to answer questions differently. Letter F, let's talk about the functional psychotic. Does this person have brain damage? No. So number 1, this patient has the potential to learn reality. Why can they learn reality? Because they don't have any damage. They can learn it. They might need some meds to balance some chemicals, and then you might need to set some structure, but they can learn it. They can improve. Well then if they can learn it, what's your role as a nurse? If they can learn reality, what is your role as a nurse? Teach reality. So how do you teach reality? You use the 4-step process that's here. This 4-step process is the way we teach reality to a functional. First step, acknowledge feeling. Second step, present reality. Third step, set a limit. Fourth step, enforce the limit. Now, that isn't good enough for me just to tell you that. I need to illustrate to you how that would look in a question. Because boards doesn't say, what's the first thing you do? A, acknowledge feeling. They don't say that. They say, what's the first thing you'll say? And they'll give you 4 quotes. And you're supposed to pick out the one that acknowledges the feeling, or the one that presents reality, or the one that sets a limit. So what do answers look like that acknowledge feeling? If you said, oh, I got to look for an answer that acknowledges their feeling, what would it look like? How would you spot it? What would it say?
So you're saying you feel this and this?
Usually the word feel is in the answer, yes. So you'd say, or you could even specify a feeling, couldn't you? If you don't say the word feel, usually there's a specification of a feeling. For example, you'd say, I see you're angry. Or you seem upset. Or that must be distressing. Or that's so sad. Or all that has happened has been so devastating. Or tell me more about how you're feeling right now. See, all of those go to what? Feeling. And that's the first thing you do. How many have noticed that in psych, if you're between a couple of answers and one of them is talking about feeling, if you pick it, you're usually more right than wrong. Have you noticed that? Because what are you doing? Acknowledging their feeling, which is the very first thing you should always do with a functional. Secondly, you present reality. Well, how does presenting reality look like? Well, it has different forms. One of the classic forms of presenting reality says, I know that blank is real to you, but I do not blank. Do you see what I'm saying? I know that you see that demon, but I do not see a demon. Do you see what I'm saying? I understand those voices are real to you, but I do not hear any voices. Do you see what I'm saying? I understand that you think that the mafia is out to kill you, but in reality, no one is going to harm you. Do you see that? That's one format. The other format of presenting reality is just to tell them what is real. I am a nurse, this is a hospital, and this is your breakfast. Do you see what I'm saying? So you can either tell them what actually reality is, or you can just say, I know that's real to you, but I do not. Both of those are acceptable formats for presenting reality. Either one is good, but it's not the first thing you do. It's the second thing you do. Setting a limit. What setting a limit looks like is when you set a limit, the answer will say something like, that topic is off limits in our conversation. Or, when we talk together, we are not going to address that problem. Or we're not going to talk about that. And sometimes it can go all the way and be as extreme as stop talking about. That would be all right. To tell them to stop talking about those aliens. Stop talking about the voices. And you can be that strong. Or you can be strong enough to say, we're not going to talk about those voices. You see, you can be that directive and that strong. And then enforcing a limit usually takes the format of saying something like, I see you're too ill to stay reality-based, so our conversation is over. That's enforcing the limit. Enforcing the limit is ending the conversation. Enforcing the limit is not taking away a privilege. You see, that's punishing. Does everybody understand the difference between enforcing a limit and punishing them? What are you doing when you punish somebody? What actions do you take to punish? What would be bad answers that would be construed as punishing? Because you've told them to stop talking about the voices, right? And they keep talking about the voices. They violate the limit. So how are you going to? What would be a bad way to enforce it?
Negatively enforced.
Such as?
Taking away their privilege.
Yeah, you can know since you can't follow the rules, you lose your telephone privileges. You lose your refrigerator privileges. You're going to be restricted to your room. No, that's not enforcing the limit. That's punishing them. The only enforcement is ending the conversation. That's the enforcement. Why is that appropriate? Why is it good to end a conversation with them when they are not reality-based and won't stay reality-based? You're not going to accomplish anything, and by continuing to talk, what are you reinforcing? The non-reality. Okay? So how does it go? Well, let's talk about this. You have a patient who says to you, and he's schizophrenic. Does that matter? Schizophrenic. Why does that matter? It throws him in what category? Functional. And you know to do the 4-step functional process. He says, schizophrenic says to you, I'm going to kill you all. You're all going to be dead by morning. I'm going to slit your throats, and I'm starting with you. Okay? Rather paranoid, violent, delusional thinking. What's the first thing you say to him? What's that?
I understand you're upset.
Right. You could say that, I understand you're upset, or you could say, I see you're angry. I wouldn't say, how do you feel right now? Because I think I know. You know, I mean, sometimes they give you enough data in the question to kind of know what they're feeling like. Okay, so I see you are upset. Then what do you do? What did I tell you to do next? Okay, but they're not going to say present reality. What? Give me a quote. In this case, you'd say, I see you are upset.
But there are no bugs on the wall.
But he didn't talk about bugs.
Okay.
That's the only problem. That is presenting reality, but he didn't say that. He said he was going to kill us all. We're all going to be dead by morning. He was going to slit our throats, and he's going to start with me.
Killing us is unacceptable behavior.
Okay, and I think that's a great answer. I think we could go better with talking about it more positively than negatively. Rather than saying you're not going to kill anybody, I would say we're all going to be kept safe. So I would present the reality, and always try to, if you're between two things, sometimes, Derek, it comes down to one is stated positively and one is stated negatively, and you always want to, rather than saying you can't have, you're on a fluid, you're only allowed to have 10 cc's at breakfast time, you say, you can have 10 cc's at breakfast. You know what I mean? They always like you to state it positively. Like with diets, it's better to emphasize what they can have than what they cannot have. With mobility, it's better to tell them what they can do and so in every way, if you're between two answers, one is positive, one is negative, go with the positive. Does that make sense? Okay, in this case, Derek said what?
Killing us is, murder.
Killing is inappropriate and not going to happen in this situation. Versus, I see you are upset, but everybody is going to be kept safe while we're here. This is do you see? It's the same thing, only stated more positively. It's presenting the reality of what's going to happen. No one is going to get killed, right? Okay, then what do you say? We're not going to talk about that kind of stuff. We're just those kinds of ideas, although they are real to you, are off limits in our conversation. So then he keeps talking about it. I'm going to kill you. I'm going to slit your throat. I've got this knife. I'm going to shank you. What do they say? What do you then say? I see you're too ill to have a reality-based conversation, so our conversation is over. And in reality, in real life, when I work psych, I then offer them a tranquilizer. I say, and we have some medication that can help you control those things. Would you like some? And that kind of thing. A lot of times they do. And I always like to say that because I like to say, I see you're too ill. I love to say that because what's it telling them about their experience? That is a symptom of their illness. And they're gaining, I'm hoping to teach them that it's not them, it's their illness and they need to recognize what's ill me and what's healthy me. And so I always love to say, I know that's a symptom of your illness, but I see you're too ill to have a reality-based conversation. So we're done now. But I always like to say, but we have medication to help you with those symptoms. Now, again, what am I reinforcing? That's a symptom, and that this is a symptom of your illness. and it's controllable, and we have meds for it, so comply with it. Do you know what I mean? Because non-compliance is the number one reason why psych patients are readmitted to facilities, correct? So I always find that, and then I say, and they say, well, what medication? Well, like Xanax or what? Well, I don't like, okay, well, you have this. Okay, well, I'll have some of that, I guess. And it works like about 1/3 of the time. And you say 1/3 of the time isn't very good. Oh, it's a lot. I mean, that's pretty good for a psych hospital. 1/3 compliance rate. So then they do well. Okay? So that's a good way to go. Do you understand the process? Acknowledge feeling, present reality, set a limit, enforce. However, if they have psychosis of dementia, who are these people? Dementias. Seniles, Alzheimer's, brain injuries, organic brain syndromes, post-strokes. Number 1 says this patient has a brain problem, structural brain problem, and cannot learn reality. They cannot learn reality. Do you think that makes any difference?
Yes.
What about the functional? What's the positive point about functional? They can learn reality. What's the best for a dementia? They can't learn it. Do you think that difference is minor or major? Major. That's a major difference. Do you see why you have to differentiate which of the 3 categories your psychotic falls into? Because it makes a huge difference in how you deal with it. Well, how do you deal with a dementia? A psychotic dementia, a person who has brain damage, and they can't learn reality. Well, number 1, you do 2 steps. The first step is you acknowledge their feeling, and the second step is you redirect them. You redirect them. So what am I telling you you don't do? Present reality. Why is presenting reality for a dementia not appropriate? They can't learn it. And you keep trying to teach something that they can't learn. It's ridiculous. It's going to frustrate them, anger them, discourage you. You can't. They can't learn it. It's impossible. So don't try. So what do? You redirect them, and redirect means to channel them from something they cannot do to something that they can do. Why do you not set limits on their bizarre communication? It's just plain mean, isn't it? That's just mean. Now, I do want to caution you guys. Here's where a lot of people go wrong and they get confused, and there shouldn't be any cause for confusion if you understand this. With your dementias, like your Alzheimer's and your seniles, when you work with them on the unit, what do they tend to get all the time? What's a problem they always have? You ever worked with elderly dementias? What's a problem they constantly have every day related to that they forget? Where they are, where their room is, what day it is. Okay? Now, that is not psychosis. At that point, they are not psychotic. They're just forgetting. Now, when they're having delusions, hallucinations, and illusions, what are they at that point? Psychotic. Okay, now here's the thing. I told you what technique is not appropriate for a dementia client when they're experiencing psychotic symptoms. What is not appropriate? Presenting reality. Don't confuse that with reality orientation. What is reality orientation? What does that mean when you see the phrase reality orientation? Tell them person, place, and time. Is that appropriate with dementias? Yes. Reality orientation is always appropriate with dementias. Is presenting reality appropriate with dementias? No. Do you see the problem with our language that confuses people? Presenting reality versus reality orientation. 2 totally different things. Can you do reality orientation with a dementia? Yes, because you're just dealing with loss of memory. Can you do presentation of reality to dementia patients? No. Can you keep that straight? Because a lot of people are going to confuse that, and I don't want you to confuse it. Let me illustrate my point here. You have a patient with Alzheimer's. Did that matter? In the question, did that phrase matter? Why? It threw him in the dementia category. We knew they were psychotic now, and it threw him in the dementia category. So you've got a patient with Alzheimer's. She's in the waiting room, the lobby of the nursing home. She's all dressed up. It's Sunday. You say to her, Mrs. Smith, you're all dressed up. She says, yes, my husband's picking me up. We're going to go to church. Okay. Problem? Husband has been dead for 10 years. So she has a what? She thinks her husband is alive, but he's been dead. So she has a what? True or false? False. Fixed belief. So she has a what? Delusion. So she is delusional. So at this point she is what? Psychotic. What do you say to her? So what would be the first thing you'd say to her? My husband's coming to pick me up. We're going to church. What does it say to do? Okay. It says to acknowledge feeling. Okay. In this case, what would that look like? What's that? There's no feeling there, though. No, I wouldn't say are you. I would say that sounds exciting, or that sounds like an exciting thing to do, or that sounds fun, or that sounds interesting, or I mean, that don't always ask. See, a lot of times when these questions, they tell you stuff so that you are supposed to recognize the feeling. So don't always ask, what are you? Are you? Just say, I see you are happy. I see you are sad. What if it fits? Those are much better answers. Do you see what I'm saying? Because if you say, how are you feeling? They say, what do I think I'm feeling? You know what I mean? But if you say, I see, you're acknowledging it. Do you understand what's the difference between exploring feeling and acknowledging feeling? What is the difference? Or is there no difference? There's a difference. Okay, what does explore feeling mean?
Asking.
Digging, trying to find out what it is. Acknowledge means you already know. You're just acknowledging with them that you see that that's what they are. And that's what we're talking about here. Got it? Okay, then what would you say? She says she's going to church, husband driving. I see. That sounds like an exciting thing to do. Yeah, and she said, why don't we go have some breakfast while we're waiting? Now, that's redirection, but I don't know if it's the best one, because she would say, but if I go to breakfast, I'll miss him. He'll miss me. Do you see what I'm saying? And so I think it's good, but I think that you could probably say something like, well, why don't we sit down here and talk about what's going to happen at church today? Do you see what I'm saying? So while we wait, so she sits down, and then you start saying, well, what church do you go to? Who's your pastor? Who's your priest? What do you like about the service? Do you have friends there? Does your family go there? What are you doing now? That's all what? Reinforcement of intact memory. And isn't that good with dementia? And pretty soon you start getting her turned from church to family. You see, and then you say, do you have any grandkids? And then you get talking about the grandkids. And then you say, do you have any pictures? Right? And they say, yeah. Could I see the pictures? Well, I don't have them with me. Well, where are they? In my room. Could you show me? Okay. Now she's leading you back to the room to show the pictures. She's long forgotten about church and husband, and you're not having a fight. Do you see how you do it? You kind of just redirect them into things. So that's the way you go. What would be the wrong answer to say to her? That sounds exciting.
But he died 10 years ago.
But your husband's been dead. That's called presenting reality. And that's appropriate for a schizo major manic, but it stinks for a dementia. Do you see where the best answer for one is the worst answer for the other? That's why you got to know which one you're dealing with, or you're not going to know what to answer. Are you seeing this? Okay, let's talk about the third kind of psychotic, and that's the psychotic delirium. Description of this psychotic delirium. This is a temporary, sudden, dramatic, secondary loss of reality. And it's usually due to some chemical imbalance in the body. So it's temporary, it's sudden, it's dramatic, it's episodic, it's secondary, and it's usually due to some chemical imbalance in the body. Now, how is that different than functional? It's temporary. What else is different about than functional? It's sudden. How is this different than dementia? It's temporary. It's sudden. It's secondary. You see? So it's different. Now, who are these people? These would be people that are crazy for the short term because of something else causing them to be crazy. For example, have you ever seen anybody go crazy or psychotic because they're on a particular drug? They have a drug reaction and it makes them lose touch with reality. Have you ever seen that? Yeah. Tagamet will do it, as obvious as innocuous as Tagamet could do that. Another area is people that are high on uppers. You know, intoxicated on uppers, they'll be this way. Or withdrawing from downers will be this way. So delirium tremens would be this. Cocaine overdose. Methamphetamine overdose. What are some other chemical situations where you've seen people act crazy? It's temporary, it's due to some other imbalance in their body. What's that? Post-op psychosis, it's due to withdrawing from a downer. Because what's an anesthetic agent? A downer. What are the pain meds? Downers. So as you withdraw from the downers, everything goes up and you have this. Particularly in the elderly. If you have an elderly patient who's had anesthesia and a PCA pump, the third post-op day into that fourth post-op day, they can go wacky crazy for about 48 hours. Just plan on it. And then they'll come right out of it. But they will be loony as a tune. Mm-hmm. So don't start zapping them full of tranquilizers or you'll confuse them and they'll end up in a nursing home when they would have come out of it in 48 hours and gone home. Who else? Post-op's classic. What else?
If you're in ICU really, really long.
Yeah, ICU psychosis can do it with the sensory deprivation can cause it. What else?
UTI in the elderly.
A UTI, an occult hidden urinary tract infection in the elderly. Classic. Any occult infection, but the UTIs in the elderly are the major ones. Have you heard of thyroid storm? That's another one. Have you heard of adrenal crisis? It's another one. So those are your... I even think roid rage, to some extent, could be classified something like that if they're actually seeing, hearing, hallucinating, and if they're that bad, they can be that. Well, what's the good news for these people? It's temporary. So really, what's the focus of managing these people? Removing the underlying cause and keep them safe. So what is the 2 steps? Acknowledge what? Feeling. And then reassure. Reassure. Of what 2 things are you reassuring them? That it's temporary, it will go away, and they will be kept safe. So reassure them of safety and that it will go away. Why don't you present reality? They're not going to get it. Why do you not redirect them? Because it's not going to work. It's just reassure them. Let me give you an example. with all three: functional, dementia, delirium, and show you how the answer changes. Because one of the things they do on boards is they change the type of psychosis, and they look to see if you change your answer when they change the type of psychosis. Or do you always go with present reality, no matter who you're with, which is the wrong way to go. Okay, here we go. You have a patient with schizoaffective disorder who points to two people talking at a table across the room. Got the picture? Schizoaffective, they're pointing to two people talking at a table across the room. And they say, those people are plotting to kill me. What would you say? Well, what's the most important word in that whole question? Schizoaffective. Why is schizoaffective the most important word? Because it throws them in the category of functional psychotic. So what's the first thing you say to that person in that context? Those two people over there, they're plotting to kill me. I see you are frightened or scared, or that must be frightening. Then what would you say? Okay, but they don't say reality. You gotta know what it's going to look like. What is it going to say? Those people are not plotting to kill you. We're all safe. That's called presenting reality. Then what do you say to that person? Furthermore, we're not going to discuss this. And if they keep doing it, what do you say? They keep talking about the two people over there. I see you're too ill to have a conversation, so we're finished. I'll meet with you in a half an hour, and then maybe you can have a reality-based conversation. Those are all appropriate. Do you see the 4 steps? Okay, let me give you another question.
Are you supposed to remove them from that?
No, not necessarily. No, not necessarily. No, that is not the priority at that point in time. The priority is presenting the reality, setting the limit. Now, if they're escalating and they're starting to do, but there was no escalation in that question. What about this? You have a patient with Alzheimer's disease who during your conversation points to two people sitting at a table and says, you see those people, they're plotting to kill me. What's the most important word in that question? Why Alzheimer's? It puts them in what category? Dementia. So now you know you're going to acknowledge feeling and redirect. So how would we then do it? What would be the answers? That's you seem scared. That must be frightening. Now what? Redirect.
What are we going to order for lunch?
That's actually changing the subject. And redirection is not changing the subject. Redirection is going with what they're talking about, but getting it achieved in a right way.
Why don't we go somewhere you feel safer?
Exactly. That would be better than, they will have both of those there. What was your answer? A?
Why don't we go somewhere you feel safer?
Yeah, let's go. We don't like why. Okay, let's go somewhere where you can feel safe. Versus, what did you say? Let's go eat?
Lunch.
Let's go eat lunch. Why would A be better than B? It's more. A is more relevant to what they're feeling and what they're talking. B says, B kind of ignores it, but it's better than presenting reality. Do you see what I'm saying? And that's why they would put A with B, because B's a good answer, but A's better. Do you understand that? Okay. What about this question? A client with delirium tremens says to you, you see those two people over there at the table? They're plotting to kill me. What's the most important word in that question? Delirium. Delirium tremens. So that makes them delirious. So what do you say? I see you're scared. And don't say I promise.
Or I can assure you.
Well, just say you are safe. Just say you are safe, and that will go. That feeling will go away when you get better. Do you see that? You are safe. That's a symptom of your illness. It'll go away when you get better. Now, could you say to the first person who had the schizoaffective, would it be okay to say, I see you're frightened, I'll keep you safe, and that will go away when you get better? No, because they didn't learn anything, right? And you can't say it'll go away when you get better to an Alzheimer because it's permanent. So do you see where the good answer for one is a bad answer for the other? How many of you in your psych questions have up to this point basically treated all psychotics the same? Do you understand now there are 3 varieties and the answers are different? Have you ever had this experience in taking psych questions? Because a lot of people do. Like, for example, you'll get a question that says the patient is hallucinating. What are you going to do? And you go, oh, I'm going to present reality. So you pick present reality. You go back to the rationale and it says, no, you should redirect the patient. And you go, oh, that's interesting. So then you take some more psych questions, and about 30 questions later, you get another question about hallucinations, right? And they say, what are you going to do about this hallucination? And you go, oh, I know. It's what? Redirect, because that's what it was the last time. So you pick redirect. You go back to the answers, and they say, no, you should reassure the patient. And you go, what? I wish you'd make up your mind. Last time you said redirect. This time you're saying reassure him. So you take some more psych questions, and about 30 questions later, you get another question about hallucinations. And it says, what are you going to do about this hallucination? And you go, well, it's either redirect or reassure. I don't know which one. They keep changing, and I don't understand this. And then you go back and forth, and finally, after 20 minutes, you finally just pick one, and you say, well, I'm picking reassure because that's what it was the last time. You go back to the rationale. What does it say? No, you should present reality. Whereupon you yell at the computer screen and say, that's what I said the first time, and you said I was wrong. What's going on here? Why do they always keep changing the answer in psych? Have you ever felt that in a psych question? Well, why do they keep changing the answer in psych? Because they're changing the patient. And when they change the patient, you change your answer. That first one that said redirect, what was probably the patient's problem? Redirect, what was probably the problem? Dementia. The second one, which was reassure, was probably a what? Delirium. The third one, which was reality, was probably a functional, and you completely missed the point, and you're trying to figure out what's the pattern, what's the pattern. That's the pattern. Does it make sense to you? Do you think you can see, do you understand how you're going to see the pattern now? Question?
What happens, because I know you said it's functional, like the 4 different types, what happens if you have like a patient with personality disorder or somatic?
Personality disorders are not considered psychoses.
Okay.
They're considered to be access to baseline factors that come along with, just like mental retardation is not considered to be psychosis. So they are not going to classify borderline personalities. What you do with a borderline personality, probably more than anything else, is if I got a question about not a borderline, but any personality disorder, I would probably use good therapeutic communication skills. Now, are they sick? Some of them are real sick little puppies. But they're not classically psychotic. Do you understand what I'm saying? And the only ones where I would really use the presentation of reality is with There are 3 personality. The personality disorders go in clusters. There's clusters, 3 clusters.
Obsessive compulsive is in the last one.
Right.
Yeah.
ABN. Okay, that's okay. Thank you. I kept thinking ABD, ABN, ABC. It's what ABN. The letters ABN are an abbreviation for what word? ABN. Abnormal. So I tell people the really abnormal personality disorders are the ABNs. Antisocial, borderline, and narcissistic. Those are the real sickies. The histrionics, the obsessive compulsives, the dissociative, the schizoid, they're no big deal. But your ABNs, your antisocials, your borderlines, and your narcissists, they're the real sick personality disorders. They're the ones that have real problems. And that's where I would probably treat them more like a functional. But for most personality disorders, I would just use good communication skills, basically. The reason why I like the functional protocol for the ABNs is I end up setting what? Limits. And with an ABN, an antisocial, a borderline, and a narcissist, you got to set limits. So that's why I like it with them, because I like to set those limits on those people.
The scores asked us about access, like what was
Oh, heaven. Oh, you mean the multi-axial assessment, access 2, 1, 2, 3, 4, 5? That would not be essential knowledge for you to know. That would be a question that would be hard. But Axis 1 is the primary psych disease. Axis 2 is only really 2 things. Mental retardation and personality disorder. Really, that's about all they'll ever put in Axis 2. 3 is medical conditions, not psych conditions like diabetes, whatever. 4 is psychosocial factors like unemployed, recently divorced, newly married, just had a baby, those kinds of things. And 5 is a score. Ranges from 0 to 100. It's a number, like 35, 52, and it's an estimation of how high you're functioning. 100 being perfect psychological functioning like me, and then 0 being completely disorganized person. You know what I mean? So it's 1 is your primary diagnosis, 2 is 2 things. 1 is your primary diagnosis, 2 is 2 things, retardation and personality. 3 is medical, 4 is psychosocial, and 5 is a score. But that's all I really want you to know. I haven't heard people reporting that those are on there. Okay, hopefully has this changed the way you're going to look at psych questions? So what's the first big task you have with a psych question? Psychotic or non-psychotic? If you know it's non-psychotic, use what?
Good.
If it's psychotic, you have further work. You have to divide it into what? 3. For the 3, the first step, for all 3, the first step is what? Acknowledge feeling. The second step always starts with the letters RE. Reality, redirect, reassure. And now, isn't it true, now when you think back on psych questions, isn't it true that most psych questions, one answer will be reality, B will be redirection, C will be reassurance, and D will be ignoring? And you see the game they've been playing all this time? Okay. All right. Let's talk about 3 more psychotic symptoms and we'll take a break. Loosening of association. Loosening of association is the fancy way of saying your thoughts aren't wrapped too tight. In other words, your thoughts are all over the map. Loosely associated. The first one is flight of ideas. This is when you go from thought to thought to thought to thought. You actually make phrases. You actually say phrases that are coherent. But the phrases are not tightly connected. In other words, each phrase by itself is coherent. But the phrases together are not coherent. Do you understand what I mean by that? It's a lot of ideas. Whereas word salad, they are sicker. They can't even make a phrase that's coherent. They just babble random words. So who's sicker, flight of ideas or word salad? Word salad. Neologism means making up imaginary words. So they'll say, you're a Brinslabik, or you're a Shabazniak, or the Krenulaks are attacking. They're making up all these new words. Robin Williams makes a fortune on humor based on loosening of association. He can do flight of ideas at the drop of a hat. He can, remember Mork and Mindy? That dates me. Probably you guys don't even know what in the world I'm talking about. Unless you watch Nick at Night. But he used to say Nanu, Nanu, and Shazbot. Those were never in the script. He just neologistically did that on the spot, and they said, "Oh, that's cool. Let's add that in." Because he just completely. Did you ever see him do just stream of consciousness? He can just do it like Good Morning Vietnam, all that flight of ideas stuff going on. So that's sort of it. He's also bipolar. That's why he makes like 6 movies in 2 years, then you don't see him for 3. Currently, you're not seeing him, but he will come out in a year and a half with 3 movies to be released that he made in 3 days. Okay, narrowed self-concept. Narrowed self-concept is when a psychotic, and that's key, psychotic, when a psychotic refuses to leave their room or change their clothes. If you've got a psychotic who will not leave the room and not change their clothes, and I would say it is a functional psychotic. The reason why they're doing it is why. Why is the functional psychotic refusing to change their clothes and refusing to leave their room? Why?
Control.
Not so much control, although that could be an issue. Paranoia could be another explanation, but it's not the number one. Think of narrowed self-concept. What would that mean?
Not worth it.
What's that?
Not worth it.
That would be sense of, that'd be low self-esteem.
Yeah.
This is narrowed self-concept. Your self-concept is how you define who you are. And how they define who they are is extremely narrow. Meaning they define who they are based on what 2 things? Where they are and what they're wearing. So the reason why they refuse to change their clothes and leave the room is they don't know who they are unless they are wearing those things in that room. And that's why they won't change it, because it terrifies them. So, as a nurse, would you make a functional psychotic who is refusing to leave their room and change their clothes, would you make them do it? Why? If you made them do it, they would cease to know who they were. You would have a panic escalation. Somebody would get hurt. So you do not do that. So what do you tell them when they refuse to leave their room and change their clothes? What do you tell a functional psychotic? I see you are uncomfortable or upset. You do not have to change your clothes or leave the room until you feel comfortable or until you're ready. And it's a perfect world so they can stay there for 30 years if that's the case. Don't say, well, they can't stay. I mean, that won't work because what if it's 3 weeks and they still don't feel comfortable? They won't be able to stay in the hospital that long. Hey, it's a perfect world. Yes, they can stay that long. However, what if they say this? Mrs. Jones has been depressed since her last child went to college 3 months ago. She has no energy to do the housework. She has lost her job because she didn't have the energy to get up and go to work. She says, I hate the way I feel. I am going to kill myself if things don't get better because this depression is ruining my life. Please help me. She is refusing to leave her room or eat her breakfast or do her daily hygiene care. What do you do?
Acknowledge how she feels, and then reinforce the reality that she needs to be.
Okay, but see, now you're taking the 4-step process for a psychotic. And this lady is a what? She's a non-psychotic. She's a non-psychotic. She just said depression. She had insight, right?
So you don't have to read into it if it's major or not?
If they don't say major, it isn't major.
Okay.
They have to specify major.
Okay.
So what do you use? Good therapeutic communication skills. But what do you say? I see you are depressed and feeling down, but what? What if a surgical patient is refusing to get out of bed after surgery? What do you do? Do you say it's okay? They can stay in bed all day?
Maybe you'll feel
What do you
better
tell
if
them? Do you get them up and out?
Yeah, I say say, maybe you'll feel better after you get up.
Yeah, but that's a guarantee. Maybe you'll feel better because they could walk and feel worse, and then now they don't trust you. You know what I mean? So what you would say is something like, it's time for you to shower, come with me, we will do. You're very, directive, because she doesn't have the energy to do it.
Tell them.
What's that? Tell them. Yeah, just like you would a post-op who won't get out of bed. Okay, now put your foot over the bed. Okay, now I'm going to raise you up. Now put your feet on the floor. Now, okay, now stand up. You know, you're very directive because they're not what? Psychotic. So what's my point? What is similar about those two situations I gave you? And what's different? The one was psychotic, had the narrowed self-concept, was refusing to leave his room and change his clothes. The other one was non-psychotic, depressed, who was refusing to leave the room and change their clothes. One, I told you what? Do not push them. Do not make them. With the depressed, what do? You force them. You make them. If they don't make choices, you make choices for them. You understand? The only time you're allowed to make choices for patients is with depressed, psychomotally retarded patients. You see? So, do you see the difference in the answers? Because your patient changed? Okay. Ideas of reference, that's when you think everybody's talking about you. For example, if two people were out there in the hall and they were talking, if I had ideas of reference, I'd think, what are they saying about me? Now, psychotics have really take this to the limit. I had one psychotic patient at Twin Valley where I took care of her. And every evening when Katie Couric came on the news, she'd take her shoe off and throw it at the TV and call Katie all kinds of choice names and say, why are you lying about me? I was never in New Mexico. I could not have done that. What did she have? Ideas of reference, because she thought Katie Couric was telling stories about her when it had absolutely nothing to do with her. That's ideas of reference. Do you remember that I said about the people that pointed at the table and said, those people are plotting to kill me? That's paranoia plus ideas of reference. And we dealt with it 3 different ways depending on who the patient was, correct? Okay. Take a break, come back at 10 till, and we'll do diabetes. Yo.
Pretty West teaching people how to write reflection statements.
No, I never was. I've never been to. Of all the diseases you should know diabetes. I'm not one to tell you to go learn all these laundry list of diseases, but you do need to know your diabetes. So let's talk about it. Definition: diabetes is an error of glucose metabolism. You don't metabolize your glucose well. That's what diabetes is. You cannot metabolize glucose for whatever reason. Sometimes it's a lack of insulin. Sometimes the cells become resisting to insulin. For whatever reason, you cannot metabolize glucose. Now, the problem with glucose is it's your primary fuel source. So diabetics get into trouble because they can't metabolize or use the primary fuel source. And without that, cells die. And that's why it's very bad. Now, don't confuse it with diabetes insipidus, because diabetes insipidus is a totally different disease. Diabetes insipidus is not a type of diabetes mellitus. It's a totally different disease. Diabetes, in the parenthesis, I want you to put diabetes insipidus is polyuria, polydipsia, leading to dehydration. Due to low ADH. Due to low ADH. So when you get a question about diabetes insipidus, and they want to know what you see, what do you see? Polyuria, polydipsia, and dehydration, which looks a lot like diabetes mellitus, doesn't it? Because it has polyuria, polydipsia, and dehydration. So they look alike even though they're not the same thing. That's why they share the same first name, diabetes. So if you're sitting there and you can't remember what diabetes insipidus is, what's the best way to remember?
Dehydrated.
It's like diabetes mellitus, only just with the fluids. It's just the fluid part of diabetes mellitus. You don't get the glucose part. You just get the fluid part. And it's due to a low ADH. So what they'll ask you about diabetes insipidus is, a lot of times with diabetes insipidus, what they would ask you is, do you have a low urine output or a high urine output? And what you should say is, oh, okay, wait, diabetes insipidus, it's not diabetes, but it's like diabetes mellitus, and diabetes mellitus has a high urine output, so diabetes insipidus has a high urine output. Do you see how I want you to remember it? Now, what is the opposite of diabetes insipidus? What's the opposite syndrome of diabetes insipidus called? SIADH. So here's what I do. I don't memorize SIADH. And I don't memorize diabetes insipidus. Why? But I get the questions right. How can you get the questions right on SIADH and diabetes insipidus and not memorize them? Everybody knows that diabetes mellitus has what? Polyuria and polydipsia, right? You should know that. So therefore, diabetes insipidus has what? Polyuria and polydipsia. So SIADH is the opposite. So instead of polyuria, they have low urine output, oliguria, and they are not thirsty because they're retaining water. Do you see that? So if they said to you, who gains weight? Diabetes insipidus, diabetes, who gains weight suddenly? Diabetes insipidus, diabetes mellitus, SIADH. SIADH. Why? Because diabetes insipidus and diabetes mellitus lose water. Right? And when you lose water, you lose weight. SIADH is the opposite. So who would have a urine output of 200 milliliters per hour for 3 hours straight and a normal blood glucose? Who would have diabetes insipidus? Who would have an output of 200 milliliters an hour for 3 hours in a row with a glucose of 280? Diabetes mellitus. Everybody says mellitus. I just am from the East Coast, so I say mellitus. Who has 10 cc's of urine out in 3 hours and a normal blood glucose? SIADH. Do you see how I'm saying? I want you to memorize that because boards does test DI and SIADH regarding urine output. So the two diabetes look alike urine output wise. The SIADH looks opposite the two diabetes urine output wise. What's the relationship between amount of urine and specific gravity of urine? What's the relationship?
Opposite.
It's inverse or opposite, meaning the less the urine out, the higher the specific gravity, the more urine out, the... So what specific gravities would SIADH have? SIADH is opposite the diabetes. The diabetes, do they have more urine or less urine? Diabetes. They have more. SIADH would have less. So if the urine volume is going down, the specific gravity goes up. So it would have a high specific gravity. Whereas diabetes insipidus, well, that would have what kind of a urine output? High, because the two diabetes have high urine output. So if the urine output is high, the specific gravity is low. So do you see how you're going to do this? And if you know the specific gravities and the urine volumes with the SIADH and the DI, you're ready to go with those two diseases. That's all they're going to test. So who would have the nursing diagnosis, fluid volume, of SIADH, DI, and DM? Which would have fluid volume deficit? Now think it through. Fluid volume deficit would be, what would you be doing with your output if you ended up with low fluid in your body, high output, and those would be what? DM and DI. Who would have fluid volume excess? SiADH. Do you see how I want you to think it through? Okay. I always find if you link things with other things you know, it's a lot easier to remember them than just remember them separately. Okay, let's dive now into, let's quit talking about the pituitary. Let's talk about diabetes mellitus directly. The types, type 1 versus type 2. You have to know these. They will expect you to know the differences between type 1 and type 2. Type 1 has 3 names. Insulin dependent, that's the I. Insulin dependent. J is juvenile onset. And K is ketosis prone. Ketosis prone. Ketosis prone. Now, one of those 3 will not be used after April 1. Which name will not be used after April 1? Juvenile onset. Okay, type 2s. The names are all of those. So instead of insulin dependent, it is non-insulin dependent. Instead of ketosis prone, it is non-ketosis prone. And instead of juvenile, it is adult. Which of those 3 will not be used after April 1? Adult onset. So you'll actually have to memorize less after April 1. C, the signs and symptoms. You must know the 3 P's. Polyuria, polydipsia, and polyphagia. P-H-A-G-I-A. P-H-A-G-I-A. Polyphagia. What does polyphagia mean? What's it mean? I can't hear.
Thirsty.
Thirsty is polydipsia. What's polyphagia? Increased appetite. But technically, no. Polyphagia does not mean increased appetite, although we use it to mean that. What does polyphagia actually mean? Increased swallowing. Now, if you eat a lot, what are you doing? Increasing your swallowing. But I want you to understand that that's not, when they say polyphagia, they are not always talking about eating a lot. For example, would polyphagia be a sign of increased bleeding after a tonsillectomy? Yes. And they're not talking about eating a lot, they're talking about swallowing a lot. See, so you understand, polyphagia technically means what? Swallowing a lot. In the context of diabetes, it's talking about eating a lot. The polyphagia only means eating a lot in this single context. Everywhere else, polyphagia means frequent swallowing. Okay? Treatment. If you don't treat type 1s, they could die. D-I-E. D for diet, I for insulin, and E for exercise. You treat diabetic type 1s with diet, insulin, and exercise. Of the 3, which one is the most important treatment modality? Insulin. By far and away, insulin is the most important. Which one is the least important of the 3? Nope. Diet. We do not mess around with type 1's diets anymore. We pretty much let them eat generally what they want. They count their carbs, they do their AccuCheck, and they give themselves the insulin accordingly. We don't restrict their diets like we used to. Now, we do tell them to lay off a bunch of refined carbohydrates, like, pure sugars. But they can even eat those nowadays, as long as they count their carbs and give themselves injections of insulin, according to their AccuChecks. However, the type 2s are different. Type 2s, if you don't treat them, they end up DOA. That doesn't mean dead on arrival. What that means is D for diet, O for oral hypoglycemic, which is the pill, and A stands for activity. Okay, of those three, which one for a type 2 is the most important treatment modality? Diet. So what is the least important for a type 1 is the most important for a type 2. It's a huge difference. In fact, most physicians would like type 2 diabetes to be controlled with diet alone. They would really, really like that. I don't know if anybody watches Biggest Loser ever, and they'll say, I had diabetes and I don't have diabetes anymore. No, you still have diabetes. You're just controlling it because you're losing weight. Is anybody watching the current season? I'm not really watching. I just watch it every so often. There's a girl there on there, and she's wearing an insulin pump. You see it's like taped here, but they don't show it a lot, but she's wearing an insulin pump. And she's still over 200 some pounds. It'll be interesting when she gets down. Do we not see that anymore? Because probably we won't. We'll probably won't see that pump there anymore. But she is a type 1, so it may not work. But it'll be interesting. A lot of people, diabetes can be controlled with just diet alone, particularly type 2s. Okay, turn the page and let's talk about diet, insulin, and exercise more in depth. When we talk about diet, who are we talking about primarily? Which type? Type 2s. We're talking about type 2s. Letter A, it is a calorie restriction. The primary dietary modification we make with type 2s in their diet is to restrict their calories. That's the primary thing we do. Hence, you get things like the 1,200 calorie ADA diet, the 1,800 calorie, the 1,600 calorie. So it tells you that calories are important because that's how it's named. So a calorie restriction is the most important part of a diabetic diet. Letter B, they need 6 small feedings a day. So if they have 1,800 calories, how do you split that 1,800 calories? Into 6 separate feedings. Because what does that do? Yeah, it keeps it level so you don't get these big peaks. Because if you chalk that all in 3 meals, you're going to have these 3 big peaks. But if you do it in 6, you're going to have, it's going to be more level. And therefore the blood glucose is going to stay more normoglycemic. Which one would be best? What if you got a question like this? You have a type 2 diabetic. What is the best dietary action to take? A, restrict their calories to an appropriate level. B, divide their food into 6 feedings a day. Okay, now, don't jump to conclusions because you have to understand this is a best question, right? And in a best question, how many do you get to do? 1. And if you say you're going to do 1, you're not going to do the other. In fact, you're going to do the opposite of the other. So if you pick A, all right, they're going to follow their calorie restriction, and it's 1,600 calories, all right? If you say, I am going to give them 1,600 calories a day, what does that mean you're not going to do? They're going to get it, what? In 3, just going to get 3 meals a day, and they're going to get 1,600 calories in 3 meals because we're not going to split it in 6. That's what you're saying if you pick calorie restriction as your best answer. Okay, let's see what you're saying if you pick 6, split it into 6 meals, 6 feedings. Okay, if you pick that, you're saying what? I'm going to split it into 6 feedings, but what? But they can eat as many calories as they want. So what would be better for a diabetic? To get 6 feedings a day, eating as many calories as they want, or to eat 3 meals a day following their calorie restriction? What would be better?
Strict calories.
So what is the best answer? Calorie restriction. Do you see what I'm saying? And you have to be, because usually when you shout out an answer or you jump to an answer without the thinking, you tend to go to the wrong one. So think it through. Do you see what I'm saying? Are you understanding this process that I'm teaching you about how to deal with best questions? How do you deal with a best question? Narrow it down to how many? 2. If you can narrow it down to 1, what should you do? Pick it. Okay? But everybody tells me they can only narrow it down to 2, and then they don't know what to do. Well, if you narrow it down to 2, then what do you say? I will do this one, but not do that one. And then flip it around. I'll do that one without doing this one. And one of those you'll like better. So pick the answer that's you're going to do in the one you like better. Question?
Would that still be the same if you're talking to a patient who's like 400 pounds and is used to, like, let's say their baseline is 4,000 calories a day.
Okay.
But they have been real good at splitting those up into 6 meals.
Okay.
Would that still be accurate to say they need to slash those like instantly into 1,800 calories?
Okay, write the question.
You have
Are you talking about a question, or are you talking about what do you do in real life?
I'm saying, yeah, for like a board's question, if you have,
Okay.
you know, like in
Write the question, and then I'll give you the answer. But I need to know how you're going to phrase the question here.
what would be more preferable for a 400-pound patient
400 pound
whose baseline is 4,000 calories
a day.
to help control their type 2 diabetes?
Okay.
What is the best answer?
Okay, what's the best answer? Now, if the answers are reduce them to 1,200 calories versus teach them to separate the calories into 6 meals. And they're talking about starting, I might seriously question the 1,200 calorie because it's such a big, huge drop initially. But the best would be to drop to 1,200 calories. The best answer still is 1,200 calories. But I probably wouldn't do it first. Remember yesterday I said there's a big difference between a first and a best. So if they said to me, what would you do first? I'm not dropping him to 1,200 calories first. I'm going to teach him how to separate it. Then I'm going to start whittling down each time to get him there. Does that make sense?
Yeah.
So I think in your case, the 6 meals would be the first thing you might do in that scenario. Okay. But see, the only time that works is when you wrote that scenario specifically that way, which boards doesn't get that picky. They go more general because they want to know, if you miss it, did you not know what to do generally? Then they can say you shouldn't pass. Do you see what I'm saying? Because if you didn't know what to do in some specific unusual occurrence, if you miss it, they can't really fault you because nobody else knew it. Does that make sense? Okay. The problem is in school, you guys are given all these bizarre questions that are tricky, and they add this in, and they say, aha, but you forgot about that. So you miss it, and you get socialized into thinking that's the way. But on boards, they don't do that. I mean, boards is, but if you have to trust that boards is fair. And it really is. They're well-tested questions. Okay, does that answer the question?
Yeah.
Okay. Let's see. Insulin. Insulin acts to do what to the blood glucose? What does insulin do to the glucose level in your blood? Lower. It lowers the blood. That's good to hear. I went to a school one time and asked that question, and everybody said, raise. And I thought, oh boy, I have my work cut out for me here. So insulin acts to lower your blood glucose. Now there are 4 types of insulin you need to know. Now there are many, many types of insulin, but there are 4 that you really need to know for boards. You don't need to know Exubera, Byetta, Apidra. You do need to know R, N, Lispro, Humalog, and Lantus glargine. So let's talk about these 4. regular insulins, the ones with the big bold R on the bottle, it has actually lots of different names. It could be Humulin R, Ileton R, Novolin R. The name is irrelevant. What is important is that big bold letter R. That means it is regular. Its onset is in 1 hour. Its peak is in 2 hours. Its duration is 3 hours. It is clear. It's clear. In the bottle, it's clear. So it's a solution. So it can be IV dripped. This is the insulin you use when you use IV drip insulin. Now, Hesse will call this an intermediate acting insulin. The product insert that comes with the bottle from the manufacturer that the FDA approves says it is a rapid short-acting insulin. So I don't know why Hesse insists on changing the FDA's classification. But if you learned that it was intermediate, it is still considered by the FDA and the product insert as a short, rapid-acting insulin. Why do you think a lot of people are starting to talk about regular not as a short, rapid, but as an intermediate?
Because they use Lispro.
Exactly. Because 5 years ago, 10 years ago, we didn't have Lispro. And the fastest one was regular. Now we have Lispro that works in 1/4 the time that regular does. And it's kind of silly to talk about Lispro as being the same time phase as R, isn't it? But I really believe that if boards ask you, is R short, rapid, or intermediate, you should go with what the FDA and the product insert says, not what Hesse says. Do you see what I'm saying? Or Hesse's books, anything from Elsevier will say it's intermediate. Okay. All right. NPH insulin, N, is truly an intermediate acting insulin. It's a true intermediate acting insulin. Its onset is in 6 hours. Its peak is 8 to 10 hours. And its duration is 12 hours. It is cloudy. It is a suspension, as all cloudy things are. They are not solutions. Cloudy things are suspensions. Clear are solutions. Cloudy are suspensions. And the bad thing about a suspension is a suspension precipitates, meaning the particles fall to the bottom over time. So you cannot give this drug IV drip, or you will overdose them and their brain will die. But there's a general rule, never put anything cloudy in an IV bag, right? When I have students clinically, I'll teach them something that can help them a little bit. When they pull out an R, a bottle of R from the shelf or the refrigerator, I'll say, what does that R mean? And they will say, regular. And I will tell them, no, it doesn't. Whereupon they start to panic. And I say, wait a minute, I'm just trying to teach you something here, so don't panic. Yes, it does mean regular, but I'm trying to tell you that R really means two other things. That R stands for rapid and run. Rapid meaning it's what? Fast acting, and run means run at IV. They will pull out the N bottle, and what's the first question I ask them? What does the N stand for? And they'll say NPH, and I'll say no. And they'll start to panic, and I'll say, wait a minute, I'm just trying to teach you something here. That N actually stands for two other things. Do you know what that N stands for? Not so fast. Not so fast, which means it's what? Intermediate. And not in the bag, which means you never put it where? IV. Because I want my students, the minute they pull that N off the shelf, what do they say? It says a big N on it. And they say what? Not so fast and not in the bag. So they will never what? Draw it up and stick it in an IV bag because they know N is not in the bag insulin. Actually, my students will forget that it's NPH. They'll call it not in the bag and not so fast insulin. And R, they'll call it rapid and run insulin. And I think that's kind of functional. It kind of works. All right, now, let's talk about the onsets, the peaks, and durations of these famous insulins. Look at the pattern. What do you see as you read across the page? 1, 2, 4, 6, 8, 10, 12. 1, 2, 4, 6, 8, 10, 12. What are you counting on?
Yeah, you said 3. Let's get 4.
Did I mess up something? What did I say? Okay, the regular onset is, 1. Peak is 2. Duration is 4. I'm sorry, did I say 3? I was thinking Lispro. I'm sorry. So it's 1, 2, 4, 6, 8, 10, 12. Do you hear the even numbers? So what's 1, 2, 4? Regular. What's 6, 8, 10, 12? N. So just remember 1, 2, 4, 6, 8, 10, 12. 1, 2, 4, 6, 8, 10, 12. Which of those will they test the most commonly? Of those, no, they test N and regular equally. The peaks. They test the peaks. So what do you really have to remember? 2 and 8 to 10. The way they'll test it. In fact, how do they test it? You tell me how they test it. What does the question read like?
Give you time, blood sugar, and
You gave 30 units of N at 7 in the morning. Then what do they ask? When would you check for hypoglycemia, which means low sugar? Well, the low sugar is going to be when the med's at its peak. So that's the way they ask for the peak without ever asking about the peak. They ask about hypoglycemia, which is the peak. So if you gave N at 7, when would you check for hypoglycemia, which is the peak? N. You gave N at 3 p.m. to 5 p.m. Somewhere between 3 and 5 p.m. Or late afternoon, they would say. See how that works? Take the peak, add it to the time they gave it. That's when you check for the hypoglycemia or the peak. Humalog, Lispro, the world's fastest acting insulin. Its onset is in 15 minutes. It peaks in 30 minutes, and its duration is 3 hours, 1533. So when do you give this insulin? As they begin to eat. So you give it with meals, not AC. What does AC mean? PC means after meals, post, PC. A means ante or before. So AC means before the meal. Do you give Lispro AC? Before the meal? No. You give it with the meal. So be real careful with your words there. The word before is wrong. The word with is correct. I tell my students, if you're not interrupting their meal to give them their Lispro, you're doing it wrong. You don't give it when the trays arrive on the unit, because it may take another 15 minutes till they get passed. By then, the Lispro is already working. And then you can't arouse them to eat, because it's peaking. All right. Lantus. Lantus is a long-acting insulin. It is called Glargine, Glargine. And nowadays, they're most likely to call it Glargine rather than Lantus. Glargine. It's a long-acting insulin. It is so slowly absorbed, it has no essential peak. It is so slowly absorbed, it has no essential peak. What that means is this one has low risk for hypoglycemia. Little to no risk of hypoglycemia. So this drug is the only insulin you can safely give at bedtime, because they will not go hypoglycemic during the night with this one. The others you cannot give at bedtime. The only time you can give the others at bedtime, well, you never give N at bedtime. But the only time you can give R or Lispro at bedtime is if what? Your Accucheck said they were sky high, then you can give it. But you wouldn't routinely give Lispro or regular at bedtime. You can give Glargine routinely at bedtime, regardless of the glucose. Duration is 12 to 24 hours. So those are the main insulins and what they're going to test. Letter B, check the expiration dates on your insulin. Please, that's important. What action by the nurse invalidates the manufacturer's expiration date? What action by the nurse invalidates the manufacturer's expiration date on the bottle? What's that? Opening it. Opening it does. The minute you open a vial of insulin, what is now no longer valid? So the manufacturer's expiration date is only good as long as it's still closed and sealed and unopened. Once you open it, now the manufacturer's date is irrelevant. What becomes the new expiration date is 30 days after that. And make sure you write on the bottle that date, and make sure you write EXP or opened. Why do you need to write opened and then the date, or EXP and then the date? Why can you not just write the date on it? Well, if I come along and I see a date, I don't know if that's when you opened it, and I don't know if that's when it expires. So when in doubt, I will throw it out, and I'll throw that insulin away. So you put EXP and a date, or opened and a date, okay? Make sure you're clear. Refrigeration is optional, meaning you don't have to refrigerate insulin in the institution. But you do have to teach patients to refrigerate their insulin at home. Now, in the hospital, the insulin that probably should be refrigerated are the unopened vials. However, once a nurse opens a vial, two things happen. Number one, the manufacturer's expiration date is no good anymore, and you got to write a new expiration date on it. And number two, it now does not have to be refrigerated in the hospital. So if they said to you, what's the most important thing, the best thing to do when you are dealing with insulin in the hospital? In your between, check the expiration date before you give it and refrigerate it when not using it. What's the best answer? Well, you'd have to figure that out. If you pick check the expiration date before you give it, you're not going to do the other one, which was what? So you're going to check the expiration dates but leave it out of the refrigerator. Or you will what? Refrigerate it and not check any expiration dates and maybe give expired insulin. So it would be better to give cold expired insulin or warm non-expired insulin. Warm non-expired. Do you see what I'm saying? So the answer, best answer is expiration date. Okay, exercise potentiates insulin, which means does the same thing as. Potentiates means does the same thing as. I want you guys to think of insulin, I want you to think of exercise as another shot of insulin. Whenever the question says, and he exercised, what do I want you to replace those words with? And he got another shot of insulin. She's going to play soccer this afternoon. Replace that with what? And she's going to get another shot of insulin this afternoon. He has gym class this morning. He's going to get an extra shot of insulin this morning. Do you see what I'm saying? So if that's the case, If you have more exercise, what's that mean? More shots of insulin, you actually need less insulin. But if you have less exercise, you need more insulin because exercise is like an extra shot of insulin. So if a diabetic is going to play soccer in the afternoon, what should the school nurse do? He's going to get an extra shot of insulin, so he better what? What should he take to the game? Rapidly metabolizable carbohydrates, right? As a snack before the meal, before the game, and during the game. Okay, sick days. Diabetics get sick for other reasons besides their diabetes, like they get the flu, they get diarrhea, they get otitis media. What do they do when they're sick? Well, when the diabetic is sick, their glucose is going to go up. It'll never go down. It always goes up. So they have to take their insulin, even though they're not eating. Because a diabetic, let's say a diabetic gets the GI flu and he is nauseated and he's throwing up and he's not eating. What's he going to say? Well, I'm not eating, so I shouldn't take my... Do you hear why but that's wrong. Your glucose is going to go up even if you're NPO, when you're under the stress of illness. So they take their insulin, even though they're not eating. Number 2, take sips of water because they're going to get dehydrated. Diabetics get dehydrated. It probably would be worth your while to remember that a sick diabetic has 2 problems: hyperglycemia and dehydration. Any sick diabetic is going to have those 2 problems. So just count on it. Hyperglycemia and dehydration. Always. Every sick diabetic will have those problems. And then stay as active as possible. Why? It helps lower the glucose. And they're a sick diabetic, even if they're not eating, their sugar's going to go which direction? Up. All right. Now before lunch, we're going to go to lunch at noon. Before lunch, I want to cover the complications of diabetes, and we'll see where we're at after that. There are 3 acute complications of diabetes and a boatload of chronics. Let's talk about the acute complications first. You should never go to boards not knowing this, because they test this all the time. You have to know your signs and symptoms and treatment of the 3 acute complications of diabetes mellitus. The first one is low blood glucose in a type 1 or a type 2. It's called insulin shock, insulin reaction, or hypoglycemic shock, or hypoglycemia. It has bunches of names. It means their sugar is low. Their glucose is low. Now, what in the world would ever cause a diabetic's glucose to go low? That's a good question. Because when a diabetic isn't sick, but has diabetes, what does their sugar run? High or low? High. And when they get sick, it runs even higher. So if you're well, it's high, and if you're sick, it's even higher. So how in the world could it ever go low? Great question. Well, here are the causes. Not enough food, too much insulin or medication, and too much exercise. Wouldn't those all make the sugar go down? However, one of them is the primary cause. Which one is the primary cause? Too much medication. In fact, I would say that it is impossible for a diabetic to have a low glucose without being over-medicated. So over-medication is the number 1, almost sole cause of hypoglycemia in diabetics. The danger here is brain damage. And the bad thing about brain damage, it's permanent. So this is no small thing. You can destroy people's lives as a nurse by over-medicating them with insulin. You can take an alert-oriented person like me and cause me to be in a persistent vegetative state in a nursing home for the rest of my life because you made one mistake with insulin. Okay? What were the signs and symptoms? The signs and symptoms you must know because boards will want to see if you can pick up hypoglycemia just by looking at the patient. Now, the easiest way I know to memorize the signs and symptoms of hypoglycemia are drunk in shock. Drunk in shock. Now, what am I talking about on this one? Here's what I'm saying. Most of you guys in here know what drunk people look like. Okay? So what does a drunk person look like? Describe it for me.
Staggering.
Staggering gait. Slurred speech. Judgment. Poor judgment. Impaired judgment. Reaction time. Delayed. Emotions. Drunk person's emotions. Talk to me. Okay, but they won't say all over the place. They'll use a fancy word called labile. L-A-B-I-L-E, which means all over the place. Laugh, cry, laugh, cry. Could they be a little obnoxious and belligerent? A little bit loud? Decreased social inhibition? Those are all signs of hypoglycemia. So anything that would characterize a drunk person will also characterize a hypoglycemic person, because both people are having cerebral cortical compromise. Now, the other part of the picture is shock. They also look like they are in shock, which is the vasomotor part of the syndrome. So what does a person in shock look like? Low blood pressure, tachycardia, tachypnea. What else? Skin, cold, pale, clammy. Could it be mottled in the extremities? Patchy, yeah. So, what I want you to do is, I'm assuming that everybody in here knows what drunk people look like. And I'm assuming you know what shock looks like. So I'm saying to get hypoglycemia, all you do is add those two. Drunk plus shock. So I don't want you to memorize any new list. Just derive the new one from two old ones you already knew. So drunk is drunk, shock is shock. Add them together, you get hypoglycemia. So when you get a select all that apply for hypoglycemia, what do?
Look for the drunk and the
Go through and
shock.
select everything that applies to whom? A drunk, and then select everything that applies to a person in shock. And I'm not talking about anaphylactic or neurogenic or septic shock. I'm talking about shock, generic, basic, oh my goodness, I'm bleeding to death shock. All right? Well, what do you do for it? Number one, administer rapidly metabolizable carbohydrate, i.e. sugars. If boards says, if you're looking for the word sugar and it's not there, they probably are saying rapidly metabolizable carbohydrate, because that is synonymous with the word sugar. Now, what would be some examples of a rapidly metabolizable carbohydrate that you could give in a hypoglycemic situation? Any juice. There's nothing magical about orange. It could be apple, grape, pineapple, guava, pomegranate, grape. What else besides fruit juices? Now what? Low calorie, sugar-free pop? No, regular pop. Mm-hmm. Which a lot of times they go, oh wow, cool. I get to have pop. What else? Chewed up candy. Let them chew it up. What else? What? Well, no, crackers don't have enough sugar. Milk is great because it has lactose, so it's got the sugar. Honey, icing, jam, jelly, those are great rapidly metabolizable carbohydrates. Okay, however, boards really want you not to give just a sugar. They want you to give an ideal combination of foods, which is the next point. What is the ideal combination of foods? You want a sugar plus a starch or protein. That's where the crackers come from. The crackers are the starch, the orange juice is the sugar. Orange juice and crackers, good job. Because you got the sugar and you got the starch. Or you could say apple juice and a slice of turkey. Because what would that be? Sugar plus protein. Which is why the milk is so fantastic. Because when you drink milk, what are you getting? Sugar and protein, which is perfect. But you use skim milk because you don't want them to burn fats for the ketones, right? So it's 1/2 cup skim milk. Fantastic answer for hypoglycemia. 1/2 cup skim milk. What's a bad answer? What's a bad combination of foods to give them? What would be a bad combination of foods to give them? Such as? No, not carbs. No. Carbs was too broad.
Like candy with cola.
Yes. Giving them a bottle of pop and a bunch of candy to chew on. You know, 1 sugar is good, 2 sugars are bad. So give them 1 sugar and 1 starch, 1 sugar and 1 protein. So what do you think about 5 packs of sugar emptied into a glass of orange juice? Not the way to go. It's not the way to go. Okay. What if they're unconscious? What do you give them? Glycogen. Or glucagon, actually. Glucagon, which gives you mobilizes the glycogen. Glucagon IM. A shot, an intramuscular injection of glucagon. What else can you give them? By another route. Dextrose per IV. But D5 is not going to do it. It's going to be D10, D50. Because D5, a whole liter at D5 only gives you 300 calories.
So D10?
Yeah, you need some D10, D50. You need some real powerful dextrose. Not just D5 won't do it. So, what will determine which one you give? The D50 IV or the glucagon IM? Because they're both appropriate. So what will determine that? The setting. The setting will. If you are talking to the mom and dad over the phone, and they're asking what they do with their unconscious hypoglycemic diabetic kid, what do you tell them to give? The IM glucagon that they should have in the refrigerator. They should all have one in there. What do you not tell them to do? Start an IV of D50. However, if they tell you it's in the emergency department and you got a severely unconscious hypoglycemic client with a glucose of 7, what do you give them? IV of dextrose. But good luck starting the IV. Because they look like a what? Drunk in shock. And what happens to peripheral vessels in shock? So good luck. You know. That's why I love saline locks and heparin locks. Intermittent venous access devices. Because if I need a lifeline in an emergency, it's going to be there. Because the hardest time to start an IV is a lifeline is in an emergency because they clamp down peripherally and you can't get a vessel. Can't get a cannulation because it's vasoconstricted. That's one where you just aim for where the veins are supposed to be, you know, because you can't see anything. Alrighty. Number 2. High blood glucose in a type 1. It's called DKA, diabetic ketoacidosis, or diabetic coma. Have you heard of DKA? Mm-hmm. I hope you have. Who gets it? Only type 1s. What should have told you it was only type 1s? How should you have known it was only a type 1? That only type 1s get diabetic ketoacidosis? Because another name for type 1 is what? Ketosis prone. And type 2 is non-ketotic. So how can a non-ketotic have diabetic ketoacidosis? They can't. So only a ketosis-prone type 1 can have DKA. Well, what would cause their glucose to go high? Well, too much food, not enough medication, not enough exercise will make the glucose go way high. However, none of those are the number one cause of DKA. The number one cause of DKA is below. The number one cause of DKA is acute viral upper respiratory infections within the last 2 weeks. So what causes DKA? Number one cause of DKA.
Viral
A type 1 gets what?
A viral?
The virus of the month club at school, right? And they get the upper respiratory viral pharyngitis that every kid in school has, right? And they recover from that within 3 to 5 days like everybody is. But after they recover initially, what starts happening? They start going downhill and getting more and more lethargic, because this is called diabetic ketoacidotic coma, DKA. So they start going downhill. So that when they come in the ER and you check their blood glucose and it's 850, and they have the signs of DKA, what do you ask mom and dad? That was when the last time they ate.
Have they had a viral infection in the last 2 weeks?
Yes. Have they had a viral infection, upper respiratory, in the last 2 weeks? What will they almost always say? Yes. And what caused the glucose to go high was the stress of that illness that was not shut off. And they started to burn fats for fuel, and they got into a negative situation. Well, what are the signs and symptoms of DKA? Turn the page. What are the signs and symptoms of DKA? I like it because they are DKA. You can get the signs and symptoms from the initials of the disease. So D stands for dehydration. They look dehydrated. You should have known that, because what did I tell you sick diabetics always get? And a high sugar. And these people have a high sugar and they are dehydrated. Classic. The K stands for 3 things that start with the letter K. They have ketones. Now, just for fun, DKA. Tell me if this is a true statement. DKA, they will have ketones in their blood. They will have ketones in their blood. True. Okay. DKA. Everybody with ketones in their urine has DKA. No. So you can have ketones in your urine and not have DKA. But if you have ketones in your blood, you have DKA. So it's the ketones in the blood that confirms the diagnosis. The ketones in the urine, that doesn't typically mean that you have DKA. Okay, the second K is Kussmaul. They Kussmaul. What's that mean? Deep and rapid. They hyperventilate. Deep and rapid Kussmaul. And the third K is K. They have a high K, which means what? Potassium. Potassium. The A stands for 3 things that start with an A. They are acidotic. What kind of acidosis? Metabolic, and that fits with Mac Kussmaul, doesn't it? A, they have acetone breath. Acetone breath, which means they have a fruit odor to the breath. And it's not always a nice mango essence either. It can be a rather funky, fruity smell. And A, they have anorexia due to nausea. Anorexia, what's that mean?
They don't want to eat.
They don't want to eat. Why? Because they're nauseated. So if you said to me, Mark, what are the signs and symptoms of DKA? I'd say, well, let me think here now. D, dehydration. So they're what? Dry, mucous membranes, weak, thready, pulse, dry, skin, poor elasticity, headache. What would the skin be if you're dehydrated?
Panting.
Poor elasticity. What else? Dry. What temperature? No. Water in your body performs the same function as water in your car. If you dehydrate your car, meaning spring a leak in your radiator, and you leak water out of your car and you dehydrate your car, what will happen to your engine? It'll overheat. So water is a coolant. So if you dehydrate, you overheat. Your skin will be what? Hot and flushed. Hot, flushed, dry. That's dehydration. See, I'm assuming you knew the dehydration signs. Maybe that was an assumption I shouldn't make. So DKA, first you check off all the dehydration signs, right? Then what do you check off? Ketones, Q small, and K. Then you check off acidosis, acetone breath, and anorexia due to nausea, DKA. 1D, 3 Ks, 3 As. And those are the signs and symptoms of DKA. Well, what do you do for it? Well, they're dehydrated and their sugar's high. So what do you do for the dehydration? IV fluids, low or fast rate? Fast rate. This one would be around 200 an hour. Some of the fastest rates you'll use are these ones. Burn is, of course, the fastest rates that you run in the first phase. But these ones are pretty high. And what do you put in the bag? The IV bag. To lower the sugar. Regular insulin, because you can run that. So you're going to get an IV with regular insulin run at about 200 an hour. That's pretty standard. And the main solution doesn't matter. It doesn't matter whether it's normal saline 0.45, D5 0.45, D5W. You're going, but their sugar's high. Why are they getting D5? What did I say about D5? 300 calories. So even if you run it at 200 an hour, they're only getting 60 calories an hour. That's nothing. You see what I'm saying? And anyhow, the D5 molecule is small, so it just goes right out. As soon as it gets in your bloodstream, it goes into the tissue. It doesn't even stay in your bloodstream to contribute to your glucose. If you guys have ever been taught to worry about the dextrose in the IV bag because of a diabetic, that's poor teaching, because that doesn't even stay in the veins. It goes into the tissue. The dextrose in the bag, if it's D5, will not create a hyperglycemia situation. Now D10 will, D50 will, but D5 will not. So don't worry about the dextrose in the bag. It's no big deal. We used to be all over that when I was in school. Oh, they're diabetic. Get the D5 out of there. It's not real good practice anymore. Okay, number 3, low blood glucose. I told you the type 1 is the same as type 2. Number 4, high blood glucose in a type 2 is called HHNK, HHNC, and some places call it HHS or HHNS. Which one do you guys use? HHNK? Did anybody use HHS? HHNS? HHNC? It's all the same thing. Who gets this? Which type? Why should you have known that a type 2 gets this? What in the name tells you it's a type 2? Non-ketotic. And whenever you see the prefix non, you know it's a type 2. Type 2s are the ones that have the nons. Type 1 never has anything that has non in it. Now, how many of you in here, if you got a bunch of questions on HHNK, hyperosmolar, hyperglycemic, non-ketotic coma, on your test, would kind of get a little nervous? Simply because of the length of the name. Well, this is actually one of the easiest questions you can get because it is very simple to understand. Letter B, this is dehydration. That's all it is. here's my point. How many of you in here, if I told you, you have a choice of taking 2 tests. One test is 20 questions over the causes, signs and symptoms, and treatment of HHNK. And the other test is over the causes, signs and symptoms, and treatment of dehydration. Would you have a preference? Which one would you rather take? No, but before I said anything, a half an hour ago, what would you have chosen? Dehydration, not HHNK. But what's the reality? It's the exact same test. So here's my point. Wherever you see the phrase hyperosmolar, hyperglycemic, non-ketotic coma, you can pull that out and plug in what word? Dehydration. Answer that question, you will get it right 100% of the time. So what would the skin look like in HHNK? Don't answer that. What would the skin look like in dehydration? Low water. Hot, flushed, dry. What would be the number one nursing diagnosis that you would see with HHNK? We'll refuse to answer that. What would be the number one nursing diagnosis you would see with dehydration? Fluid volume deficit would be your number one nursing diagnosis. What would be your number one nursing intervention or medical intervention for a client with HHNK? Well, I refuse to answer that. What would be the number one nursing or medical intervention in a patient who is dehydrated? Giving fluids. Do you see? What would be some outcomes you would want to see in a client with HHNK? Increased output. What's that? What? Coming what direction? Up. What's that? Moist mucous membranes. All the things that you would like to see if somebody were dehydrated. What would the outcome of your treatment want to be? You'd want to see them. So I guess what I'm saying is don't make HHNK hard. Make it easy. It's nothing more than dehydration. It's actually DKA without the K or the A. Because if you take DKA and you take the K out and the A out, what do you have left? Dehydration. That's HHNK. Why do HHNKers not get the Ks and the As and only the D? Because they don't burn fats, they don't make ketones. If you don't make ketones, you don't get ketones. If you don't get ketones, you don't get acid. If you don't get acid, you don't Kussmaul. If you don't get acid, you don't have the K shift that raises it. If you don't have the ketones, you don't have the acetone breath. And if you don't have that, your lining of your gut doesn't swell and make you nauseated. So what did I just rule off the DKA list? All of the what? Ks and all of the As, and the only thing I had left was the D. That's why HHNK is just the D, whereas DKA is the D, the K, the As. Does that make sense? I want you to look at this. Okay. Therefore, which one is the use of insulin most essential in treating? HHNK or DKA? Which one is insulin the most essential in treating? Well, if I said HHNK and DKA, you would immediately change HHNK to what? Dehydration. And if I said, in what situation do you need to use insulin? DKA or dehydration? What would you say? DKA. So the answer is DKA. You don't have to use insulin with HHNK. All you have to do is rehydrate them because they are dehydrated. By the way, which one is more life-threatening? Which one has a higher mortality rate, more people die of? HHNK or DKA?
DKA?
No, actually, more die from HHNK. Which one, if a DKAer comes into the ER and an HHNK comes into the ER, who is higher priority? The DKAer. Which doesn't seem to make any sense. Because I just said, who has a higher mortality rate? HHNK, but who's a higher priority? DKA. Well, can someone explain that to me?
The HHNK, they come in later when they're
They come in a lot later because they don't have the acidosis, the ketosis that makes people see symptoms. And so they get worse and worse and worse. So by the time they come, they're already bad. But a DKAer is acutely ill with all these symptoms that we can quickly treat with a simple rehydration with insulin. Do you see? Whereas the HHNKer will probably be treated with IVs, but probably is in such bad shape they're probably not going to make it anyhow. But you understand what I'm saying? Now, who would die first if we didn't treat them? HHNK or DKA? DKA. But we treat them so they actually have a lower mortality rate, even though it's more life-threatening. Does everybody get that? Okay. Long-term complications of diabetes are related to two problems. Oh, by the way, okay, B said this is dehydration. C says the signs and symptoms are like signs and symptoms of dehydration, and the treatment is rehydration. Did you get those blanks filled in? Good. Number 5, the long-term complications of diabetes are related to letter A, poor tissue perfusion, and B, peripheral neuropathy. Poor tissue perfusion and peripheral neuropathy. Now, what are some long-term complications? They are not DKA, HHNK, and hypoglycemia. Those are acute complications. I'm talking about renal failure, gangrene, stasis ulcers, blindness, impotence, heart disease, brain disease. So, if they ask you, diabetics have renal failure, what would this be due to? Well, it's one of two. Which two is it up? It's one of the two. Either what? Poor tissue perfusion or peripheral neuropathy. If it's renal failure, which one do you think it is? Poor tissue perfusion. If it's that they lost control of their bladder and they are now incontinent, what is that? Peripheral neuropathy. They can't feel it when they injure themselves. Peripheral neuropathy. They don't heal well once they injure themselves. Poor tissue perfusion. See, you're going to always blame it on either poor tissue perfusion or peripheral neuropathy, whichever one makes the most sense. It'll be pretty logical for you. Number 6, which lab test is the best indicator of long-term blood glucose control? The hemoglobin A1C. The HA1C. HA1C. The hemoglobin A1C. It's also called the glycosated hemoglobin. The glycosated hemoglobin. I've also heard it called the glycosylated hemoglobin. It's the same thing. Glycosylated hemoglobin, glycosated hemoglobin, hemoglobin A1C are all the same test. Now, what numbers do you want to see with the HA1C? You want it to be 6 and lower. 6 and lower.
6 what?
Just 6. On boards, they never test units. So all you need to know is numbers, which is great. What hemoglobin A1C means you're out of control. 8 and above is out of control. So in the 6s and lower means in control. 8 and higher means out of control. So where's the problem? With a 7. So the question is, when they come in with a hemoglobin A1C of 7, what's the conclusion? Yeah, they're on the border. So what do they need? Some workup. They need some evaluation. They need brought in the hospital, checking out what's going on. They might have some infection somewhere. So a hemoglobin A1C of 7 means we need to check on you. 6 means you're good to go. 8 means you're out of control. 7 means maybe. So just so you understand what the implications of those numbers. You'll see on TV, I just saw an advertisement the other day. It said that a certain thing lowered the A1C 0.9, which actually is really almost the whole point, which could take you from out of control almost to control. So it doesn't sound like much of a change, but for an A1C, a 0.9 change is huge. All right, let's get is stuff here?
It's here, it's out on the table.
Okay, let's get our blood sugars up. I feel bad because we're going to end up doing dumping syndrome right after lunch. That's not good. That's what happens.
When we did that one day when we we brought in our meals that day, we were doing anorexia that day.
Yeah, the anorexia.
All right, we'll start. Is anybody not here? You're all here? Okay, let's do drug toxicities on page 26. Bad news, you got to know your drug toxicities. Good news, you don't have to know them all. You just need to know what everybody else knows. And if anybody knows drug toxicities, they know these 5. Anything beyond these 5 is really nuts to know. It's not really need to know territory. You do need to know these 5 though. I would really suggest that this is a little bit of memory work, but it's good it's a good payoff for it. Because you understand this is a test for nurse safety, and one of the biggest ways you can be unsafe is to not know drug toxic effects. Do you see how that could result in real patient harm? So that's an area they like to test is toxic reactions to drugs, drug toxicities. So let's talk about these 5. Lithium. Lithium, of course, is the famous anti-mania drug. It's used for bipolar, but it's not used for the depression. It's used for the mania. Its therapeutic level in the middle column there, you should write 0.6 to 1.2. Now the toxic level is greater than or equal to 2. Now immediately you should see that there is a gray area there where you're higher than 1.2 but under 2.0. Do you see that gray area? That is a gray area where no books agree on exactly what's going on with lithium at those levels. From 0.6 to 1.2, everyone agrees that it is therapeutic. Everyone agrees that 2 and over is toxic. But in between, you just pick your book and they're going to say different things. One of the things that you guys don't know about me, well maybe you do know about me, that probably is good for you to know about me to help you understand why I say what I do and how I say what I do, is that for years I was a NCLEX RN item test writer. I wrote questions on the NCLEX. So the questions that were on there, I've written some of those questions. So I've been through the whole training protocol on how they want you to write questions for them. So when I tell you that questions are written this way, that's because I've been through the in-service education on it, and I've been trained as their item writer. In 2003, I think it was, maybe it was 2002, somewhere right around in there, the NCSBN made a rule that you cannot be an item writer and be a NCLEX reviewer at the same time, which makes sense. You can't write the questions and then go teach people how to pass the test. It's not ethically correct. So at that time, I had to pick between writing questions and reviewing, and I picked reviewing, and so I stopped writing questions. And so I haven't written a question since 2003, roughly. But if they only change 5% every year, there's still loads of questions on there that I've written. Now, I say that to tell you that when I give you ranges, the ranges I give you may not be the ones you learned, but they are the ones that you use when you write questions. Do you see what I'm saying? And most of the time, my ranges are wider than what most of the times than what you learned, because the instructions are to every item writer on the boards is when you write a test question that where you use a lab value or a range, a value in a range, a number, go to at least 5 different books published by 5 different publishers and see what they say the range is, then make your range wide enough to fit all of those. Do you see what I'm saying? So if book 1 says 1 to 2, book 2 says 1 to 2.3, book 3 says 0.8 to 1.9, well, you got to go from 0.8 to 2.3 as your range. That way it's a fair question no matter what book the students used. So you're going to see my ranges are different, but my ranges are made to fit the NCLEX. Do you understand that? And not necessarily a particular book. So you may use my ranges and my numbers, and you may go take the like the Saunders review book with questions, or the exam cram with questions, or the NCLEX Gold with questions, and using my ranges you may miss the question. Why? Because they went by their ranges. What ranges? The ranges in the MedSurg book that company publishes. Only one book, not 5. Now Kaplan does what I do. Anybody that's a national reviewer does what I do, which is a wider range than normal. Okay? So here's the deal. Boards would never give you a lithium of 1.3, 1.4, 1.5, 1.6, 1.7, 1.8, 1.9. Why? It's in that gray area where books don't agree, and item writers have to get it to where all the books agree. So I teach you 2 and greater because every book agrees that is toxic. Alrighty? So don't worry about that when you see these ranges. Okay, Lanoxin. Lanoxin, what's the other name for it? I told you yesterday you have to know this. DIG. This is used to treat basically 2 things. DIG is used to treat AFib and congestive heart failure. Atrial fib and congestive heart failure. How should you have already known that it treats atrial fib? DIG. In what context did we talk about DIG yesterday? Adena, beta, calcium, DIG. Oh, so DIG is the D of the ABCDs of atrial treatment. So atrial fib, yes. And then congestive heart failure is the other big one that it treats. Well, what is the therapeutic level of DIG? 1 to 2. And you notice I'm not giving you units, correct? Because what did I tell you about units? Don't worry about it. They're not going to ask you. They're going to say, how many milligrams per deciliter of? And you just say the number. Its toxic level is greater than or equal to 2. So what do you notice about 2?
Therapeutic range.
It could be therapeutic and it could be toxic. So what do you call it when they give you a value of 2? Toxic. Why? It's safer to call something toxic when it may not be than to say it's therapeutic when it might not be. So always err on that safe side. What do you notice about lithium and lanoxin's toxicities? They're the same at 2 and greater. Aminophylline. Aminophylline is a airway antispasmodic. It relieves spasms in your airway. It is technically not a bronchodilator. What do I mean by that? It is technically not a bronchodilator. What does it not do? It doesn't stimulate your beta-2 agonist cell to bronchodilate. It just relaxes a spasm. Now, when you're in a spasm, your airway is what? Narrow or wide? Narrow. And when I relax a spasm, what happens to the airway? It gets what? Wider. So it actually looks like it's a bronchodilator, but it's not really a bronchodilator. Epinephrine's a bronchodilator. Ipratropium is a bronchodilator. Alupen, albuterol are bronchodilators. Terbutaline is a bronchodilator. This is a muscle spasm relaxer. Has anybody ever, and I'm sort of just going off the side here on these things just to see if you can apply some stuff. Have you ever seen anybody come in or heard of anyone coming in an acute asthmatic attack and the bronchodilators aren't working? That happens on occasion. Probably what's happening. Why aren't the bronchodilators working? What's that? I really can't hear you unless you talk. Okay, the inflammation, but there's a bigger reason. They're in a spasm. They're in an acute lockdown spasm. And the bronchodilator isn't going to work because the spasm's in the way. So what do you have to give them first? Some aminophylline to do what to the spasm? Relieve the spasm. Then you can come in with a bronchodilator and it will work. So just remember, when a bronchodilator doesn't work in an acute airway problem, give them a theophylline, give them an aminophylline, and that'll melt the spasm, and then the bronchodilator will work. Yes?
Do they have protocols then where they give the antispasmodic first versus?
Yeah, a lot of times when little kids come in with acute reactive airway disease, they'll slap them on an aminophylline drip and then start giving them breathing treatments with betas. And they may have 20 of them. And the first 19 may not work until that aminophylline kicks in, then the 19th one works. You see? So I've seen little kids. What's the most breathing treatments you've seen airway? Anybody ever in work ER in children's stuff ever? Or what's the most? Nobody's? Okay, well then it's a dumb question. But I have seen up to 20 breathing treatments being given in a row to these little kids. It's really just phenomenal. Okay, that's not typical. That's the extreme. All right, what's the therapeutic level? 10 to 20. There again, don't worry about units. 10 to 20. Any aminophylline under 10 is what? If you get an aminophylline level of 8, what's that mean? So they need to take more. Or are they taking it? Okay. If it's 21, what's it mean? It's toxic. But anything in between 10 and 20 is therapeutic. What if it's 20? Because 20 toxicity is greater than or equal to 20 on this one. So 20 could be either way, so you call it toxic if you have to. So aminophylline toxic is greater than or equal to 20. Dilantin, what is this used for? Does anybody know what dilantin or phenytoin?
Seizure.
Seizure, yeah. Its therapeutic level is 10 to 20. And its toxicity is greater than or equal to 20. So what do you call 20? Although it may be therapeutic. Bilirubin. Bilirubin is not a drug. It's a waste product from the breakdown of red blood cells. When boards test bilirubin, they will only test it in newborns. They will never test it in adults. Does anybody know what the normal adult bilirubin is? It's like 1 to 2, 1.4 to 2.3, something like that. It's really low. But in newborns have high bilirubins all the time. Why? What are they doing? Breaking down which red blood cells? The moms. So babies will run bilirubins of 5, 6, 7, 8, 9, and that's fine. Now, if I had an 8 bilirubin right now, they'd have my rear end in a bed over there finding out what's wrong with me. But a newborn with an 8 is no big deal. So what I want you to do with this bilirubin is, do you see where it says therapeutic level, the middle column? In the box for bilirubin, I want you to write the word elevated level. Elevated level. So what is the elevated range for bilirubin in a newborn? 10 to 20. So what does it mean when a bilirubin in a newborn is 9.9 and less?
Normal.
It's normal, but it's high for an adult, but it's normal. So we don't even get concerned about newborn bilirubins until it hits what number? 10. Which is 5 to 10 times more than what an adult should have. So what is the bilirubin toxicity greater than or equal to 20. So when do you suppose a child with what bilirubin and above do you think needs to come into the hospital?
10 or above?
Certainly before, what about before 10?
No.
No. And even at 10, 11, and 12, what are they? Is it elevated? But you can manage it at home with sunlight, drinking a lot, flushing that bilirubin out. It's usually right about 14 to 15 that docs start thinking about hospitalizing these kids. About 14 or 15. Because once you hit 15, where are you in the scheme of things overall? You're halfway to what? You're halfway to toxic. And once you hit toxic, they can die. So you don't want it to be 18 or 17 or 19. That's way too close. You just don't like that. So, but most docs will not bring in a 12 or a 13. They'll usually wait till 14. Some docs wait till 15. I don't see any docs that wait till 16. I just typically not. Okay, so halfway through the elevated range, they start to hospitalize. Now, what do you notice about those toxic levels? What pattern do you see? 2s and 20s. 2s and 20s. Which ones are the 2s? Lithium and Lanox, and we start with what letter? So you pick the lower number with the ones with L. So lithium, Lanoxin go low. 2. Bilirubin, aminophylline, Dilantin go high, go 20. So you're usually picking between 2 and 20. And those are the major ones that they talk about. All right, what about kernicterus and opisthotonus? Do you see those words right there? You need to know these words, these vocabulary words. What does kernicterus mean? Does anyone know what kernicterus means? Bilirubin in the brain. When your bilirubin crosses your blood-brain barrier and it's in your cerebral spinal fluid, it's in your brain, it's in your meninges, you have kernicterus. So kernicterus, okay, what's jaundice? It's a yellow color due to
Too much bilirubin in the blood.
bilirubin in the skin. What's kernicterus? Bilirubin in the brain. Do you see what I'm saying? So jaundice is bilirubin in the skin. Kernicterus is bilirubin in the brain. Both are due to bilirubin. It's just where is it? Kernicterus usually occurs when you get up around 20. When your bilirubin gets around 20, you start going kernicteric. Do you see why it's so dangerous? Because bilirubin, when it gets into your brain, it causes what we call aseptic. What does that mean? Aseptic. A means what? Without. Sepsis means infection. So aseptic means no germs. It causes aseptic meningitis, aseptic encephalitis, which means a sterile encephalitis due to the irritation of the bilirubin. You don't have to know all that. Just know that when your bilirubin gets to be 20, you go kernicteric and you could die. The baby could. Now, opisthotonus, does anybody know what that is? I told you we'd learn a lot of vocabulary this week. What's opisthotonus? Okay, it's a position the baby assumes when they have bilirubin on the brain. It's a position. Kernicterus is a condition. Opisthotonus is a position. And what they do is they hyperextend. These babies hyperextend due to the irritation of the meninges with the bilirubin. So these babies hyperextend. Now, what do you know about the flexibility of a newborn? No flexibility or unbelievable flexibility. Unbelievable. So when they extend, literally their heels will come up and touch their ears. They will be like in a back walkover. They'll be completely, and they'll be very rigid in that. They'll hyperextend. They almost look like they're decerebrating, if you've ever heard of decerebration. They're real hyperextending. When you see that, when you see a little kid whose bilirubin is 15, Okay, kid came in, bilirubin 15, and he starts extending his neck. What do you think? Is that something that needs followed up right away, immediately, medical emergency? Yes, because he could be going into opisthotonos because he's kernicteric. And you want to catch it right away. Now, the question that often is asked on boards and other standardized tests is, in what position do you place an opisthatonic child? Now think about it. If they're hyperextending like this, what's a good position to put them in? On their side. You can't put them on their back. You can't put them on their abdomen. You have to put them on their side. Okay, that's it on drug toxicities. Just remember your 2s and your 20s. Yes?
Does bilirubin, they don't test based on how many hours you work every 1 day? On the boards?
Well, the only thing boards will do there is they'll talk about pathologic jaundice versus physiologic jaundice. And physiologic jaundice, the bilirubin is high and the kid is yellow at birth. With pathologic jaundice, no, reverse that. Pathologic, it's high at birth and the kid's yellow at birth. Physiologic jaundice, the kid's bilirubin is low at birth, normal at birth, and over the next 2 to 3 days goes high on bilirubin. So here's the deal. If they come out yellow, something's wrong. It's pathologic. If they come out yellow. If they turn yellow over the next few days, that's typical, expected. But they're just going to ask about whether it's present at birth or develops on day 2, day 3, and which one's pathologic, which one's physiologic. And they won't get any more specific than that. Which is in the blue book, so you got to remember that blue book too. Okay, dumping syndrome versus hiatal hernia. These are very commonly tested things on boards, particularly dumping syndrome. They really like to talk about dumping syndrome. It shows up a lot. Definitions. What is hiatal hernia? Well, I like to talk about these two together because they're both gastric emptying problems. And they're kind of opposites. And I like to remember opposites together. Why? Memorize one and you got the other. That's why diabetes insipidus and SIADH, I'm only going with one, figuring the other one out. Well, let's talk about what hiatal hernia is. Hiatal hernia is regurgitation of acid, meaning acid comes back up into your esophagus, where it's not supposed to be, because the upper part of your stomach herniates upward through the diaphragm. You're not supposed to have... your stomach is supposed to be 100% in your abdominal cavity, right? With hiatal hernia, you have a 2-chambered stomach. You're like a cow. You got 2 stomachs. Typically, this is your thorax here. Okay, and here's your diaphragm, separating your abdominal cavity below from your thoracic cavity above. Esophagus comes down like this, and then the stomach is there. It's supposed to be all below this diaphragm. In hiatal hernia, what happens is part of it goes up like this, and you've got a 2-chambered stomach with a band around the middle. And what happens when you eat, it sort of sits right here and then comes right back up. That's the problem with hiatal hernia. Now, below the line there, do you see where it says gastric contents move? Gastric contents move in the right or wrong direction? Wrong direction at the correct rate. In other words, does the stomach empty faster or slower or at a normal rate? Well, it empties at a normal rate. The rate's not the problem. With hiatal hernia, the rate is not the problem. It is the direction that is the problem. It's moving in the wrong direction at the correct rate. Now let's compare that with something called dumping syndrome. Dumping syndrome, again, is a gastric problem. It usually follows gastric surgery, in which the gastric contents dump too quickly into the duodenum. Now, are your gastric contents supposed to go into your duodenum? Yes. So what's the problem? It's too fast. So in this case, the gastric contents move in the right direction at the wrong rate. So you see where they're opposites? One is correct rate, wrong direction. The other is wrong rate, correct direction. They flip-flop. So if these were speeding tickets that if these were traffic violations you got, what would you be cited for in hiatal hernia? Going the wrong way on a one-way street, correct? What would you be cited for with dumping syndrome? Speeding. So one's a speed issue, one's a direction issue. All right, what are the signs and symptoms? Well, hiatal hernia is real easy. The signs and symptoms of hiatal hernia are just plain GERD. G-E-R-D. Gastroesophageal reflux disease. In other words, heartburn and indigestion, to state it simply. So when you see GERD, don't freak out. It's just heartburn and indigestion. No biggie. But let me tell you something. Hiatal hernia is a specific case here. You can have GERD for 100 different reasons, one of which is hiatal hernia. What makes GERD hiatal hernia is this. Hiatal hernia is GERD if you lie down after you eat. If you have indigestion and heartburn, it doesn't mean you have hiatal hernia. You could have it, but it doesn't mean you do have it. I'm going to give you 2 examples, and you tell me which one has GERD and which one has hiatal hernia. All right? A nurse gets up in the morning, skips breakfast, goes to work, passes a whole floor of meds, does a bunch of treatments, and at 11 o'clock gets epigastric burning pain, burping, indigestion, and it really, really hurts, and they gotta drink some milk or something, or this hurts. Do they have GERD? Yes. Do they have hiatal hernia? Why not? You aren't lying down and you didn't eat. Okay, but what about this patient? Nurse gets off at 7 p.m., goes home, eats dinner at 8 o'clock. Sits down, watches TV, half hour later eats a bowl of cereal. 20 minutes later eats a bag of chips. 20 minutes later eats, ice cream and chocolate syrup. Then they get tired, and 10 minutes later they go to bed. Half hour later they wake up with burning, epigastric pain, indigestion. They go, oh, it hurts. Same set of symptoms that the other nurse had. Could this person have hiatal hernia? Why? They laid down right after they ate. You cannot have hiatal hernia unless your symptoms occur when you're lying down after you eat. If you have GERD at a random times, you don't have hiatal hernia. Hiatal hernia is dependent upon position and meal time. That's hiatal hernia. It's just indigestion and heartburn when you lie down after you eat. Okay, dumping syndrome, and they like to test dumping syndrome, and it's a huge list of signs. The easiest way I know to remember all the things that happen in dumping syndrome is to take what I already know and combine it to equal dumping syndrome. So what do I want you to take? Well, first off, if you want to know what a person looks like with dumping syndrome, the first thing is talk about drunk. Okay, what's a drunk person look like? Staggering gait, slurred speech, impaired, judgment delayed, reaction time, emotional, what's the fancy word? Labile emotions. Well, all that can be dumping syndrome, because with dumping syndrome, you do have cerebral impairment because of decreased blood flow to the brain, because all the blood's going to the gut because it dumped into the duodenum. Then you also get shock. Signs of shock, which are what? Hypotension, tachycardia, tachypnea. What's the skin? Pale, cold, clammy. Cold because you don't have any blood there. It's vasoconstricting. So pale, cold, clammy. All right, so drunk plus shock. What does that equal? What did I teach you that drunk plus shock equals? Hypoglycemia. Well, to get dumping syndrome, you add to that acute abdominal distress. And what belongs on the list of acute abdominal distress signs and symptoms? When someone has acute abdominal distress, describe them for me. Cramping, pain, doubling over, guarding, protecting. What else? What would you hear with a stethoscope? Borborygmi, thank you. Yes, hyperactive bowel sounds, but they won't say that. They'll say borborygmi. What kind of bowel elimination pattern would you have? Diarrhea. So you get cramping, abdominal pain with diarrhea, borborygmi, guarding, bloating, distension, tenderness. That all goes with dumping syndrome. So if you get a dumping syndrome question and they ask you for signs and symptoms, how do you learn them? Drunk, shock, acute abdominal distress. So here's what hopefully you're, see, I want you guys to start filing things better, more efficiently. They do test alcohol intoxication, which is drunk, right? So drunk is drunk, right? You know that. Okay, shock, they'll test that too. Shock looks like shock. Do you understand this? Now, if you take drunk and shock and you put them together, what do you have the signs and symptoms of? Hypoglycemia, low blood sugar. If you throw in some acute abdominal distress with that, what do you get? Dumping syndrome. So I'm trying to link 4 of the major things they test. Shock, low blood sugar, dumping syndrome, alcohol intoxication. They all can be learned together. So what's the protocol? Drunk is drunk. Shock is shock. Drunk plus shock is hypoglycemia. That plus acute abdominal distress is dumping syndrome. And you're just, see what I'm trying to do is get you keeping adding rather than memorizing 4 separately. Okay, drunk is drunk, shock is shock, drunk plus shock is hypoglycemia, drunk plus shock plus acute abdominal distress is dumping syndrome. Okay, number 3, what's the treatment for hiatal hernia and dumping syndrome? They're going to be opposites. Because think about this. With hiatal hernia, you want the stomach to empty faster. Why do you want the stomach to empty faster with hiatal hernia? Because if it's empty, it won't what? Reflux. However, with dumping syndrome, we want the stomach to empty slower. Do you see it's the opposite? So if you just remember one, remember the other's the opposite. So what are you going to do to affect stomach emptying time? Well, there are 3 things you can do. To change the way the stomach empties, you can play around with the head of the bed, you can play around with the water content of the meal, and you can play around with the carbohydrate content of the meal. All right, so let's go through this. In hiatal hernia, what do we want to do with the head of the bed during and after meals? We want it in high position. Why high? That makes gravity empty it faster. Okay, go down the column. What do we want to do with the amount of fluids we give with the meal? Would a liquidy meal or a solid meal, which one will go through the stomach faster? Liquids. So we want the stomach to go through faster with this. So we want the amount of fluids to be high or low. So high fluid. And carbs go through you really fast. Carbs go through your stomach fast. So if you have a high carb, will it empty faster or slower? Fast. So here again, you want the carbohydrate content to be high or low? High. Now, the dumping syndrome is opposite of that. So how should a dumping syndrome eat their meals? In low position, head flat. In other words, how would they eat? How should they eat? Yes. Head of the bed is what? Flat. They're turning to their side and they're eating on the side with the head down. They don't eat on the back with the head down. That would be stupid, right? But on the side with the head down. So low head of bed. What about the fluids with the meals? High or low? Low. So when would they get their fluids? Not with the meals. They'd get it, what, an hour or two before meals or an hour or two after meals, but they would never get it with the meals. And what about carbohydrate content? Low, because we want the stomach to empty slow. When everything is low, the stomach goes slow. Do you hear that? When everything is low, the stomach empties slow. In high aidal hernia, you want everything to be what? High. In high aidal hernia, everything needs to be high. So when you see high aidal hernia, you should say everything needs to be high. What needs to be high? Head, fluids, carbs. And if you want the stomach to go slow, pick everything low. Head low, fluids low, carbs low. Now be careful. What if they throw you a curve and they talk about protein in the diet? For these two. What do you think? Yeah, low protein in high hernia, high protein in dumping syndrome. Because if you're low carb, you're going to be high protein. You understand that? So whatever carbs is, protein's the opposite. Any questions about dumping syndrome and hiatal hernia? They're pretty clear. This is a review, so sometimes people say, "Mark, I know most of what you're teaching me," and I say, "Good. This is called a review." So don't get upset when there's a lot of stuff you know. Get upset when it's all a newsflash. Electrolytes. How many of you in here can give me 15 signs and symptoms of hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, hypermagnesemia, hypomagnesemia, hypernatremia, and hyponatremia with 80% accuracy? How many could do that? When you raised your hand, everybody in class went, "Oh, I'm not there." No. Anyhow, how many could do it with 50% accuracy?
Can I use my book?
No. You probably wouldn't even be able to get 50 with your book. No, okay, what about 5% accuracy? Yeah, I got takers on that. Okay, I'm going to ask you that same question in 15 minutes, and I want to see what you say in 15 minutes, all right? So let's talk about electrolytes. To know your signs and symptoms of electrolyte disorders, you need to memorize 3 sentences. The first sentence you memorize is, kalemias, do you see where we're at? Number 1 here. Kalemias. What are we talking about? Kalemia. Potassium, yeah. Kalemias do the same as. Same as goes in the blank. Same as. Same as. The prefix, except for heart rate and urine output. Potassium imbalances do the same as the prefix, except for heart rate and urine output. You memorize that. Kalemias do the same as the prefix. So what I'm telling you is when you get a kalemia, just look at the prefix. There are only 2 options, hyper and hypo. Hyper means everything is what? High, and hypo means it's low. And your symptoms will go high with hyper and low with hypo. They'll go high with hyper and low with hypo, because it's doing the what? Same as the prefix. Except for the heart rate and the urine output, which will go what? Opposite of the prefix. So with hyper, urine output and heart rate go down, and with hypo, urine output and heart rate go. Yes. So, in your box there, give me some signs and symptoms of hyperkalemia. Hyper. Okay, start with the brain. Give me some hyper signs in the brain. Surely you can. You know what I'm talking about, right? You're not that. I know it's the post-lunch lull, but cerebrally, if it's hyperkalemia, kalemias do the what? Same as the prefix. The prefix is hyper, so everything in the brain is going to go up because it does the same in hyper. So if you talk about the brain, what symptoms are hyper signs in the brain? Give me some hyper signs in the brain. Agitation, restlessness, irritability, aggression, obnoxiousness, decreased inhibitions, loud, boisterous, right? Those all go with hyperkalemia. All right, well, let's talk about the lungs. What are you going to see there? Tachypnea. What are you going to see in the heart? Low heart rate, because there's the exception, but the T waves will be peak, tall. The STs will be elevated. See, the only thing that goes up is the heart rate. Everything else about the heart goes with the prefix. Okay, what will you see in the bowel? Diarrhea, borborygmi. What will you see in the muscle?
Increase.
Spasticity, increased tone. What will you see in the reflexes? +3, +4. And all those signs, what do they have in common? They're all up. Why are they all up? Because you have hyperkalemia. And in kalemias, they do the same as whatever the prefix says they are, except for the heart rate and the urine output, which goes opposite. So what would you list for hypokalemia? Lethargy. Tachycardia, because it can go opposite there. Tachycardia and polyuria. What? Bradypnea. Bowels are going to be what? Slow down. So what might you have? Ileus, constipation, all of that. What are you going to see in your muscles? Flaccidity. What are you going to see in reflexes? +1. Do I want you to memorize these lists that we're generating? No. Because you can get those lists from the saying that says what? Kalemias do the same as the prefix except for heart rate and urine output. Are you seeing where I'm going with this? Okay. Your patient has hyperkalemia. Select all that apply. Adynamic ileus. Obtunded. +1 reflex. Clonus, which is, okay? U wave. Depressed ST. Let's see what I want to do here. Polyuria. Bradycardia. Okay, I want you to look at it and then talk to your buddy, partner. See if you can select. But use the sentence. Kalemias do the same as the prefix except for heart rate and urine output. And draw your arrow. So you're going to have to draw an arrow. And you're also going to have to draw the exceptions, which is the heart rate and the urine output. Oh, that should say hyper. It says hype. Hyper. There's an R there. Sorry, guys. Hyper.
What about the U wave? It says just U.
A U wave. A U wave is a wave that goes like this.
Up and down.
It goes what? Down.
What was clonus?
What is that?
Polyuria is a hyper. Urine goes down.
Okay, so okay, high. So everything's going.
Make sure you get all your arrows right. So you need to draw a general arrow, an arrow for the heart rate, and an arrow for the urine output. Make sure you get them right.
Okay, hyper. So everything's going to go up except for heart rate and urine. So we need to go to urine, so which is going to make them go low. So it wouldn't be that. Hyper. So wait a minute. Except for everything's going to go. I know it would be bradycardia because it's going to be opposite.
Bradycardia is the
It wouldn't go high. It would do opposite. It would go low. Okay, so that.
Okay, how many did you select?
Hyper.
Okay, I selected 2. Let me see
I
if
got
I'm
2.
wrong. Okay? Because I'm going to write my arrows out first. I see hyper, and I know kalemias do the what? Same, so it's going to make everything go up, but heart rate's going to go down, and urine output's going to go down. Okay, A, dynamic, without movement. Ileus, that's down. That does not fit. Obtunded, that is down. That does not fit. +1 reflex, that is down. That does not fit. Clonus, that is irritability. There we go, that fits. U-wave, it goes down. That doesn't fit. Depressed ST, it's going down. That doesn't fit. Polyuria, oh no, it should be oliguria. That doesn't fit. Heart rate down. Bradycardia, yeah, that fits. Now, those of you that did 3, which one did you add that you shouldn't have added?
Polyuria.
You forgot to write the... See, if you forget to write your arrows, you're dead in the water. You got to write your arrows. Then go looking. Don't look first and then go back and write arrows. You know what I'm saying? Know what you're looking for first.
Know the meaning of the words, too.
Yeah, meaning of the words is helpful, yes. The U-wave, a U-wave is something that starts on the baseline and goes down from the baseline. So it's a sign of cardiac depression. And the idea, though, Leonid, is if you don't know what something is on a select all that apply, don't pick it. Because everybody tends to what? Over-select by 1. Isn't that what you guys did? You over-selected by 1. I mean, it's like predictable. Yes?
What does obtunded mean again?
Obtunded is just a little more comatose than lethargy. So you got lethargic, and then as you go even more deep into a coma, you get obtunded. A lethargic person, ask me a question, and I'll be lethargic. Just ask me a question.
Where do you live?
No, say that.
What's your name?
Mark.
Where do you live?
Okay. See what I'm saying? Or she'd say Mark what? Do you see what I'm saying? Okay. Now that's lethargic. Okay. This is obtunded. Okay.
What's your name?
You know, what would you do? What would you do? You're a nurse. Do what you would do.
What's your name?
You see what I'm saying? Now what's comatose? So obtunded, they pretty much you can rouse them and then they go off to la la land, and then you rouse them and they go. Lethargics will respond, but it's going to take a while to get it out. Obtundids will never respond, but they're rousable. Yes.
Stupor follow obtunded?
Stupor and obtunded are often considered to be the same idea. Stupor is more a generic word. Obtunded is more the medical term. Usually, go on. I won't go there. It doesn't need to happen. Okay, calciums. Calcemias do the opposite. Calcemias do the opposite of the prefix. Which means if your calcium goes high, everything goes low. And if your calcium goes low, everything goes high. So hypercalcemia, what would you have? Bradycardia, bradypnea, flaccid muscles, hypoactive reflexes, lethargy, constipation, right? Everything goes down when calcium goes up. However, when calcium goes down, hypocalcemia, everything goes up. So what do you get with hypocalcemia? Agitation, irritability, clonus, +4 reflexes, spasm, irritability, seizure, tachycardia, all that kind of stuff. And you get two other things, Chvostek's sign and Trousseau's sign, which Hesse loves. Trousseau's and Chvostek's. Chvostek's starts with what two letters? CH. And what do you do to elicit it? You tap the cheek. So just think Chvostek's cheek. Chvostek cheek. So when you touch their cheek with Chvostek's, they go into a spasm of the face. Their face spasms. Which shouldn't happen. If I touch you on the cheek, you should go. And you shouldn't go. That would be Chvostek's. What is it a sign of? It's a sign of neuromuscular irritability associated with a low calcium. It is a sign of neuromuscular irritability associated with a low calcium. Why does that sentence make sense? Irritability, low calcium. Why does that make sense? Because calciums do the opposite, so irritability would have to be low calcium. The other sign is Trousseau's. Trousseau's is when you put a blood pressure cuff on their arm, you pump it up and they go into a spasm of the hand. So it's a hand spasm when you put a blood pressure cuff on. So Chvostek's you do what? Cheek. Trousseau's you do blood pressure cuff and look for that. Stupid way I remember this. Really dumb, but it works for me. Trousseau sounds like a French name. So when I see Trousseau on a test, I think of an effeminate Frenchman. And he says, I'm Trousseau. So, so that Trousseau's. So I know it's weird, but, it may stick.
I was thinking Jacques Cousteau.
Jacques Cousteau. Okay. Boards live Hesse test. Those of you that are going to take Hesse, they will test Chvostek's and Trousseau's till the cows come home on that. They'll love it. All right. Hey, by the way, what if I change this to hypercalcemia? Would it change the answer? Yeah. Because now you're looking for what? Calciums do the opposite. This says hyper, so it's going to make everything go down. So you're going to see this and this and this and not that and that and that and that and not this. Oh, you will see that. Yeah, you will see. You will see that. Yes. I'm sorry. I got a little pen heavy there. You see? So it's really.
Polyuria.
Yeah, you won't see polyuria. It's really good when you guys are better than me at this. That's what we need to be, because I'm not taking the test. You are. Okay. But do you see what I'm saying? It really is more manageable. Now, if they ask you which sets of these, like for the hyperkalemia, if they ask you which one of those was most likely, you'd have narrowed it down to two. Which two? Clonus and bradycardia. But because it was potassium, you'd give the edge to the heart. If they're talking calcium, you'd have all these things, but you'd give the edge to the muscles and the nerves. Do you see what I'm saying? So there is that little, but make sure it's the right thing first before you do it. You know what I mean? But if you're between a couple of signs for potassium that are correct, and they're asking you to pick between them, for potassium, pick the heart sign, but make sure it's going the right way for the prefix, correct? And when you're talking about the calcium, pick the skeletal muscle and nerve, but make sure it's gone the correct way. All right, let's talk about magnesium. Number 3, magnesiemias do the opposite of the prefix. Now, some review books out there say that hypomagnesemia is not associated with hypertension. Because it does the what? Magnesiums do the? So a hypomag would result in high blood pressure. Some books say, no, that's not true. Check it out. Go investigate, and you'll find that low magnesium is associated with hypertension. Okay, so some of these books get a little sloppy in their answers. Who had that exam cram book yesterday?
Don't they say that magnesium often, like if it's high sodium, high magnesium? So then that's kind of...
Yeah, a lot of times they'll say that when you retain sodium, magnesium sometimes gets retained. So they say that high magnesium is associated with hypertension, but no, it's really a function of the high sodium, not the magnesium.
Yeah.
If you just talk about magnesium itself, the low magnesium has the high pressure.
But then it is kind of related.
But it is kind of related, but it is not a symptom of or a sign of. So what will boards do as far as blood pressure and magnesium go? They won't even go there, because that doesn't tell them anything significant about you. It just tells you on what side of the debate are you on, that kind of thing. Just a little thing about, people have asked me about using multiple choice books to study for boards, those multiple choice books. What have I told you about them already? 1 out of 5 answers is bogus in those books. 20% of the question in those books are wrong. They are wrong. And when you do them, you think they are all, what, 100% right. And you start to doubt yourself when you're the one that knows what's right and the book is wrong. So you have to be real careful. When you do those books, do I want you to do them? Yeah. But how do I want you to do them? If you answer an answer and you know it's right, you go to the rationale, they say you're wrong, what should you say? What do I want you to say? It's bogus. I am not having my confidence destroyed. I do know what I'm talking about. The book is wrong. I mean, there was a classic one on the examgram the other day that you showed me at SASC. Which patient needs a private room? And there was a patient with Cushing's syndrome in there. Well, Cushing's people are immunosuppressed. They should be in a private room. The other patient was hyperthyroid. And they said a hyperthyroid should be in the room because they don't sleep well because they're hyperthyroid. And if they had a roommate, they wouldn't be able to sleep real well. Well, my opinion is between somebody that isn't sleeping and somebody that's immunosuppressed, there's no... Any nurse you ask would say, do you see what I'm saying? So you got to watch those books. And then even in that book, which is the book I like the best, I think it has the best questions of any book. I have real problems with it. In one of the chapters it said that hypokalemia is not seen with Cushing's. Absolutely it is. With Cushing's you've got a lot of what? Aldosterone, which makes you retain sodium and water. Well, to retain sodium in the loop of Henle, what do you have to kick out? Potassium. So you do get hypokalemic. And then in chapter 8 or 9, they ask about it again, and they say that you do see hypokalemia with Cushing. So in chapter 3 they say you don't, and in chapter 8 they say you do. That's the state of the art of those books. Do you see what I'm saying? So when you go do these books and you know your stuff and you're ready to go, and it's telling you, no, you're wrong, you're wrong, you're wrong, you're probably what? You're right, you're right, you're right.
You need better proofreaders.
Well, they just, yeah, I mean, they're not, they're putting out a product to make money.
Right.
And the faster they can get it done, with the fewer people looking at it, the more money they make. Okay? We took, 3 faculty at Cedarville took the HESI test, and there's 160 questions. We disagreed with 30. And your faculty would too, if they took the test. They would disagree. And with ATI, they would disagree with even more. But they've never taken the test, so they don't even know what's on it. Do you see what I'm saying? They don't even know what's on it, and they're asking you to take it, and they're making decisions based on something they've never seen. And I'm telling you, they will. You tell them. He said, you take that test. You take that test, and you see if you disagree with, and they'll disagree with, I guarantee they'll disagree with at least 10 to 15%, if not 20 to 30%. They really, really will. But that's no excuse to get a 650 on the HESI. You understand what I'm saying? If you disagreed, if you missed all the questions that were bogus on HESI, you know what you'd end up with? If you missed all the ones that were bogus and you got like 80% to 90% of the ones that really were valid, do you know what score you'd end up with a HESI? An 1100 something. Do you see? So that's not going to flunk you on. You know what I'm saying? I'm telling you 2 things. I'm telling you they have a lot of bad questions on there, but those bad questions aren't going to be what? Don't say, oh, they're going to get. No. You have to not know some things too. All righty? Question?
Oh, I was just going to say, our school, they weight so much on the ATI that if you get below a level, you get 15 points off your whole points system, so that could totally...
I would just, when after you graduate, that's the best time to go back and just ask them and say, have you guys taken the ATI? No, have you taken it? No, honestly, have you taken it? Do you know what's on it? Have you seen those questions? Do you know what the question? Have you done a quality inspection of the product that you're putting? Do you know the product that you're putting so much weight on? See, I wrote my test. I wrote my final in my course, so I know. So when I say you fail it, I say you fail it because I wrote that test and I know that test. But a test I don't know, how do I know what it's like? These products are not that fantastic. The boards is fantastic. These products are not. You see what I'm saying? No, but then having said that, I'm saying that there's no reason not to get a reasonable score on these, even with those horrible questions. Okay? All right. But what I don't want you to do is this. I don't want you to learn a lot, know a lot, go take these questions and take 100 of them and have your confidence totally destroyed because they don't agree with what you said. Do you see what I'm saying? And you tend to only focus on the ones that you didn't agree with, not the 100 you did get right. You tend to focus on the 4 or 5 that you missed. Isn't that the way we are? Mm-hmm. So don't let those destroy. How many find that doing those batteries of questions are the fastest and quickest way to destroy your confidence? Yeah, and that's not what they should. That you shouldn't even be doing them if that's what it's doing. Do you understand what I'm saying? Okay. All right. So magnesiums do the what? Opposite. Now, can you have a tie? Could it be possible that a certain symptom could be caused by a magnesium imbalance or a calcium imbalance or a potassium imbalance? Could that happen? Yeah. Sure. So how do you break those ties? Well, here's the tiebreaker. In a tie, don't pick magnesium. Why? It's not a major player. So it's probably not the magnesium that's causing the problem. Number 2, if it is skeletal muscle or nerve, blame it on calcium. For everything else, blame it on potassium. So let me show you what I'm talking about here. I'm talking about this kind of question. Your patient has diarrhea. What caused it? Hyperkalemia, hypokalemia, hypocalcemia, hypomagnesemia. All right, now, you know it's an electrolyte question, right? So you know you're going to be playing games with arrows, correct? So, is this symptom up or down? So you got to find something that causes stuff to go up, the bowel to go up, right? Okay, potassiums do the what? Same. So hyper makes everything go. So could that cause that? So that's a possibility, is it not? Kalemias do the same. Hypo makes everything go down. Could that cause that? No, that's out. Calciums do the opposite. So hypo makes everything go up. So could that cause that? Yes. Remember, they're in the same direction that could cause it. Magnesiums do the opposite. So hypo makes everything go up. So could that cause that? Yes. So we have a what? Tie. So what don't we pick in a tie? So we rule out D. Is this skeletal muscle or nerve? No. So what do we rule out? Calcium. So we blame it on the high potassium. Are you seeing how that works? Let me show you another one. What if it said tetany? Is that up or down? Up. So let's do the same. Kalemias do the same. So hyper makes everything go up. So could that cause that? Yes. Same, down. No, that would be out. Calciums do the opposite. So low calcium makes everything go up. So could that cause that? Yes. Magnesium does the opposite. So low makes everything go high. So could that cause that? Yes. So we have the same three-way tie we had with diarrhea, correct? Now, what do we rule out first? The magnesium again. Is this skeletal muscle? Yes. This is skeletal muscle and nerve. So now we blame it on the what? The calcium, and we don't go any further. Now let me show you what mistake people make with electrolytes. Your patient has tetany. What caused it? A high potassium. B, a high calcium. C, a low magnesium. Do you know what? 90% of students taking this question without understanding what I just taught you would pick for this one? The high calcium. Because they've got burned in their brain calcium muscles, calcium muscles. If it's muscle, it's calcium, right? So they're going to pick high calcium, and they're going to be dead wrong. Why? It's going the wrong way. You've got to use your sentences first. Potassiums do the same, so this could cause that. Calciums do the opposite, so that's going to make everything go down. That would be ruled out. See how the answer that everybody would pick should be the first one ruled out, because they're not using what? Their sentences. And they just think muscle, calcium, potassium, heart. And they don't even look to see if it's going the correct direction. How many think you might have done that? If it's potassium, it's heart. If it's calcium, it's muscle. And then you don't even look at the prefix. Okay, so look at the prefix first, then use potassium, heart, calcium, muscle for tie breaking. Yes?
So if it was low calcium, low calcium, you pick that then over potassium.
This could cause that. This could cause that.
That's specific.
And this could cause that. Okay, now our tiebreaker is in a tie. Don't pick magnesium. If the symptom involves skeletal muscle, which it does, pick the calcium. And you don't have to go any further. But you got to go through for the first time to make sure that your prefix agrees with the symptom. You have to make sure that that imbalance would actually cause it. Then you go break your tie second. What most people do by mistake is they use the tiebreaker first. Do you see what I'm saying? They rule out magnesium. For skeletal muscle, they pick calciums, and for everything else, they pick potassium. And they don't even look to see if it's even feasible. That's the problem that people have. Question? Okay. All right, let's turn the page and talk about sodiums. Do you see the one with the E? I want you to write dehydration, using it like an acrostic, like a crossword puzzle. Put the D over top the E, and then write hydration down. The one with the E, hypernatremia, is associated with dehydration. You see over in the other column, the one with the O? Write the word overload down from that. Overload. Aren't dehydration and overload opposites? So when you get a hypernatremia, what should you see? The letter what? E, which tells you it is the same as dehydration. And when you see hyponatremia, you should see the O and say that's the same as fluid overload. So here's how you would use this. The one with the E is dehydration. The one with the O is overload. And you're using sodium here. So if they said this, a student nurse runs to you, the LPN, and says, oh my goodness, I just ran an IV, a whole liter of IV fluid into the patient in 10 minutes. I forgot to close the clamp. Okay? Ran a whole liter in 10 minutes. I forgot to close the clamp. What electrolyte imbalance would you expect to see? Why did you say hyponatremia? Because they would have had fluid overload, and you'd have been absolutely 100% correct. Which patient is put on a fluid restriction and Lasix? Hyponatremic. Which one is given lots of fluids? Hypernatremic, because that's dehydration. Who has hot, flushed, dry skin? That describes what? Hypernatremia, so that's the one with the E, so that's dehydration. So here's my point. If you had a 20-question test over dehydration and fluid overload versus a 20-question test on hypernatremia and hyponatremia, which one would you rather take? The dehydration overload. But what's the reality? It's the exact same test. Because anytime you see dehydration, you say what? Hypernatremia. Whenever you see overload, you say hyponatremia, and vice versa. So in addition to a high potassium, what other electrolyte imbalance is possible in DKA? In DKA, what other electrolyte imbalance is possible? Hypernatremia. Why? Because wherever you see the word dehydration, you can throw in the word hypernatremia. Anywhere you see hypernatremia, you throw in the word dehydration. So what nursing diagnosis would be major for hyponatremia? Hyponatremia, what major nursing diagnosis? Fluid volume excess. Exactly. Or SIADH would have hyponatremia. DI would have hypernatremia. And HHNK would have hyper, because HHNK is the same as dehydration, which is the same as hypernatremia. Is that sort of easier for you? Okay. So what do you have to know your electrolytes? Here's what you have to know. Kalemias do the same as the prefix except for heart rate and urine output. Calciums and magnesiums do the opposite. The one with the E is dehydration. The one with the O is overload. That's it. Now, if you use those, kaliemias do the same as the prefix, except for heart rate and urine output. Calcium, magnesium do opposite. The one with the E is dehydration, one with the O is O. Could you give me 15 signs and symptoms of hyperkalemia, hypokalemia, hypercalcemia, hypoglycemia, hypermagnesemia, hypomagnesemia, hypernatremia, and hyponatremia with 80% accuracy? Who could do it? And are you memorizing stuff? No, because those lists won't stay. Okay? So, but you need to memorize what? Kalemias do the same as the, except for calcium and magnesium do the one with the E is, the one with the O is. Okay, so learn that. Otherwise, learn your lists. Have at it. Be my guest. Okay, the earliest sign of any electrolyte disorder is numbness and tingling. The earliest sign. So if they said to you, what would be the first thing you would see? What would you say? Numbness and tingling. Now, vocabulary, this word means numbness and tingling. Paresthesia. So boards will say paresthesia instead of numbness and tingling. One thing they love to say is circumoral paresthesia. What's that mean? Numb and tingling lips. So that's a very, very early sign of these electrolyte disorders. The universal sign of electrolyte imbalance is muscle weakness. All electrolyte imbalances cause muscle weakness. They all do. Does anybody know the fancy word for muscle weakness? Paresis. You need to know those two words, paresthesia and paresis. Paresthesia is numbness and tingling. Paresis is muscle weakness. All right, that's it on signs and symptoms. Let's talk about treatment. And the only treatment they're really going to test is potassium. All righty? First rule, never push potassium IV. Everybody knows that? Yeah. Good. Never push potassium IV. Number 2, not more than 40 of K per liter of IV fluid. Now LPNs, you probably don't have to worry about this, but RNs, on your test, if the doctor writes an order for 60 of K in the liter, you're supposed to call and clarify. 40 a K, you don't call, you don't clarify, you just follow the order. But if it's over 40, you question and clarify. That's pretty standard. Okay, 3 and 4. Numbers 3 and 4. These are ways to lower a potassium. Why is a high potassium such a bad thing? It stops your heart. Cardiac arrest. So what is the most dangerous electrolyte imbalance of them all? High potassium. Of all the electrolyte disorders, the worst one is a high potassium. It beats all of them because it can stop a heart. So we need to know how to lower that potassium. So number 3 is the fastest way to lower the potassium, and that is give D5W with regular insulin. Give D5W with regular insulin. What's that going to do? It's going to drive the potassium into the cell, out of the blood. And it's the potassium in the blood that will kill you, not the potassium in the cells. So does D5W and regular insulin get rid of the excess potassium? Yes or no? No. What does it do with it? It hides it. Hides it where? In the cell. Does it really solve the problem? No. Then why do we do it? To save their life. Sometimes it's so high and that heart is being so negatively affected that we got to get that potassium down fast. We don't have time to solve the underlying problem. We don't have time to get the kidney kicking it out. We just have to get it out of the blood as fast as we can do it. It's sort of like your floor is dirty as all get out. Company's coming in the driveway. So what do you do to the dirt? Sweep it under the rug and throw the rug back down, because you don't have time to what? Really clean the floor. That's the way this is. With this, we're just sort of sweeping the potassium under the rug. Now, what's going to happen over the next few hours after this works? It lowers the K. Fantastic. Now, what's going to happen over the next 8 hours? The potassium is going to leak right back into where? The blood, where it could kill you again. So this is, what's the upside of this one? Fast and quick. What's the downside? Temporary. Which is why we use the other one, K-exalate. Now, K-exalate goes into your gut. It either is put through your mouth or through your rectum, in enema or a ingestion. And it's full of sodium. It's chock full of sodium. Now, as it sits in your gut, what do you think it liberates into the blood? Sodium. But to maintain electronegative equilibrium, what has to be kicked out of the blood into the gut? Potassium. And where does it? It's picked up by the K-exalate. So the K-exalate goes in full of sodium, but it trades sodiums for potassium. So when you defecate the K-exalate out, what's it full of? Potassium. Now, how did your blood start out? High in what? Potassium. It ends up high in sodium. So you have what imbalance? Hypernatremia. That's the one with the E. So that is just simply dehydration. So we give them fluids and we correct that problem. So what we're doing is we're training a non-life-threatening electrolyte imbalance for a life-threatening one. You know what I mean? We're getting rid of a life-threatening imbalance and giving them a non-life-threatening imbalance. But they still have an imbalance when we're done. Now, what's the good side about K-exalate? What's the good side? What's that?
Does it last longer?
It lasts longer, yes, but there's a reason why. It lasts longer. Why? It gets rid of the excess potassium out of your body, never to reoccur. Okay, well, what's the downside of K-exalate? Well, yeah, you get hypernatremic, but that's not the worst downside. It takes a long time. It takes hours, and you may not live that long. So what's the advantage of D5W regular insulin? What's the downside? Temporary. What's the upside for K-exalate? Permanent. What's the downside? Takes a while. So what do you think we do simultaneously? We give them both. What lowers the potassium right away? D5 regular insulin. As it starts to come back out of the cell, who picks it up? K-exalate, and out it goes. So, let me ask you this. What electrolyte does K-exalate work with? For calcium, magnesium, or potassium? Potassium. What's the symbol for potassium? Now, does K-exalate make potassium enter the cell or exit the body? Does it do it fast or slow? Early or late? Say that real fast. Okay, so the minute you see K-exalate, what should you think? K exits late. Potassium leaves the body, but it's going to take a while. Well then, so if K exits late in K-exalate, then what happens with D5W and regular insulin? K what? Enters early. you see what I'm saying? So if you know that K exits late in KX then you know what D5W in regular insulin does, which is the opposite of that. It doesn't exit, it enters, and it doesn't do it late, it does it early or fast, okay? Do the practice question at the bottom of the page using the rules that I taught you. Do not use your normal thinking. Use the rules that I taught you. I want you to think through it. Remember, if a answer is part wrong, it's all wrong. And when you get an electrolyte question, what is it all about? Drawing what? Arrows. Yeah.
I don't know what it is, but it's such a cute default. But you know that there's something too you can also give. It's only temporary though. It protects the heart. I feel like it's calcium.
Yeah, you can give, calcium gluconate. Yeah. No, that's more of an emergency situation. They're going to ask about treatment that you're going to do on a unit in a non-code, non-emergency, Okay, what answer did you guys come up with? D. How many said A? B, C, D. Okay, how hard was this question? Scale of 0 to 10. 0 being easy, 10 being unbelievably difficult. What would you give it?
1.
1, 2, 3. An hour ago, what would you have given it? So what did you see? What did you notice? What word did you notice? Hypercalcemia. Calciums do the? So it's going to make everything go. A negative inno, negative chrono, negative dromotropic effect right on the heart and everything else. Okay, so what's wrong with A? Why did A not get your answer? Tacky, killed it. Why did B not get your answer? Elevated. Why did C not get your answer? Tall. So what was good about D? Decreased, inverted, blocked. Right? Okay, good job. And you don't have to, see, the nice thing about it is you don't have to, it's actually testing your knowledge of the principles of what it does, but you don't have to memorize all fancy stuff, okay? All right, take a break, come back at 20, at half past. 60 mil per drop. No, 60 drops per mil. And micro is the same. Okay, mini and micro. They're synonymous. No. Which leg of yours is big one? You hold it on the side. And advance it with the wheel. Yes, the one that goes by itself. This is the weak one. That goes together. And then I go like this, and now I'm on my bad one by itself, which is cool. And the weak one gets back. And see how wide the base of support is? Yeah. That's better than having it over here when you have narrow. Okay. Let me ask you. Your client had a right CBA. In which angle is it? Really? Y'all have to pay attention next week.
You are really quick in term pay. Always around time.
Okay, let's start. Endocrine overview. Endocrine glands. This lecture is going to be real helpful for HESI stuff because they love to test adrenals and thyroids. The endocrine overview is only going to be about thyroids and adrenals. You do not have to know the thymus, the pineal, the parathyroids. You don't have to know all those. Just know your thyroid gland, know your adrenal gland, and you're good to go. Now, if you don't know your thyroid, you're in trouble. If you don't know your adrenal, you're in trouble. So focus on what you need to know. So let's focus on those two glands. The first one is hyperthyroidism that I will talk about. Whenever Mark Klimek sees the word thyroidism, he turns it into metabolism because that's what the thyroid does. The thyroid regulates metabolism. So when you see hyperthyroidism, what do I want you to turn it into? Hypermetabolism. If that is true, do you see that now you do not have to memorize the signs and symptoms? They're just logical. What would be the logical set of signs and symptoms you would see if you had a high metabolic rate? Weight loss. So they're skinny and weight loss. What else? What would their pulse rate be? Blood pressure. Their personality. Irritable, hyper, obnoxious, excitable. Life of the party for about 5 minutes till everybody gets sick of them. Heat. What? Intolerance and cold tolerance. So they can tolerate the cold because they're like a little furnace. They cannot tolerate the heat because they're already burning up. Exophthalmos. What's exophthalmos? Bulging eyes.
What was the word for that?
X-E-X. E-X-O-H-P, O-P-H-T-H-A-L-M-O-S.
Oh, okay, I got it now.
Exophthalmos. So they're skinny, they're hyper, they're tacky, they're hypermetabolic. The person I remember, this dates me too, you guys probably do not know him, was a guy named Don Knotts that was, what was he? He was Barney Fife on Mayberry. You know, the skinny little guy, Sheriff Andy. He's always hyper, bug eyes, skinny, classic hyperthyroid guy. The name of this disease is Graves, G-R-A-V-E-S, Graves disease. Now, they will not tell you, they will not say Graves disease, hyperthyroid. They'll give you one name. And you're supposed to know Graves is hyperthyroid. The way I remember that is a saying my grandma used to say, which is, you're going to run yourself into the grave. What two words does that link? Run with grave. Well, if you're run all the time, what are you? Hyperthyroid. So running yourself into the grave helps me remember it's hyperthyroid. Number 3, the problem here is hyperthyroidism. So you have 3 treatment options. You have 3 ways to treat hyperthyroidism. Number 1, radioactive iodine. Radioactive iodine. Now there's 2 things you need to know about radioactive iodine. Number 1, the patient should be by themselves for 24 hours. They should be in a room by themselves for 24 hours. And after that, they have to be real careful with their urine. They should flush 3 times. If they spill their urine on the ground, they need to call the hazmat team. Because somebody has to come with a Geiger counter to make sure it's all cleaned up. So if you have a patient on radioactive iodine for hyperthyroidism and they spill urine on the floor in the hospital, you can't call housekeeping. you got to call your hospital hazmat team, and they come with all their paraphernalia. It looks really, really silly for them to go worrying about the urine. But that's where the radioactivity is excreted, is through the urine. So this is the one place where they have glow-in-the-dark urine. Not really, but you have to treat it like it's bad. So the only risk to you, the nurse, for a patient who's had radioactive iodine is what? Their urine. And give them a private room in the first 24 hours. Okay, the next treatment we have is PTU. PTU. A drug. Yes?
Would you get family visitation on that? Is that an issue? I've seen several ATI questions.
With radioactive iodine, no family visitation in the first 24 hours. And if they go home, they are supposed to stay in the family room and nobody else, or they stay in their bedroom, nobody else goes in for 24 hours. So there's a restriction of visitors, home restriction for 24. After 24, they can have all the visitors in the world as long as they don't pee on them. Okay, the second problem is PTU, propylthiouracil. Propylthiouracil. Now, I don't want you to memorize that PTU is propylthiouracil. What's it used for? Hyperthyroid. So what must it do to your thyroid? If it treats hyper, what must it do? Bring it down. So I want you to remember that PTU stands for puts thyroid under. Whenever you see PTU, what should pop in your head? Puts thyroid under, which tells you it treats hyperthyroid. Its primary use is for cancer. It's a cancer drug. But one of its special uses is for hyperthyroids because it will also put the thyroid under. So what do you think the number one nursing thing is with this drug, if it's a cancer drug? Immunosuppression. So what blood values do you have to watch when they're on PTU? Their white blood cell counts. So it puts the thyroid under, and it also knocks down your white count. The most common way, however, that we treat hyperthyroid is surgical removal. We do a thyroidectomy. Thyroidectomy. We remove part of the thyroid or all of the thyroid. Now, if you want to get your thyroidectomy questions correct, you must pay attention to whether they're talking about a total thyroidectomy or a subtotal thyroidectomy. Because that's going to make a huge difference in your answer. If you just treat all thyroidectomies the same, you will miss loads of questions. So what's the most important thing in a thyroidectomy question? Total or sub. Now, I taught this one time, and a student called me the day after and said, what you taught didn't help on thyroidectomies. And I thought, okay. And I said, well, what didn't help? And she said, well, there was a different kind of thyroid surgery on there that you didn't cover. I thought, boy, that's interesting. Total, subtotal. That pretty much covers it for me. I can't think of, it's either total or it's subtotal. I mean, what third possibility could there be? And I said, well, what was it? And she said, it was a partial thyroidectomy. Subtotal is a partial, total is a complete. So a complete thyroidectomy is a total, a partial is a subtotal. Now, she passed. So you don't have to be, a real shining light. You just have to do some shining. She certainly was not a shining light. Why did she make such a dumb mistake? She wasn't managing her anxiety. And she was looking for total and subtotal, and it wasn't there. She panicked. And she didn't say, now wait a minute, which of these is closest to what I do know, right? Because it may not say it exactly the way you want it. Remember the guy with the cracker and the dry carbohydrate? You know, they'll say things differently than you learned them, but it means the same thing. If you see something on the test that means the same as something you learned, but it's saying it differently, guess what? It is what you learned. Don't say, well, that sounds like the same thing, but I didn't learn it that way, so it's probably not that. Oh, that is the worst thing to do. You should do the opposite. You should say, that sounds an awful lot like what I learned, which was this. It's not the same phrasing, but it sounds like that, so it must be that. Do you see the difference? Always assume that if they tell you something synonymous, that it means the same as what you know. Don't assume it's something different. Always assume it's what you know. Okay, so for totals need lifelong hormone replacement. Why? Because if I take your whole thyroid out, you don't have any. So you got to have lifelong hormone replacement. Also, letter B, you are at risk for hypocalcemia. Why low calcium? Why, after a total thyroidectomy, do you have a low calcium? Because it's almost impossible to spare the parathyroids when you take the whole thyroid out. So you end up with low parathormone, low calcium. So they're at risk for low calcium. What are the signs and symptoms of hypocalcemia? We talked about that last hour. Calciums do the opposite. So hypocalcemia is going to make everything go up. So you're going to have tetany, spasm, irritability, clonus, seizure, tachycardia, hypertension, irritability, jitteriness, tremor. Right? What's the first sign that's going to happen? Paresthesia. Excellent. See, once you start learning enough, things start cycling around and it's all no news, right? It's old news. What two signs will you have? Chavostex and Trousseau's. Because your calcium is low. Okay, subtotal thyroidectomies, on the other hand, do not need lifelong replacement. Why? Because you got some left and it's supposed to kick in. Might you be on hormone replacement for a little while? Till that other one kicks in, then it's supposed to be off. Do you think you get the hypocalcemia much with this? No, because if you only take out part of it, you can spare your parathyroids and your calcium's fine. However, what these people are at risk for is something that totals never get, and that is thyroid storm or thyroid crisis. Same thing. It also has another name, thyrotoxicosis, which sounds like a toxic thyroid, so that sounds like hyperthyroidism to me. Thyroid storm. Now, what are the symptoms of thyroid storm? 4 really bad things. Number 1, super high temperatures of 105 and above. Number 2, extremely high blood pressures. Stroke category. So you're probably talking 210 over 180. Now, I'm just giving you that as a ballpark. That's no set in stone number. Severe tachycardia, probably in the 180s. Could be as high as 200. And there again, that's just a ballpark. There's nothing magical about that number. And lastly, they are psychotically delirious. They have psychotic delirium, which we talked about before. These people are in a medical emergency. This thyroid storm is a very, very bad thing because it can cause brain damage, and brain damage is permanent. You literally fry your brain to death with hypoxia and or hypoxia. So you must treat this immediately, and what you treat it with is get the temperature down and get the oxygen up. Get the temperature down, get the oxygen up. Well, how do you get the temperature down? What's the first way you would do it? Ice packs. What's the best way? Cooling blanket. Because if you would pack him in ice without the cooling blanket, use the cooling blanket without the ice, which way would be better? Ice without the cooling blanket without the ice. What's better? Cooling blanket without the ice. So the best is the cooling blanket. But what would you do first? First I'd put him in ice, then I'd order the cooling blanket and have it there. So you see there's another first best difference. And what would you give that? How do you get the oxygen up? Oxygen per mask at 10 liters. Just as an interest note, what's the problem with that order? What do you think you experience when you try to implement that order? What's that? And these people are what? Psychotically delirious. So how likely is it you're going to keep an oxygen mask on this patient? Yeah, good luck. Good luck. So this is a medical emergency. You pack him in ice, order the blanket, throw a mask on him with high O2. And they will come out of it themselves without treatment, or they will die. And there's nothing you can do to make it go either way. It's just when that T3, T4 gets out of their system, they'll be okay. We don't want to medicate them, because if we medicate them, it could go the other way. So this is a self-limiting condition. All we're doing is sparing their brain until they come out of it. Now, I've seen this about 5 times in my career. The longest lasted 12 hours. The shortest lasted about less than 2 hours. But when you're treating these people, it's 2-on-1, meaning 2 staff for 1 patient. You need an aide and yourself, because you can't do it with just yourself. Yes?
What is Tylenol going to do?
Tylenol works in the hypothalamus, and at this point the hypothalamus is being severely threatened, because it's right near the pituitary, and the problem with the thyroid storm that caused it was the TSH from the pituitary. So that pituitary hypothalamic axis is part of the problem that's causing this situation. And Tylenol works in that hypothalamus, and it's not going to work. Tylenol just isn't going to do it. So you really have to, pack them in ice. So you really don't treat a lot of it. It's kind of scary, because you're just sitting there, doing what you can. All right. But I would say that good nursing care is going to save their life. Why? Because medicine isn't. Yes, question?
So you said, to clarify, first ice packs and then oxygen later.
Well, I mean, if you had to pick between the ice packs and the oxygen, I would do the oxygen first, the ice pack second, the cooling blanket third. But if I was between the ice packs and the cooling blanket, the ice packs go first. But I would always pick stay with my patient, because you don't leave your patient to go get the oxygen. You see what I'm saying? But it's a perfect world, so it's sitting right there. All right. Post-op risks. They love to ask you about thyroidectomies and post-op risks, because it depends on the type of surgery and it depends upon the time frame. So let's talk about this. You've got to know this. You have to know this. In the first 12 hours, it doesn't matter whether it's a total or a subtotal. It does not matter. The top priority is airway. Because where's your thyroid? So if you have edema in the area, what's it going to press on? The airway, the larynx, so trachea. So you've got to watch out. Second big problem is hemorrhage, because it's an endocrine gland which has a lot of blood vessels. So the top two in the first 12 hours for both types of thyroid surgery are airway and hemorrhage, which is pretty much standard, isn't it? Okay, now where the difference comes in is in the 12 to 48 hour window. If they give you a patient who's longer than 12 hours, but less than 48, now you have to pay attention to what type of thyroidectomy was done. Letter A, the post-op risks 12 to 48 hours after a total. The big danger is tetany due to the low calcium. For a total, they get the tetany because of the low calcium. However, letter B, the post-op risks 12 to 48 hours for a subtotal is storm. What storm? Thyroid storm. So you see where they're different? But they're the same in the first 12 hours, but different in the next 36. So, 12 to 48 hours after surgeries, what do totals get? What do subs get? Totals get tetany, subs get storm. Totals get tetany, and subs get storm. So TTSS, total tetany sub storm. Total tetany sub storm. TTSS. When? 12 to 48 hours after surgery. In the first 12, what is it? Airway and hemorrhage, airway and bleeding for everybody. All right. What's the big risk after 48 hours, by the way? Infection. Right? How long does it have to be before you're allowed to pick infection as a high priority? At least 42 hours. We'd prefer 72. Here's the deal. Never pick infection in the first 72 hours after anything. So if they had a trauma and it's been 36 hours, would you pick infection? No. They gave birth to a baby 8 hours ago. Would you pick infection? No. Never pick infection in the first 72 hours. You only pick infection after 72 hours, not in the first 72. Question?
Is tetany serious?
Tetany is dangerous because your larynx can go into a tetanic laryngeal spasm, which would close the vocal cords in an irreversible spasm, which essentially cuts off your airway, and you die. Okay, hypothyroid. Hypothyroid is hypometabolism. So if hypothyroid's hypometabolism, what are the signs and symptoms of a low metabolic rate? If your metabolic rate is really low, what would you look like? Obese. What would your personality be? What's that? What? Flat, boring, dull. Cold intolerance, heat tolerance. See, you cannot tolerate what you are. So if you're cold, you can't tolerate. You have cold intolerance. If you're hot, you have heat intolerance. Do you see what I'm saying? So hypos are always what? Cold. So they have cold intolerance. Hyperthyroids are always hot. So they have heat intolerance. So you cannot tolerate what you are. What would the pulse be and the blood pressure be? Low. If they were a test taker, what kind of test taker would they be? Slow, extremely slow test takers. They tend to get lower grades in school. Not because they're not smart, but because they can't process fast enough. It could even affect nursing practice in the sense that you don't think fast enough. Okay, the name of the disease is mixed edema. M-Y-X, and then the word edema. That's the name of it. Okay, the treatment. Do you have too much hormone or not enough hormone? Not enough, so what's the logical treatment? Give them thyroid hormones. Synthroid, levothyroxine. Number 4, caution, do not sedate these people. Why do you not sedate them? Because they're already super slow. You sedate them, you'll actually put them in a coma. It's called a myxedemic coma. So what pre-op order would you question with this hypothyroid patient? Ambien at HS, the sleeping pill before surgery, the night before surgery, because they don't need that. Now, let me ask you this. You got a hypothyroid client. He's on thyroid pills every day. He's going to have a open heart surgery. He's scheduled for it in the morning. Doctor orders NPO past midnight. You got a problem with that? What's your problem? Call and question what?
That they're holding the med, the thyroid hormone.
Okay, because NPO means nothing, and nothing means nothing, including anything, which would be a pill. So nothing by mouth means they're not allowed to have any of their oral pills, which means you would not give the person their morning thyroid, which means they would be hypothyroid and very susceptible to any drug that would sedate them. Do you get any drugs during surgery that sedate you? It's called an anesthetic agent. Do you see what I'm saying? So if you would follow that order and not give the thyroid pill the morning of surgery, what could likely happen to your patient? Never make it off the table. They would die from the depressant effects of the anesthesia. So you as a nurse would never hold what pill before surgery without express orders to do so. Thyroid pills. Never hold your thyroid pills unless they tell you to do it. And even if they told me to do it, if I called the surgeon and he told me to hold the thyroid, what would I do? I'd call the anesthesiologist. And if he said hold it, what would I do? I'd call the head of the anesthesiologist, my supervisor, and say, hey, look, this is not cool. Now, my supervisor should what? Contact the supervisor of the anesthesiology and say, hey, look, what's going on here? You see, you aren't supposed to go up the ladder outside your department. You go up your department and they go across. Do you see what I'm saying? If I really felt it was unsafe, I would refuse to follow. I would just refuse to. I don't know. You understand? If I thought it meant a patient dying, how far would you go? You know what I'm saying? If it was your dad, what would you do to keep him from going to surgery? You'd lay down on the floor and not let him get the cart over your body. Do you know what I mean? So I'm just saying, would you do the same for your patient? Okay, enough said on that. Adrenal cortex. The second gland we're going to talk about, the adrenal cortex. Interestingly, adrenal cortex diseases start with either the letter A or the letter C, which are the initials of adrenal cortex. So could Graves be the adrenal cortex?
No.
Could myxedema be the adrenal cortex?
No.
Could pheochromocytoma be the adrenal cortex?
No.
Could Cushing's?
Yes.
Conn's? Addison's?
Yes.
Corticoinsufficiency?
Yes.
Adrenal insufficiency?
Yes.
Yes. So all of those diseases start with an A or a C. Now I didn't say that all diseases start with an A or a C, or adrenal cortex, because asthma, obviously no. All right. Addison's disease. Let's start with Addison's. It starts with an A. It's under secretion of the adrenal cortex. Under secretion. What are the signs and symptoms? Just two things you need to know. They are hyperpigmented. What does hyperpigmented mean? Very tanned. Very tanned. So they look what many people call healthy, but they are the farthest thing from it. Because the second thing you need to know about it is these people do not adapt to stress. They do not adapt to stress. Because their adrenal gland is under secreting. So if they undergo any stress at all, what could happen? What's the purpose of the stress response, I might ask? What's the purpose of the stress response? Not to increase the metabolism necessarily, although it will. That's what mediates it, but that's not the purpose of it.
Heart rate.
That's what it does, but that's not what the purpose. What? Okay, but what's the big when you are under stress, there's a threat to your brain. And the purpose of the stress response is to perfuse the brain with blood, in other words, support the blood pressure, and give the brain glucose, which means raise the blood glucose. So the purpose of the stress response is to raise the glucose, raise the blood pressure. Does everybody understand that? Your stress response is supposed to raise your glucose and raise your blood pressure. That's what its purpose is. If these people do not have the adrenal cortex to carry out the stress response, when they undergo stress, what will happen? Okay, what's the purpose of the stress response? Raise the and if you've got a disease in that organ and cannot do that, what will happen when you undergo stress? Your glucose will go down and your blood pressure will go down and you'll go into shock like that. And it doesn't take much to put them into shock. In fact, these people have been known to go to the dentist, have a tooth filled, and they go into full-blown shock because of that stress, which wouldn't bother most of us. If you ever work squad, these are the people that you happen on the scene of a little fender bender, and somebody's gone. No blood pressure, nothing. They're gone. And you think, well, they couldn't possibly have been hurt that bad. Well, you'll search them, and what will you find? A really tan guy wearing a bracelet. And what does the bracelet say? I have Addison's disease. These people, you look at them wrong and they go into shock. No, not really, but I mean, they are your time bombs waiting to go. This is a very scary disease. You're okay until something happens, and then wham, they decompensate like that. Yes?
I thought it was rare. Do you see it?
It's very rare. As far as endocrine disorders, it's one of the rarest. It's one of the rarest. It's like for every 600 Cushing's patients I would see, I see one Addison's. And that's probably being generous. I probably have only taken care of 2 or 3 Addison's patients in my entire life. Cushing's, all the time. Kennedy was supposed to have had this disease, JFK. Was rumored to have this disease. So that means when he got shot, what? There was no chance. There was no. I mean, even if it had been now, and if it hadn't gotten hit in the skull, if he had gotten like a shoulder injury now, he might not have made it. So it was. And think about this. What's really dangerous to people with Addison's disease? Stress. You're the president of the United States. It's not the best. He probably couldn't get elected right now because they would have made such a big deal of the you know what I mean? It would have disqualified him. But it was hidden. People didn't know about it. What's that?
He didn't seem very tan.
Well, he was a little bronzer though. Early years he wasn't. He was real pasty. But then he got tanned as he went on. And then he started taking steroids, so he got puffy.
Okay, yes.
So the nice little puffy cheeks he had there near the end, that was steroids. That wasn't Jackie. Okay. Well, what's the treatment?
Steroids?
Yeah. Give him what he's low on, which is what? Steroids. Not pump you up steroids, but glucocorticoids. All drugs that end in what? What do all steroids end in? Sone. Betamethasone, beclomethasone, dexamethasone, prednisone, mometasone, hydrocortisone, fludrocortisone. So drugs that end in sones are steroids. So you give drugs, these drugs to people in Addison's, right? So Addison's disease, is it under secretion or over secretion?
Under.
Do you have to take something away from them or add something to them?
Add.
And what do you add? A sone. In Addison's, you add a sone. And that tells you whether, doesn't Addisone tell you whether it's hyper or hypo? Sure, because if you're adding, it's what? Hypo, and it tells you what drugs to pick, anything ending in sone. So just remember, Addison's, you add a sone. And that'll help you remember it. Cushing's syndrome. This is over-secretion of the adrenal cortex. Over-secretion. The way I remember this is, if you have a cushy bank account, do you have more or less money? More. If you have a cushy chair, does it have more or less stuffing? More. If you have a cushy tushy, do you have more or less? More, yeah, you got a whole lot more, right? A lot more. So, cushy just sounds like more to me, doesn't it? Cushing's, cushy, over. Addison's, you got to add because it's under. I never forget which one's under and which one's over. Okay, now, the signs and symptoms of Cushing's disease, you have to know this. They will test this, and knowing this list gets you what we call 2 for the money. Which means when you memorize this list, you're actually getting 2 things. Number 1, you're getting the signs and symptoms of Cushing's, and number 2, you're getting all the side effects of steroid medications. So when you memorize this one list, you're getting 2 things. Cushing's signs and symptoms and side effects of steroids. Any drug ending in? Sone. So that's good for a lot of reasons. Now, I am going to have you remember this by drawing a picture of a little man. And I'm serious, I want you to draw this little guy over and over and over again until you draw him perfectly. Because if you can draw him perfectly, guess what? You know the signs and symptoms of, and you know the side effects of any drug ending in sone. So here's what it goes. Now this man is called Cushman. Okay, Cushman. Now, I'm going to draw a head, but don't draw the head real big because you need a really space for a really big body. Okay, so don't take up all your space with the head. Okay, the first thing on the head is you need to draw a moon face. Okay, he's got a moon face. And you say, oh, I can't draw. Okay, well, can you do this? That'll do. Okay. So draw a moon face. Whatever your skill set is, just draw a moon face. Because that's the first symptom, moon face. Puffy moon face. Then, draw a beard on him. What's the fancy term for excess hairiness on the body? Close. Hirsutism. Hirsutism. That means lots of hair. Hirsutism. Okay, next, draw a real big body, and I mean a big one. Put a bump on the front. Oh. And a bump on the back. Put a bump on the front and a bump on the back. Now, what's the bump? Okay, let me ask you this first. What do we call the big round body? Obesity, but a certain type of obesity. Truncal or central obesity, they'll call it. Because see, your arms and legs aren't fat. It's just your body. Your arms and legs are actually really skinny. So it's truncal or central obesity. That's the big body. What's the bump on the front? No. No, the buffalo hump is the bump on the back. Because buffaloes have a bump on their back. So that's the buffalo hump right there. This is the gynecomastia. Gynecomastia. Those are female tight breasts on men. They sort of wear the bro. If you remember Seinfeld. So you have gynecomastia and buffalo hump, as well as the central obesity. Now, I want you to draw a skinny arms and skinny legs. Skinny arms, skinny legs. Because they have atrophy of those muscles. Those muscles waste away. All right, then I want you to fill him full of what? What's that? Water. So he's retaining what? Sodium and water. He's retaining sodium and water. So what's he losing? Out the back. What's he losing? Potassium. He's losing potassium. Okay, put some striae on him. What are striae? S-T-R-I-A-E. Stretch marks. He has these stretch marks on his abdomen, striae. Then, the most important one of all to remember, this is the most important one, put high glucose if you have room. High glucose. Because this causes them to be hyperglycemic. They look like diabetics. So if you're on a steroid and you're diabetic, talk to me. Diabetic, put on a steroid.
A lot of insulin.
What's that?
You need a lot of insulin.
You need more insulin because the steroid is going to increase the blood glucose and you're going to go out of control. What's that?
And you're immunosuppressed.
Yeah. Now I want you to put bruises all over him. Because what does he do real easily? He bruises extremely easily. We're almost done. We only have two things left. The last thing is I want you to make him say something. You know how they have those little cartoon speech balloons? Have him say something, and what he says is, I'm mad. I have an infection. I'm mad. I have an infection. Well, that tells you two things about him. What's the first thing it tells you? He's grouchy. He's irritable. And secondly, he's immunosuppressed. So if you ask me, Mark, what are the signs and symptoms of Cushing's syndrome, or what are the side effects of steroid meds, I would close my eyes. Why? I'd be picturing him and I'd say, okay, moon face, hirsutism, central obesity, gynecomastia, buffalo hump, retaining water and sodium, losing potassium, high glucose, wasting extremities, striae, bruising, irritability, and immunosuppression. And who did I describe? Cushman. I have this vision, and I went down through and chung, 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 chung. Because you're going to see it. One of the famous ways that people ask it is they'll give a person with an acute exacerbation of COPD in which they need Solumedrol, a steroid IV push every 8 hours to reduce the inflammation in the airways. And it's a steroid. And they'll ask what nursing action needs to be taken when they're on this steroid. Accucheck's Q6. Because what do steroids make your sugar do? Go up even if you're not diabetic. And if you are diabetic, look out. Okay, so you got Cushman? I'm serious about drawing him because if you don't draw him and don't learn him, many of you in here are going to say, oh, nuts, when you get onto your test because you're going to wish you had. You're going to wish you had. Okay, now what's the treatment? Well, the question is, do you have too much or too little here? Too much. What's the classic treatment for hypersecretion of a gland? What's the number one treatment for a hypersecretory gland? Cut it out. So adrenalectomy. But what happens if you do a bilateral adrenalectomy, do you think? If you do a bilateral adrenalectomy. What does that mean? Do you have any adrenals left? So what do you have? Addison's. Okay, now think about it. Why did you do a bilateral adrenalectomy? What did you look like that made the doctor do a bilateral adrenalectomy? Looked like Cushman, right? So he did that to prevent that. But once you do that, you can induce what disease? Addison's, for which you give a steroid ending in sone, the side effects of which now make you look like Cushman, which is why you had the surgery. So it's really frustrating. I mean, it takes like a year or two to get them equilibrated back to where they're feeling normal. And that's the problem with endocrine surgery, is the endocrine surgery creates the opposite problem, for which you have to take the hormone, the side effects of which make you look like the thing you had in the first place. So think about, if you're hyperthyroid, high thyroid now, what's the major treatment? Thyroidectomy. And if you do a total thyroidectomy, what do you induce? Hypothyroid, for which you have to take thyroid pills. What are the side effects of thyroid pills? They look like Graves' disease, which is the reason you had the surgery in the first place. You see, any endocrine gland works that way. It's really frustrating to these poor people, and it takes years to get it back to normal. Okay, let's finish up. For today, we have probably 2 things to do and we'll be done. Let's talk about toys on page 33. Kids' toys. Children's toys. This is a lecture about selecting the appropriate play activity or toy given the age of the child, generally speaking. Now, when you select toys or play activities for children, there are usually 3 things to consider. I'm just going to walk over here, I'll keep talking. 3 things to consider. The first one, is it safe? The second one, is it age appropriate? Third one, is it feasible? You have to make sure that the toys you're using are safe, age appropriate, and feasible. Sorry, my back's killing me. I can't stand anymore. First thing, safety. Safety considerations when you're thinking of toys. There are 3 things you have to consider with safety of a toy. The first thing is, number 1, no small toys for children under 4. If you've got a 4-year-old kid or younger, you should not pick a toy that has small parts they could aspirate. If they're over 4, guess what? The small parts are just fine. So 4 is your cutoff age for small pieces, parts to toys. Second thing you consider for safety. Number 2, no metal, M-E-T-A-L, no metal toys if oxygen is in use. If they're getting oxygen. Why? Sparks. Does anybody know a fancy word they might use in place of metal? That means the same thing as metal? Die-cast. D-I-E-C-A-S-T. Die-cast. If they say a die-cast car, they're talking about one of those little metal matchbox thingies. And that's a no-no if oxygen is in use. Third safety consideration, number 3 safety consideration, and this is more vocabulary than anything. Write down, beware of fomites. F-O-M-I-T-E-S. Beware of fomites. Now you guys should be asking me, what in the world is a fomite? A fomite is a non-living object that harbors microorganisms. It has to be non-living, and it harbors microorganisms. By the way, just to see if you know your epidemiology, what do you call a living organism that
Vector.
harbors microorganisms?
Vector.
A vector or a host. But this is a non-living, so it is a fomite. Now, why in the world are we talking about fomites with kids?
Put it in their mouth.
Toys are notorious fomites in a pediatric ward. They stick them in their mouth. The next kid sticks it in their mouth. I mean, it's just really bad. So toys are horrible. Now, which toys make worse fomites than other toys? What toys are the worst fomites? Stuffed animals. What makes the best toy because it's unlikely to be a fomite? Hard plastic. What can you do with hard plastic toys that you cannot do with stuffed animals? You know, bleach them till they're dead. You know what I mean? You can terminally disinfect a hard plastic action figure. Okay? You can't terminally disinfect Tickle Me Elmo. All right? So if you have a child that is immunosuppressed, what would be the best toy for that child?
Hard plastic.
A hard plastic action figure. All right, those are the safety considerations. Feasibility just means could you do it? And it's pretty common sense. For example, can a 13-year-old, is swimming a good activity for a 13-year-old? Is it safe for a 13-year-old? Is it age appropriate for a 13-year-old? Is it feasible for a 13-year-old in a body cast? No. See, so feasibility can come into this too, but that's just going to be common sense. In other words, feasibility means could you actually play it with this child in the situation they're in? Okay, the next one is age appropriateness. This will take up the majority of the lecture because this is what they test mostly. Is they want to know if they give you a kid of a certain age, what toy should you give them? So let's start out with the first year of life, infancy. From 0 to 6 months of age, the best toy is a musical mobile. The best toy is a musical mobile. Because these kids are sensory motors. They are sensory motors. So the best toy is something that stimulates both motor and sensory. That's why the musical mobile is best. However, if the boards does not have musical mobile there, your second best answer is to look for something hard, meaning what? You know, something that can be distant. No, did I say hard?
Yeah.
It needs to be soft right now. But it has to be large. Why large?
They don't choke on
So they don't choke. Why soft? So they don't hurt themselves. What's the problem? Well, what the problem is, what do you do with a 3-month-old who is supposed to have soft toys if that 3-month-old is also immunosuppressed? You see the treatment problem there? Boards won't go there because that's a conflict of two principles. They're just happy you know the principles, period. So don't go there. But you do see the inherent problem in that, don't you? Okay. Now let's talk about the 6 to 9 monthers. The 6 to 9 month olds. These kids are working on a skill called object permanence. Have you heard of object permanence? What does that mean? Yeah, the idea that it's still there even if you cannot see it. For example, if a child does not have object permanence, if I put their favorite toy under a blanket, what will they do? Cry. Because it's what? Gone. Into that, third dimension, that 8th dimension, never to be seen again. If a child has object permanence and you put their favorite toy under a blanket, what will they do? Rip off the blanket and grab the toy. You see, it's very different. Now, at 6 to 9 months of age, your play should be teaching them that. That is the big task they need to learn intellectually. So you should play with them with toys and activities that teach them object permanence. So the best toy is what I call a cover-uncover toy. Cover-uncover toy. Now, I cannot tell you exactly what toy they will use. Okay? But I can tell you what kind of toy you should select. So you should select for a 6 to 9er, you should select a toy where you cover it up and then you uncover it. Then you cover it up and then you uncover it. What is that teaching them? Object permanence. So could you give me some examples of cover-uncover toys? Jack in the Box. Those pop-up pals. Remember? You push the right button, then they pop up, then you push them down, then you pop up, and then you push them down. Those books that have the little windows, and then where are the birdies? Oh, there they are. Where are the birdies? Oh, there they are. Where's the birdies? There they are. And you're covering and uncovering the little picture of the birdies in the nest. That's perfect for this age group. Fantastic. Playing peekaboo. Why? You're there, then you're not. Then you're there, then you're not. That's good. Putting a blanket over your head and then uncovering your head and then putting a blanket over your head. That's really cool. That's good. And then what you do is they start laughing and then you stop doing it and see if they're learning. Because if they're learning, they'll pull the blanket off and laugh. If they don't, they'll go. Actually, do you guys know much about dogs? That's how you test a dog's intelligence. Because one of the highest order cognitive skills a dog can perform is object permanence. And if you throw a blanket over your dog and it just sits there like this, you got a dumb dog. If you throw the blanket over the dog and he goes, then you got a good dog. You got a smart dog. So you'll know how dumb your dog is tonight. Some of you are saying, I do that to my husband and he doesn't take off. All right. Well, what's the second best toy? if a cover, uncover toy does not show up. Something large, but it should be hard, firm. So you can make it of plastic, wood, metal. So how old does a child need to be before they're allowed to play with anything made of wood, metal, and hard plastic? At least 6 months of age. By the way, what is the worst toy in the world for a 6 to 9 month old kid? The absolute worst toy. The musical mobile. What was the best toy for a kid before 6 months? The musical mobile. What's the worst toy for a kid after 6 months? The musical mobile. Why? Because now they pull themselves up, they sit up, and they strangulate. Many, many kids have had strangulations or near strangulations from the musical mobiles that should have been taken out of the nursery months ago. Okay. The next age group are the 9 to 12 monthers, right? And these kids are working on vocalization. They're learning to speak. So what kind of toys are best for these kids? Speaking toys, talking toys, verbal toys. Now, I'm not going to give you a specific one because I don't know what they're going to test. But this is going to be like Woody the Cowboy, Teddy Ruxpin, Tickle Me Elmo, Slap Me Susie. I don't know them, all of them. They're just sort of, all those ones where you got a what? You got a string, and you pull the string, and it says something. That's really cool. See and Say, Barnyard Friends, the cow says moo. Fantastic for this age group. Talking toys. What kind of books? Talking books. Really good for this age group. If we just talked about books alone, what's a good book for a kid under 6 months? Soft booking and go what? Right? What's a good book for a kid 6 to 9er? Picked window books. What's the best book for a 9 to 12er? Speaking books, talking books. All right? The other thing about a 6 to 9er that's down here is purposeful activity with objects. Purposeful activity. In other words, how old does a child have to be before they'll do anything purposeful with a toy? At least 9 months. So let me ask you this. Could a 7-month-old play with 3 wooden blocks? Could they play with 3 wooden blocks? Is wood okay? Because they're over 6 months. They could play with 3 wooden blocks. Could a 7-month-old build a tower of 3 wooden blocks? Why? Why no? Build is a purpose word. And you cannot pick any answers that have purpose words in them until the child is at least how old? 9 months. So here's the deal. Never pick answers with the following words in it if the kid is under 9 months. Never pick an answer with the following words in it if the kid is under 9 months. So here are those words. Build, sort, stack, make, construct. Why? Those are purpose words, and a kid does nothing purposeful before age 9 months. I tell people, a baby's in the womb how long? 9 months, and it's another 9 months after they're out till they do anything purposeful. Prior to that, it's all random. Okay, let's talk about the toddlers, which are the 1 to 3-year-olds. They are, the best toy for them is a push-pull toy. Something that you push, something that you pull. Now, I don't know what it's going to be, but give me some examples of push-pull toys. The lawnmower, the wagon, the buggy, that stupid popcorn poppery thing. What else? Yeah, baby strollers. The little dog with the floppy feet that you drag behind you. So anything that they push, anything that they pull, fantastic for 1 to 3 year olds. Work on the gross motor skills. Work on gross motor, which is running, jumping. I always say, if it takes finger dexterity, no for the toddler. If you're sitting there thinking, now which of these activities could a toddler do? If any of those activities take finger dexterity, do not choose it for the toddler. Toddlers do not have finger dexterity. So could they use colored pencils? No. Scissors? No. Not even blunt scissors they can't use. So anything that requires finger dexterity is no for the toddler. The interesting thing is, people have misnamed finger painting. Finger painting is not finger painting. Finger painting is hand painting. Can toddlers do finger painting? Yes, because it takes your hand, not your... Do you ever see a toddler go... Yeah, with their fingers? No, they go... So it's hand painting, not finger painting, okay? So can they do anything that takes finger dexterity?
No.
No. But they can do finger painting, because finger painting isn't finger painting, it's hand painting. That's where people get confused. Does that make sense? Okay. They're characterized by parallel play. Parallel, which means you play alongside but not with. You play alongside but not with. Okay, let's talk about preschoolers, the next age group, the preschoolers. Work on their fine motor. So what do you pull out now? Things that take
Pencil.
what? Finger dexterity. So you need to, preschool is the finger dexterity. Number 2, work on their balance. So tricycles, tumbling class, dance class, ice skates, those are okay at this age. Don't put your toddler in dance class, gymnastics class, and hockey class. It's not going to work. When they turn preschool, they'll learn in 2 weeks everything they would have learned in 2 years as a toddler. So it's a waste of your money. Yes?
What about swimming lessons?
Swimming is different because that's more gross motor. In some sense, it doesn't really depend on balance. So infants should actually be taken for swim lessons because of safety issues. So an infant should be taught how to swim, at least know how to be used to being in the water, at least, so that it's not a, I would say probably, I don't know what age. Anybody know the age where swimming is?
It starts at 3 months.
0 to 3? I was going to say as soon as you want.
You can get them in.
That's what I
The
thought.
water, it's a parent-teacher class until they're in preschool. And
Yeah.
then once they hit preschool, then they're on
their own.
group class.
But I don't think there's any lower limit. I think, like you said, 0 is what I know. Okay. What else? Okay, they are characterized. Work on balance. They're characterized by cooperative play. Cooperative play, which means what?
Play together.
As opposed to parallel. Parallel plays alongside but not with. Cooperative plays with. So they play with each other in groups. They interact and play together. And lastly, they like to pretend. They are highly imaginative. That their pretend play is big. You know, you be the sheriff, I'll be the saloon keeper, you be the barmaid, I'll be the outlaw, you know, and you all role play. I grew up in Youngstown, Ohio. I always got to be the Pope. Role play. I was the one with the wagon, so I got to be the Pope. Okay, I know you care. Okay, the next age group is the school age. And the school age kids are characterized by the 3 C's. They are creative. In other words, let them make it. Don't you make it and give it to them. In other words, would it be good to give them a coloring book and crayons?
No.
What would be better? Blank paper and colored pencils. Because then they can create their own pictures rather than fill in the blanks, you know? Would you give them plastic cookies, plastic lemonade, and plastic donuts and have them have a tea party? No. Could they have a tea party? Yes, but what would you do with a school age? They make the what? Cookies. They make the lemonade. They make the muffins, and they have you see what I'm saying? That's why Legos is such a good toy for this age group. Why? They're building and making. They're creating. You don't give them trucks and cars, and you give them things that they make into cars and trucks and that kind of thing. That's why Transformers is good, because it makes the creativity and all. Okay. Second C, they are collective. They're always collecting something. Beanie Babies, Pogs, Digimon, Pokemon, Webkins. What was the stupid one this Christmas? Zuzu Pets. Yeah, Zuzu Pets. You know, all that kind of stuff. And don't the toy manufacturers know this? Oh yeah. Remember about 5 years ago, of course I had girls. So 6 years ago, Mattel came out with Barbie and the not 2, not 4, not 6, not 8, not 10, but 12 dancing princesses. Because they knew that all the little girls would want what? All 12, so why would you give Barbie and the 2 dancing princesses? I mean, that's stupid. What a bad marketing plan. You know, go 12, you know, they'll buy them. So, you know, that's toys. They know all this stuff. And last C, they are competitive, which means they like to play games where there's a winner and a loser. Now, they don't like being the loser. I never said that. But I'm saying that if you go over here to the 5th grade, to the nearest elementary school, and you tell them, we're going to play a game, what do they say? Yeah, cool, get out of school, play a game, cool. But if I tell those 5th graders, guess what? Everybody's gonna win. Nobody's gonna lose. We're all gonna get the same prize. What will they say?
Oh,
stupid game. Just give me the dumb prize and don't waste my time. But if I tell them, hey, we're gonna play a game, $400 and a bike for the kid that wins. Oh my goodness, I'll have those kids doing all, I'm tipping cows, you know. They'll be doing everything. So they like competition. Now what about preschool? Make a statement about competition in preschool. No, not unless you want a room full of screaming, crying kids. Who wins in preschool? And what do they get? The same prize. And I'm talking the same prize. Don't go in with orange lollipops and grape lollipops. Go in with one size, one flavor, and if they don't like it, they don't get it. Don't go in with 2. You're going to have a Chernobyl. Forget about it. Adolescents, what's their play? Peer group association. Peer group association. They want to what?
Hang out with their friends.
Hang out with their friends. So do they do much?
Sleep.
Have you ever seen a group of teenagers? I have girls, so I'm suspicious as a father. So I build a rec room on our house so that the pool table and the TV and everything would be at whose house? ours so that all the people would come to our house so I could keep a little. I didn't tell about the closed circuit television in the, no, I didn't. But they would all come over to our house, 20 of them. And guess what they'd do? 20 of them. So I'd go in the room and I'd say, how about if we play polo? Dad, get out here. Well, how about if we watch a movie? Dad. So for 4 hours. And I go in and here's my daughter texting. And I say, Emily, who are you texting? Bethany. Bethany who? Bethany Wales. Emily, Bethany's sitting right over there. Yeah, I know. They're texting each other in the same room with all these boring teachers doing nothing. I know, I'm old, forget it. But they just hang out. Now, what's that got to do with nursing? Here's the deal. If they gave you a question where a gang of teenagers, 5, 6, 7, 8 of them, were hanging out in one teenager's room, what do? Do you let them or not let them?
Let them.
You let them, unless one of 3 conditions is happening. Here are the 3 things that would, well, no, not what you're thinking. Unless one of these 3 things is true, you let them hang out. The first thing is, if anyone is fresh post-op. In other words, if any one of those teenagers, adolescents, is less than 12 hours out of surgery, they shouldn't be hanging out. Okay? Second thing, if anyone is immunosuppressed, they shouldn't be, for obvious reasons, correct? And thirdly, if anyone has a contagious disease. So if you've got 13 kids hanging out in one room, unless somebody is fresh post-op, somebody is contagious, or somebody is immunosuppressed, let them hang out. Get over your control issues. Let them hang out. All right? Let's do the last lecture of the day, laminectomy. Laminectomy. What page? 38. I'm not going to do lab values at this time of day. Your brain will go totally fried. Laminectomy. Lamina are the vertebral spinous processes, and ectomy means removal. So laminectomy. Ectomy means removal, and the lamina are the vertebral spinous processes. Vertebral spinous processes. Now, what are the vertebral spinous processes? Well, let me ask you this. Have you ever felt the bumpy bones on the back of somebody? You're not really feeling the body of the vertebrae. You're feeling those wingy thingies out the back. Those are the lamina. So in a laminectomy, do I remove the round bodies of the vertebrae? No, you'd be an invertebrate if I did. That wouldn't be good. What I'm removing is those wing things out the back. I remove those. So we're just removing the posterior processes of the vertebral bones. Just part of it. Now the question is, why in the world would you do that? What's the reason for a laminectomy? The reason is to relieve nerve root compression. To relieve nerve root compression. Because sometimes when the nerve roots come out of the spinal cord, there's like calcium or herniated discs or inflammatory masses pressing on them, and that causes problems. So we cut away that bone to give the nerve more room to exit. So it relieves the compression on the nerve root. Well then, what are the signs and symptoms of nerve root compression? The 3 P's. Pain, paresthesia, which means what? Numbness and tingling. And paresis, which is muscle weakness. Pain, paresthesia, and paresis. Those are the 3 signs that your nerve roots are being pressed upon, for which we would do a laminectomy to remove those back bony parts so that your nerve roots can come out real nicely and not be pressed on. Now, when you get a laminectomy question, the most important thing to pay attention to is the most important thing that you pay attention to in any neuro question. Does anyone know what the most important thing to pay attention to in any neuro question is? Location. It is location. If you want to get a neuro question correct, pay attention to the location of the problem, because the location will determine the symptoms. The location will determine the prognosis. The location will determine the treatment. Location is everything in neuro. There are 3 locations for laminectomies. They are cervical, thoracic, and lumbar. Cervical, thoracic, and lumbar. Cervical means the neck, thoracic means the upper back, and lumbar means the lower back. Now, in the rest of this page, I'm going to illustrate for you how, when you change the location, you change the answer to the question. So let's talk about it. Is the next one F or E?
E.
E. Letter E. What is the most important pre-op assessment for a cervical laminectomy? What's the most important word in that question?
Cervical.
Cervical. Okay, so the cervical spinal cord innervates 2 things: diaphragm and arms. Diaphragm and arms. That's what your cervical innervates. So, if you are doing a pre-op assessment for a patient going for a cervical laminectomy, what is the most important thing you would check out before surgery? What? Breathing. Why? Cervical innervates the diaphragm. So breathing is number 1. Check out their breathing. How are they breathing? Number 2, if that is not there, if breathing isn't there, the next best answer is the function of their arms and hands. That would be your backup answer. So what's number 1 answer for cervical? Breathing. What's number 2 answer for cervical? Arm and hand function. However, letter F, what did I change in the question?
Correct.
Location. I changed it from cervical to thoracic. And when I changed location, I changed the answer. It is no longer breathing and arms and hands. For thoracic, the most important assessment is the cough and the bowels. Cough mechanism and bowels. Cough and bowels. So what would be the most important thing to assess before a thoracic surgery? How well the patient coughs. Not so much gag, but how they cough. So what I want you to do is this. I want to illustrate how this is. Your thoracic spinal cord innervates your abdominal muscles and your gut muscles. So what I want to do is I want you to do this. I want you to put your hand on your abdomen, on your abdominal muscles. I want you to cover your mouth, and I want you, on my signal, I want you to cough. And when you cough, I want you to feel what happens here underneath your hand. Okay, ready? Cough. How many felt a contraction? Great. Okay, now, I'm going to give all of you a thoracic spinal cord injury. Okay? Okay, you got it. So now you can no longer contract what? Your abdominal muscles. So relax them. Relax them. You're paralyzed. There. You cannot contract those muscles. You're paralyzed. Okay, now, put your hand on your abdomen. They're paralyzed. Cover your mouth. And this time on my signal, I want you to cough. But don't you dare contract these muscles, because you're not allowed to, because you're paralyzed there. Okay, ready? Cough. Wow, some of you actually got a good cough out. Usually that's impossible. Somebody has to be cheating. No, but do you understand? So in order to cough, what do you have to be able to do? Contract these muscles. And if you can't contract these muscles, you cannot cough. You can go, but you can't cough. Can you breathe? You can breathe, but you cannot cough. So what assessments do you have to make for a thoracic? Coughing and bowel sounds, right? All right, but what about G? What did I change in G? The location, and when I change the location, I change the answer. The lumbar innervates the bladder and the legs. Bladder and legs. So what's the most important assessment before lumbar laminectomy? Yeah, when was the last time they voided? Is their bladder distended? Or is it empty? You need to know that before surgery. And then, if that's not there, what's the backup answer? Function of arms and legs. So that's important, knowing that. So cervical is what? Cervical is
Diaphragm.
breathing and arms. Thoracic is coughing and bowel. Lumbar is bladder and legs. Okay, let's turn the page and talk about post-op laminectomy. The number one post-op answer on NCLEX for laminectomy is log roll. If you have a question that says log roll your patient and it has anything to do with spinal cord, including laminectomy, what's your top answer?
Log roll.
Log roll. You always pick log roll if it's there. You cannot go wrong by picking log roll. Now, in addition to knowing that, there are 3 other things you need to know about mobilizing clients after spinal surgery. Number 1, do not dangle these people. Do not dangle them. Now, dangle does not mean to hold them by their ankles out the window. What does dangle mean? Sit on the edge of the bed, which is what we do for everybody. Isn't that the first thing we do for all post-ops? Dangle them. What am I telling you about these people? Don't do that. Go from lying down immediately to what? Walking around. None of this dangle business. Now, can they sit on the edge of the bed long enough to overcome orthostatic hypotension? Sure, but they shouldn't sit there for 10, 15 minutes dangling. Yes?
So will it be specified as like feet flat on ground, sitting on edge of bed?
Sitting on edge of bed with feet flat on ground is not appropriate for a fresh post-op laminectomy. If they say sitting at the side of the bed long enough to overcome orthostatic hypotension, then it's okay for a laminectomy. But if they say sitting with the feet on the ground, sitting with the feet not on the ground, dangling, none of that for a lamb. Sitting is a horrible position for a lamb. Okay, number 2 restriction. Do not sit for longer than 30 minutes. They're not allowed to sit for longer than 30 minutes. So what kind of typical post-op order would you question with a laminectomy? What typical post-op order would you question with a laminectomy? Up in chair for 1 hour, TID. Isn't that real common? Up in chair for 2 hours, TID. Real common. Up in chair for meals is really not bad. Because how long does a meal usually last? About a half hour. So that's not bad. Because they would say up in chair for meals is good because you're only up for a half hour. So they'd say that's okay. Third thing, they may walk, stand, and lie down without restrictions. They may walk, stand, and lie down without restriction. So there's only a restriction on what position? Sitting. All the OSHA studies since 1970s have proven what is the one hospital worker position designation that has the highest incidence of back injuries. What worker in the hospital has the highest risk of back injuries? Not nurses. Not nurse aides. Admitting clerks. Because what do they do all day? Sit. And that's worse than lifting and slugging 200-pounders in the bed. It's worse for you. It's terrible. So sitting is horrid position for your back. Okay, let's talk about post-op complications. What will the post-op complications depend on? Location. So what would be the number one post-op complication after a cervical laminectomy? But breathing is not a complication. It's a good thing.
Shortness of breath. Just.
They won't breathe very well and very deeply after surgery. They will have trouble breathing deeply after surgery. What will develop? Pneumonia. Yes, pneumonia is the number one complication. Why? Because they don't breathe so well. Why? Because it's a cervical, and cervicals don't breathe so well after the surgery. Because that's the location that hits the lungs. Okay, well, what if they change it to a thoracic? The post-op complication after thoracic, what would it be? Well, what won't they do so well? Cough. So what will they get then? Pneumonia. And they'll have an ileus because their bowels won't work. But what's the number one problem after a lumbar laminectomy? Urinary retention, followed by problems with the legs. Do you see where they can trick you? And they could say, a person underwent a lumbar laminectomy 10 hours ago. What's the number one problem? A, airway, B, breathing, C, circulation, D, urinary retention. What would be the answer? Urinary retention. Because they don't have A and B and C problems because it doesn't affect them. You see? So that's not what they would do. Let me ask you this. You are caring for a patient with a lumbar oligodendrogliosarcoma. What is the number one problem? A, airway. B, ileus. C, cardiac arrhythmia. D, urinary retention. What would be the answer? D. Because it's a what? Lumbar. And it doesn't matter what it is. You don't have to even know what this is. This does not determine your answer. What determines your answer? Location does. So all you have to do is, if you know that cervical is breathing and arms, thoracic is cough and bowels, and lumbar is bladder and legs, you got the whole thing. Because all you have to do is look at the location, because the pathology doesn't matter. Could I put a lumbar abscess? And wouldn't it be the same thing? Lumbar surgery, same thing. Lumbar spinal cord injury, same thing. Lumbar ependymoma, same thing. So what determines pathology in neuro? Location, which makes it actually easier. Okay? Okay, next thing. Typically we don't have chest tubes with laminectomies, but the anterior thoracic will have chest tubes. Letter C. Letter C, the anterior thoracic will have chest tubes. What does anterior thoracic mean? Anterior. From the front, through the chest, you go to the spine. Well, if you get to the spine through the front of the thorax, you're going to have a pneumohemothorax and need chest tubes, right? Okay. Number 5, laminectomy with fusion, and the key word here is with fusion. That means they take a bone graft from the iliac crest. So laminectomy with fusion involves taking a bone graft from the iliac crest. Here's what they do with this one. Here's your vertebrae. Here's your vertebrae. Here's your disc. If they take the disc out, you cannot have bone on bone. So they have to take some bone from your hip, bring it over here, put it in between these, and fuse it so that you don't have that grinding. So this is a laminectomy with fusion. Not all laminectomies have fusion. Most laminectomies don't. In most laminectomies, all you're taking off is this wing thing out the back, and you're not messing with the disc. But if you remove the disc, then you got to do a fusion. And you got to get bone from somewhere, and one place we get it is from the patient's own hip. So if you have a laminectomy with fusion, how many incisions will the patient have? 2. One where? Hip, and one on the spine. So turn the page. Of those 2 incisions, which one will have the most pain? The hip will. Believe me, that hurts. Which one has the most bleeding and drainage? The hip. That's where the hemovac will be. That's where the JP will be. Which one has the highest risk for infection? Actually, they're equal. They have a 50-50 chance of infection. And which one has the highest risk for rejection? The spine. So if you look at the 2 incisions post-operatively, which one causes the most problems? Which one causes the most problems? The hip does. So surgeons are wanting to get rid of that hip incision. Why do the surgeons want to get rid of that hip incision? Because it's shorter recovery, a lot better, no problems, cuts the infection rate in half, decreases the drainage by 80%, decreases the pain by 80%. A lot better all the way around. Hospitals love it because they get money for shorter stay, they make more profit. That's why here it says surgeons are using cadaver bone from bone banks. Why? Yeah, because if they're going to cut this disc out, they can take bone from a dead person, put it in between your bones and fuse it, and there's not that second incision. So they use that quite a bit. There is a slight increased risk of rejection, but not that bad because bone is not protein, and protein is what triggers the antigen-antibody response, the immune response. Nowadays, they're even moving away from cadaver bone to guess what? Synthetic bonding substances that we are developing in the lab. But that's not on boards yet. Okay, discharge teaching. Is this important? Oh yeah. Discharge teaching, very, very important. There are 4 temporary restrictions and 3 permanent ones after laminectomies. The first temporary, do not sit for longer than 30 minutes. How long do you think that restriction applies? How many weeks? 6 weeks. If you have to guess how long something should be restricted and you do not know, you should always pick 6 weeks because that will pay off for you. If you know how long to restrict it, then pick that. But if you don't, pick 6 weeks. You'll be surprised at how well that pays off. Number 2, lie flat and log roll for 6 weeks. Now that doesn't mean you have to actually do it for 6 weeks continuously. That just means when you do turn, log roll and do lie flat for that 6-week period of time. Number 2, no driving for 6 weeks. And do not lift more than 5 pounds for 6 weeks. And how heavy is it? What common household object is about 5 pounds? Gallon of milk. I know a lady that had back surgery, laminectomy, when her infant was like 9 months old. And that was disaster. Why? She couldn't pick him up, and what does a 9-month-old always want? Picked up. That kid learned to walk real fast. I mean, that kid was walking at 10 months. I go, whoa! Well, necessity is the mother of invention, So that kid really learned. Permanent restrictions. Laminectomy patients will never be allowed to lift objects by bending at the waist. How should they lift objects? Lift with the knees. Well, everybody should be that way, right? Should anybody do this? You should all do it with your knees. That way you get bilateral knee replacements instead of a laminectomy. Second thing, cervical lambs are not allowed to lift anything over their head. Nothing goes over your head with a cervical lamb for the rest of your life. So can a cervical lamb do this?
Yeah.
This? Yes.
Yeah.
That? No, not even with a feather. So they need step stools in their house. And then no off-trail biking, jerky amusement park rides, or horseback riding for obvious reasons. You know, the percussion stuff. So that's laminectomy. But understand, this lecture on laminectomy can be used to get any spinal cord questions correct. Correct? Isn't that true? Because you're going to pay attention to what? Location. And that's where it's going to pay off. Okay, tomorrow for the last day. And I think, let me see, we covered 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We did 18 already, and we have 1, 2, 8 to go, right? Is it 8 to go? And we did probably 10 today, so we have less to do tomorrow than we did today. So we'll see you tomorrow. And we've not even been together for more than 24 hours. That's amazing. Anyway, I know. And that's why, but this is what the book says. So you have to go with what the book says, and this is book stuff. There is usually ileus and pneumonia.
Oh God, I'm running.
Because coughing and bowels. The thoracic is always about coughing and bowels.
Thank you.
With this, does
Coughing and
the
bowels.
divorce test the Erickson's stages of development?
Yes, and that's
number
in the
2.
blue book, so-
It's in the blue book. So tie this to this.
Tie this to that. Yeah, it's sort of built on it, but not built on it. This is more built on cognitive ability, more Piaget, whereas because Erickson is psychosocial development, toys are a lot more cognitive.
Number B.
Your ability to play a game of toys, more
Ileus
your
and
cognitive
pneumonia,
development
he said
than your
means coughing and
psychological
bowels.
development.
So
Look at
that's
that.
that for the complex. That's here and the blue book.
Yes, that blue book is so essential. I can't stress it enough that that book is learning the stuff that only you can do. I can't learn it for you. You just have to put in the time to learn it. And I know a lot of people just go, but you know, that's the way it goes. Because if you put in the time, it'll pay off. Okay, thank you.
And pneumonia, coughing and bowels, urinary and leg problems, and then pneumonia after cervical, watch for pneumonia. Oh, but anyways, we could always recheck.
Yeah.